met him very early on, and he was our expertise.
Okay. Can we have the
He would
slide?
take us to meetings, to introduce us to industry partners. He would invited us here, I think in 2011, we came and met with the GI committee at MD Anderson, the surgeons, the rad-oncs, introduced us to the whole team. He would take us to meet with us at different meetings, introduce us to everyone he knew. You cannot do this kind of work without professional expertise. And everyone in this room knows Dr. Jobley. He's world renowned in this cancer, but he helped us help you. So,
if you go back in there,
yeah.
so just go to that computer, and switch your info, the computer starts. So listen.
You can see a picture up here of when the Quang lab opened and our board came and took a tour. So many milestones have happened for us at MD Anderson. So grateful. So we have two strategic priorities at the foundation.
I didn't have a choice on the okay, so let me see.
Melinda runs the advocacy program. Our goal is to connect patients and caregivers as early in their diagnosis, and as often as they need. We provide education and support. We facilitate engagement in the community. We empower them to be able to participate in research if they would like to do that. And then we're also trying to equip the community providers with resources and opportunities to collaborate on a wider basis. The first thing they need to do is they need to find the right team. If you are in this room and you are working with MD Anderson and Houston Methodist, you're already working with specialists, but so many of our patients are not. And so we use a objective data source that shows clinicians around the US, they're treating a high level of patients, they're doing multidisciplinary boards, they're publishing research, they have clinical trials available for patients. And patients can go to this map, they can click on their state and they can see who those specialists are. And you can see this year that will go over 11,000 unique visits to this map. Patients are anxious to find specialists who can help them. The second and third themes are that they need the right tests. So they need to have biomarker testing. And why do they need to have biomarker testing? Because about 50% of patients have an option available to them, a targeted treatment, whether it's in a clinical trial or it's something already approved, will be available to them. You won't know that unless you get the biomarker testing. And that's the way that you find the right clinical trial. So most of you know that that clinical trials are part of the treatment pathway for cholangiocarcinoma patients, but you can't always find those clinical trials unless you get the right testing. So there are a lot of QR codes. So get out your phone. So if there's something on one of these slides that you want more information on, you can get the code. But there are so many options coming. There are so many things in the pipeline. Everyone's working hard. Lots of hope there. We have a lot of support groups, virtual support groups, patients, caregivers, bereaved caregivers, Canadian, Spanish, French. When the need arises, we pull together a support group, and that's a great place for you to meet others and get the support that you need. Cholangio Connect, I'm looking for Patty. There she is. This is a program that was started by Patty Maxson. She grew this program very organically into a program that needed to be taken over by a full-time staff member. So thank you, Patty, for your kindness and all the lives that you've touched. You can see that we're just probably going to hit 1,500 matches made between mentors and mentees this year. We have about a 34% increase in asks to be part of the Cholangio Connect program from 2023 to 2024. And you can see that we have many international mentors from Australia to Vietnam. These patients are coming from all over the world. They need to talk with someone who understands what's going on. And I think all of you can relate to that. So thank you, Patty. We are so grateful. We do patient education webinars twice a month on everything, clinical, translational, in every possible way that we can inside and outside the United States. Everywhere that cholangiocarcinoma is being discussed, everywhere decisions are being made, anywhere there's funding available, we're in there speaking on behalf of the patients. These are some of the international organizations that we work with. Some of our friends from the Canadian group are here. We're so happy to have them. There are groups popping up everywhere. There's a new group in India. There's a new group in Spain. There's a new group developing in Korea. All of these we're helping with resources in the best way that we can. And we just feel that the patients are best served within their country by mentors that about the future there. I'm going to talk a little bit about research. This is Dr. Juan Valet's area. He's going to be talking about something different today, so I'm going to talk about that. But these are kind of our four main goals: to facilitate the availability of global basic translational data resources for everyone working on cholangiocarcinoma, to catalyze innovation and progress, to fund high-risk, high-reward research, and to reduce barriers for industry partners who are developing breakthrough drugs and devices. So, since 2015, when we started doing research fellowships, we have funded a little over $3 million in the seed funding that we do for research fellows. We do it all over the world. Wherever the best research, the most innovative research is, that's what we're funding. And here are three of the research fellows from Anderson. We're super proud of them and the work that they're doing. The ICRN, the International Cholangiocarcinoma Research Network, has 372 individual members. 166 institutions are represented in 31 countries. And our goal is collaboration. We want to collaborate together to accelerate the clinical transition of scientific discoveries. Wherever the good science is happening, wherever the good translation is happening, wherever good clinical things are happening, we want to be collaborating in that. And we do that through the International Cholangiocarcinoma Research Network. So if you're in this room and you are a medical professional and you are not a member, there's the QR code for you, Dr. Valet, or you can talk with Dr. Valet, he'd be happy to give you more information. There are a lot of benefits to that. The patient registry, we'll talk quickly about two data resources that we rely heavily on. Citizen is a data partnership for us. They take your medical records, put them all in one digital place. Very convenient for you, very simple. It's about a 5-minute process. They have a table just right out here outside. If you are a patient and you are not enrolled, would you please consider enrolling? It will take just a couple minutes of your time. It will be a very convenient thing to you, but it will also help the researchers within the ICRN, the network. They will have access to that data and will be able to do better research. So we're excited about this. This is called patient-powered research. It's your ability to help with the research, really just by taking 5 minutes of your time. So there are some of the benefits, lots of insights, lots of patient-powered research. Really excited about that. Komodo Health is another one of our data partners, and this is claims data that the ICRN members get access through the foundation. And these are just about 5 of the projects that we're working on. CUP, which is cancer of unknown primary, and a lot of you probably know that patients often get diagnosed with CUP before they get a cholangiocarcinoma diagnosis. Autoimmune disease and cholangiocarcinoma incidence and prevalence in the U.S., precursors to a cholangiocarcinoma diagnosis in Europe. So a lot of good research coming from there. Our annual conference, I know many of you have been, many of you have not been able to go, and that's why we're here. That's why we're here in Houston, because you know the patients can't always get to Salt Lake City where the annual conference is. So next year's conference, here's some statistics from last year's conference. We awarded over $800,000 in research awards. There were 29 different countries represented in both patients and researchers. We had over 1,000 attendees. 43 of the 50 states were represented, 8 Canadian provinces, and there were 55 posters represented. So it's a great opportunity to share your research, great opportunity to collaborate. Just a really great opportunity, and for the patients, it's a great opportunity to come together and learn together and empower yourself so that you can get the information that you need. These are the chairs. We're doing something a little bit unusual, and you can talk more about with Dr. Valet about the consensus conference. It's going to look and feel the same, but it's going to be a little bit different because we're really going to be rallying around what are the global research priorities. What do we need to do all together as a community? What do we need to find so we can move things forward in an accelerated way?
I need
So
this
the objectives are that we're going to align the available research funding and leverage additional funding and collaborate on larger funding opportunities. And to do that, we have to identify together as a community what those research
that's over
priorities
here.
are. It's going to be multidisciplinary teams working on this, and everybody's helping to make these decisions. So we're really excited about this. And you can see some of the work that we do.
On the computer, on the.
So the potential is, right, you could increase in funding over the years, and this compared to the major cancers is like this. We're just hardly getting funding, and so, I mean funding from the NCI, the NIH, for these rare cancers. So we want to make the best use of these funds. We want to know what the research priorities are, and then we want to get everything moving in that direction, get those priorities done, just one after one.
This one?
So again, consensus conference, just a little more information there. We're really excited about that. Also wanted to just announce, if you're not already aware, we're putting together a Houston coaching. We have care teams in Chicago, New England area, Seattle, Tennessee. And these are groups that fall under advocacy, and Claire and Dave are going to talk with you about those at lunchtime if you would like to be involved. It's a great way to get involved. And, or you can send an email to that email that you see right there.
I get to go to the computer that's here.
So our vision is really a brighter future for patients with cholangiocarcinoma, and we're getting there really soon. We'd like to take bigger steps. And so we can't do that unless we all work on this together. And that's happening, and it's happening through meetings like this, where we're all involved. We're all excited, we're inspired by the patients, we're inspired by the science that we see happening, and we're inspired to see how it's working and moving the patients and seeing longer and longer survival, and lots of great things happening. So I want to thank our sponsors, AstraZeneca, Intera, Survey, Daiichi Sankyo, Insight, Jazz, and Taiho. Some of these companies have been with us for a long time, and they are working hard, and they love coming to the conference, they love meeting the patients, makes their work personal, and we're so grateful for their support, because
So she's in,
without their help.
She's in.
That's my contact information.
I don't know, she logged into it.
At any time, I'll talk with you. So grateful to be here with you. If I haven't met you, please come and introduce yourself to me. I'd love to meet you. And thank you again, and thank you so much, MDX and Houston Methodist. We are so grateful to be here.
So this switcher should be able to switch.
All right, very good. So we're going to start with our first AM session today, looking at the treatment landscape for advanced and metastatic biliary tract cancer. I'd like to invite our moderators, Dr. Ian Fu and Dr. Sonia Lee, to come up to the front and to introduce us to the speakers for this session. Both of them are GI medical oncologists here at MD Anderson, working in the space of biliary tract cancers, and doing a tremendous job. So thank you very much, Tom.
Number 4. Oh, yeah, hold on.
Thank you so much for your invitation. My name is Sun Young Lee. I'm one of the GI medical oncologists working at MD Anderson. So I'm going to introduce Dr. Rahul Elruri.
I gotta do audio.
She's a respected faculty member of the Department of GI Medical Oncology at MD Anderson Cancer Center.
Okay.
So her
Thank you.
academic journey is distinguished by her graduation with honors and distinction in research from East Western University School of Medicine residency at Duke, followed by medical oncology fellowship at MD Anderson. And she's our respected faculty member specializing in colorectal cancer and biliary tract cancer. And she's going to discuss an update in medication treatment in biliary tract cancer. Thank you.
Thank you so much, Sun Yang. Thank you to the organizers, both here in Houston as well as the foundation. I mean, this is incredible. Our first ever Houston Symposium, and fully kind of, exceeded the registration. And so we're really excited to kind of present the talks that are coming ahead. And I'm excited to kick off the talks today. I have 12 minutes, so I'm going to try and keep us on track today. So I'll set myself a timer. So I'll be discussing updates in systemic therapy and some lessons that we've learned from our clinical trials. So just starting off with, how do we define cholangiocarcinoma? And many of you in the room are probably well aware, but I like to think of it like a tree with intrahepatic cholangiocarcinoma really being within the branches of the tree, the small branches, and the tree being the liver. And perihilar cholangiocarcinoma we're very excited as a group to finally have some additional options for patients. But the thing we learned is that more is not necessarily better, and that clinical trials are important, particularly randomized clinical trials against standard of care. So these are several trials that did not meet their endpoints for improving outcomes. And a lot of them were triplet chemotherapies, adding additional agents to the standard of care versus standard of care alone, and showed that they did not necessarily benefit patients.
I can't get that.
And so it really highlights the importance of us creating clinical trials that are, compared against our standard of care, and that these large clinical trials worldwide are going to ultimately be our path to creating additional options for patients.
Will you come see what they need?
What do they
The
need?
second lesson is that we really need to find a way to reduce delays in diagnosis and
They
treatment.
can't hear the sound right now.
So this was a survey done of about 700 patients through the Cholangiocarcinoma Foundation, and most of them said that it took approximately 22 months, so almost 2 years, from when they first noticed some sort of symptoms to ultimately their diagnosis. In fact, a third of patients said they were misdiagnosed initially. And a lot of this has to do with nonspecific symptoms like fatigue, abdominal pain, things that may not necessarily lead to the diagnostic testing needed to diagnose cholangiocarcinoma. In addition, there's a lot of delays in diagnosis because of mammograms or colonoscopies or EGDs or other imaging and interventional modalities that are used in patients who otherwise do have cholangiocarcinoma. And finally, tissue confirmation tends to be an issue, particularly in those patients with the perihilar or the tumors
in between the branches as well as the trunk. And as a result of this, only about a third of patients present with surgically resectable disease, meaning patients that can be operated on, which, as we know, as things stand right now, the only cure that we have for cholangiocarcinoma. And what we also know, half of patients go on to receive second-line therapy, and even less go on to receive third-line. And so this really is an area where we need additional options for patients. And this was similar findings found in TOPAZ-1 as well. About 42% of the patients went on to receive any subsequent anti-cancer therapy. And at the time of TOPAZ-1, only about 3.5% of patients received targeted therapy. But that has changed quite a bit now. And as Stacy pointed out this morning, a lot of patients we now know
showed in the previous slide. And so the most important thing is biomarker testing, but also trying to get this testing done in a timely manner. So there's two ways that biomarker testing can be done. One is from tissue, and one is also from the blood. And what we've found is that sometimes tissue testing can take up to 4 to 6 weeks to come back. But blood-based testing now can come back in several days to up to a week as well. And so getting both of these tests is really important so that we can identify patients who have specific mutations that may allow them to be on a specific clinical trial or a targeted therapy. But what we know is a lot of patients with cholangiocarcinoma do have fusion as well as rearrangements, which are not generally, these liquid biopsies or blood-based tests are generally not as effective for finding these types of mutations.
Oh,
But the main thing is we need clinical trials for the other half of patients who do not have actionable mutations. And how do we find trials for these patients? We need to better understand both the disease as well as understand what are some ways that we can predict response to treatment amongst patients. And so we have some data within TOPAZ-1 showing that patients with BRCA1, BRCA2 mutations tended to respond better and longer to the therapy with immunotherapy. However, we still don't know exactly who are the patients that are benefiting from the addition of immunotherapy to the gemcitabine and cisplatin. And what was also found in TOPAZ-1 was that the median time to response, meaning the time that we saw either shrinkage of a disease or response in the tumors themselves, was 1.6 months. So that's usually around the time of the first scan for patients. And so we really need to figure out who exactly are the patients that are responding at this time frame versus the other half, and try to see what can we do to try and improve outcomes for all of our patients. And a big part of this is really understanding mechanisms of resistance. So we know in cholangiocarcinoma, the cancer does figure out a way to grow despite the chemotherapies and targeted therapies that we currently have available. But now we have a lot of awesome technology, a lot of amazing science and scientists working on this. So the tumor microenvironment is now, we can look at through really fancy technology, really expensive cameras, can actually look at a cell at a single cell level and actually look at all of the cells within that area, the white blood cells, the blood vessels, the tissue, and actually see what is going on in patients both before treatment as well as on treatment. We're learning from the gut microbiome. What are the bacteria in patients' blood that are potentially improving or not responding to the treatments that we have?
Okay.
And finally, we're
Perfect.
looking at
Thank you.
circulating tumor moieties is how I describe it. So either circulating tumor DNA, exosomes, there's such a wide wealth of knowledge that we're still learning about this. And so a lot of patients who are on trials have a lot of research, blood samples, as well as biopsies. A lot of that work is actually going into understanding the disease better, both at the bench as well as clinically, and hopefully will result in more effective trials in the future. The fourth lesson is that we really need to prioritize quality of life. So in the same survey that the cholangiocarcinoma conducted, the second most important thing that patients said regarding their treatment was quality of life. But when we look at these trials, almost 100% of patients have some sort of side effect, with 75% having what we call severe side effects, so grade 3 or 4 side effects, and similarly seen in both of the immunotherapy and chemotherapy trials. And this is a list of the side effects that were listed in the TOPAZ-1 trial. But what I wanted to point out is a lot of these, and more than what I've circled here, can be managed with appropriate other medications and supportive care. And what we know is that palliative or supportive care has been shown not only to improve quality of life for patients, but also overall satisfaction in their care. But we use very little palliative support across the country. In a recent study, only about 15 to 17% of patients had access to appropriate palliative care. And so this remains an area both in our trials in terms of quality of life metrics that we can manage, as well as just in our clinical practice to really emphasize. And then finally, we need our trials to really represent all of you all, the patients that are being treated with these therapies. So when we look at both TOPAZ-1 as well as Keynote 966, only about 7% of the participants were from the United States. And while biliary tract cancers are more, have a higher incidence in Asia, this is still very low, with our racial minorities having even lesser representation in these trials. And according to recent research, only about 1 in 15 oncology patients is able to actually participate in a clinical cancer trial. So what can we do and why is that? It's because most of our patients, 85%, are actually being treated out in a community center, so not at an academic center like Methodist or MD Anderson. And so we as researchers, as clinical investigators, need to find a way to really get the trials out to our community. And so ways to potentially do that and that are being evaluated are regarding financial support, mobile phlebotomy, so being able to get your labs potentially drawn at home, as well as digital health. We've learned from COVID that we can do telemedicine and we can do it pretty well. And so incorporating these is what really is going to lead to high quality clinical trials that are closer to patients in their homes. And the final lesson is that cholangiocarcinoma truly does require a team-based approach. These are all of the different people that are probably involved in most patients' care, whether you see them in clinic or behind the scenes. And I'm really excited today because we have a lot of these people giving talks, almost there, about how we can improve outcomes for our patients. And most importantly is you all, the patients, families, and caregivers. Without you, none of this work would really have even been done. I think Stacy has really pointed out the work of the foundation in advocating for patients, in having enrollment in clinical trials and really being able to lead the effort so that we can improve outcomes in the future. Thank you all so much.
Thank you so much, Valerie. So next speaker is Dr. Huang Valley. So it is my honor to introduce Dr. Huang Valley, a luminary in the field of medical oncology and Chief Medical Officer of the Cholangiocarcinoma Foundation. Dr. Valley's seminal contributions have profoundly introduced the management of biliary tract cancers. So notably, he was the PI of the pivotal ABC-02 trial, which established a superiority of combined gemcitabine and cisplatin over gemcitabine monotherapy in advanced biliary tract cancer, setting a new standard of care. So he's going to discuss molecular profiling and personalized medicine in biliary tract cancer. So once again, it's my honor to introduce Dr. Valley. Thank you.
Thank you, Dr. Lee. Thank you for everybody for the invitation. Just want to get my slides up, please.
Yeah, of course.
So you heard from Dr. Alluri the importance of biomarker testing. So I'm just taking these thoughts one step further. My task is to bring you up to speed with molecular profiling and personalized medicine, but then answer the question, are we there yet? Sounds like somebody in the back of a car on a long trip. So just quickly focus on what we mean by precision medicine. I want you to just imagine this is a whole group of patients with any condition. At the moment, for some conditions, everybody gets treated exactly the same. What we mean by molecular profiling or biomarker testing is that we take samples from the patient. It can sometimes be a blood sample, it can be a tissue, a biopsy, and we call that a biomarker. And you'll hear this term biomarker repeatedly. So very often we think about a biomarker that will just tell us what's the right treatment. But in fact, we use biomarkers for lots of other different things. We can use it for diagnosis, and we have some tumor markers, for example, like PSA for prostate cancer, which is used for diagnosis if it's elevated enough. There are biomarkers that will inform clinicians about the prognosis, who will do well or who will do badly and maybe needs a different treatment. We can also track biomarkers as patients are having treatment. So as a biomarker is high, it tells us that the cancer is there or is relapsed. As the biomarkers fall, a patient is responding to treatment. So we can use it to track progress, and we call that a pharmacodynamic biomarker. We can also use biomarkers to predict who will get more side effects. One of our common drugs, 5-FU, we use a biomarker to predict who will get very severe side effects from 5-FU, and then we look for alternatives. But I guess what's brought this to this session today is a predictive biomarker to tell us whether we can identify a matched treatment. And the idea is that we then move from this position where everybody's the same to then be able to identify which patients are more likely to benefit from a particular treatment. You also heard from Stacey's presentation that we think about cholangiocarcinoma based on their anatomical site that we have for very many years. So we also know that within each of these anatomical sites, so here this is intrahepatic, meaning starting inside the liver. These are the distal cholangiocarcinomas and the perihilar cholangiocarcinomas in green, and then gallbladder cancer, which is a little bit outside of today's remit. But what you can see is that the abnormalities that we can identify within these are slightly different. That's telling us that the biology of these cancers is also different. And what we need to do is to fine-tune what we do to match the biology of the disease that we're treating. And the reason it's important to do the biomarker testing is to identify some of these alterations that you can see,
Of course, this is the inside
because for many of these, we have these treatments. And this list of treatments for the individual molecular alterations is expanding year on year, thanks to the research that you've heard about by patients taking part in clinical trials and giving access to their samples to be tested. So how does this all work? I really love this image that I found some time ago. So I want you to just think of the milkman as giving the signal by stepping on the doorstep. That then sets up a cascade of events. The eggs get dropped into the boiling water, the bacon gets sliced, the bath gets run, the householder gets woken up as other people in the house also. But it all gets triggered by that one signal from the outside of the house. And this is pretty much what we're doing in cellular pathways. So you have the signals, the doorstep, this is then the inside of the cell, and you have a cascade of signals that go through to tell the cell to divide, to grow and multiply.
The microphones instead of, like, it seems
And
like taking up audio.
as clinicians, we have moved away from just focusing on anatomical subgroups. They remain important because if you're doing surgery, if you're doing a local treatment, the anatomy is key. But particularly as medical oncologists, we're thinking of these subgroups that are emerging. And this was the first image that we did in 2020. And the size of each of these circles represents how frequent these alterations are. But you can see that even in a relatively short window of 3 years, we have more targets identified. We have more
additional testing, whether it's immunohistochemistry, next generation sequencing, to be able to identify some of these markers that we're talking about. You've also heard that it can be done as a blood test, sometimes called a liquid biopsy, and the accessibility, of course, of a liquid biopsy is much easier than trying to go back and have another biopsy of the tumor. It's a very invasive procedure, but the information that you get is different. So as clinicians, we have to be mindful to make sure that we understand the limitations of the information that we're getting between the two different types. Something that's a little bit more investigation at the moment is taking bile. Not every patient needs to have an endoscopic procedure. Where that is happening, sampling of the bile can sometimes give us information. Currently, this is not ready yet for being able to make a cast iron diagnosis, but it is something that's being investigated further. So then the question is, when should this be done? I think in general, we feel that the earlier the better, because it allows you to have a view of the treatment options at some point along the pathway. In general, we're focusing on patients who, again, are not having a surgery for early stage disease, and we then undertake molecular profiling as part of the workup during first-line treatment, which is currently chemotherapy with immunotherapy if patients are eligible. And the idea is that you then have lined up a very clear map of which alterations are present, which treatments can then be given after that first-line treatment. As Dr. Andori mentioned, we do need to find some more treatments for patients who don't have any alterations, and that is an active area of research. This is data that comes from a clinic in Barcelona, and if you've not seen these curves before, because you may see quite a few today, let me just quickly walk you through how to read these graphs. So you really start here at either 1 or 100%. So here is where you have all patients. And as time goes by, so you've got time along the bottom, you can see this is an overall survival curve. So it means that every time there's a little step down, it means unfortunately that another patient has died. So what you want to do is to have curves that are up at the top end, and you want to avoid being down at the lower end. So just to quickly orientate you. And what this study was able to show is that if patients had a good target and received a good drug, those patients had the best survival. But even having a good target, but you weren't able to receive a good drug, that also is prognostically better. Patients did better than patients who had no target. Now that list of targets is always changing, so we're refining what we understand.
One of the challenges that we have is the emergence of resistance. This is a cartoon which is really focusing on immunotherapy, but it really talks to resistance in all settings. So in panel A, some patients will have a cancer that is resistant to that treatment. So it doesn't matter what you do in terms of that specific treatment, the cancer carries on growing. In panel B, you'll see that some patients have a cancer that responds very well to a treatment, but then if the cancer comes back, it's resistant. Or you can be in a position where you have this mixture of sensitive and resistant cells. That initial treatment picks off the sensitive cells, but then allows a growth advantage to some of the resistant cells that then cause a problem later on. And this is another similar scenario where you've got the emergence of new resistance after a particular treatment. So why is that important? Well, let me show you a real example that was published a few years ago from a patient having an FGFR inhibitor. This is a CT scan before the patient received treatment. This is at the time of best response, so the tumor had shrunk by 50% from starting. And then this is a scan done at the time that the cancer was then getting worse. What you can see is that a tumor biopsy at the beginning showed this particular alteration called an FGFR2 fusion. When the cancer got worse, that fusion was still there, but new mutations had then developed. And you can see those highlighted in green and red here. These are new mutations that they saw in the tumor biopsy. And this is the way that the cancer was developing resistance to that particular therapy. And what this study was also able to show is that in the bloodstream at baseline, there were no mutations present. And then the mutations that had developed in the tumor were also visible in the blood, as well as some additional mutations. So what this is telling us is that it's important not just to test at the beginning, but retest later on when treatment, particularly when the cancer is getting worse, to see have any new mutations developed, and what does that mean in terms of any treatment options. This is just another example, now focusing on IDH instead of FGFR. This, again, is a CT scan before a patient started treatment, and then when the cancer was getting worse. And you can see here that the initial mutation, IDH1, was well controlled with the treatment. And when the cancer started getting worse, a new mutation has come called IDH2. And this is another enzyme in the same pathway. So what's happened is that within the cells, IDH1 has switched to IDH2 in order for the cell to continue doing its function, and that has emerged as a mechanism of resistance. And a lot of oncologists are working on trying to understand why some patients respond very well, what is the switch that then causes resistance when the cancer gets worse. And this is a little bit of a detailed, complex slide, and apologies for that, but it's just really for me to simplify how I think about resistance. I break it down into three. It's either primary resistance, which means that the cancer gets worse right through the treatment. You have no signs of any response. And if you get an acquired resistance, is that within the pathway that you were targeting, or is it a resistance mechanism outside of the pathway? Because all of those may have implications on how we deal with therapy.
Is this a mechanism to send it out to a remote audience?
But we only know this if we retest. And I think this just again highlights the importance of retesting. So if you have that conversation with your clinician about the need for retesting, then often this is the reason behind that. Why don't we just always do liquid biopsy? It'll be much easier. You can retest and retest as you go along. Of course, it is a resource that is expensive, so we need to acknowledge that. But we also need to be mindful of what the limitations are. This was a study in Germany of 24 patients with cholangiocarcinoma, and they were specifically looking what is the overlap between the alterations in the tumor and circulating tumor DNA. And it was pretty good, 67%, but you can see that you miss some alterations that are seen in the tumor or the blood, so it's not 100%, and that's the key take-home message. It also varies by the mutation that you're looking for. So with IDH1 mutations, you can see here the overlap is pretty good. For FGFR fusions, in this particular study, they saw all the alterations from tissue in ctDNA. But if you're looking at FGFR mutations, the concordance wasn't very good. So again, as clinicians, we need to understand what are the limitations of what we're looking for when interpreting these results. So with that, I'm going to wrap with my take-home messages. The cornerstones of treatment, surgery, radiotherapy, chemotherapy, they remain as key instruments that we have in tackling this disease. Immunotherapy is now here to stay on the basis of the TOPAZ-1 and the Keynote 966 study. Our understanding of the biology and what makes the cancer tick is improving. Biomarker testing, I hope I've persuaded you, is important to help identify either a treatment or access to clinical trials. And it's so great to see that this list of targets continues to grow year on year. And we acknowledge the hard work from pharmaceutical companies who are also working with scientists and investigators to try and target these specific alterations. It is important to have adequate tissue biopsy, and I've not shown you the data, but one of the studies showed that in 25%, so 1/4 of cases, the tissue was just not of a good enough quality to be able to run the tests. And so when I was working in tumor board, it was very much the message I was getting to our diagnostic team is, if you're going to take one biopsy, take two, so that you've then got enough to do the biomarker testing when it's required. I'm mindful I haven't answered the question, which was molecular profiling and personal medicine. Are we there yet? Difficult to know where there is. But I think I've hopefully been able to show you that we are unlocking precision. We have more targets, more treatments, but still a path to walk. Thank you very much.
Hello, my name is Ian Hu. I'm an assistant professor in GI medical oncology. It's my pleasure to introduce our next speaker, Dr. Tan. Dr. Tan is a medical oncologist in the Phase 1 Clinical Trials Department here at MD Anderson Cancer Center. He has a dedicated focus on translating next-generation sequencing and multi-omic profiling into clinical practice. He's been previously awarded several ASCO Merit Awards in research work related to genomic profiling of cholangiocarcinoma. He was also awarded the Cholangiocarcinoma Foundation Research Fellowship Award in 2023 to work on MTAP loss in cholangiocarcinoma. He recently joined the faculty as assistant professor in the Phase 1 department here after completing his medical oncology fellowship this past year. It's my pleasure again to introduce Dr. Tan.
Thank you for the kind introduction.
Good morning, everybody. Also, in the interest of time, I'm just going to start the timer really quickly. So we're going to be talking about phase 1 clinical trials really quickly, and this is an area of great depth. So we'll cover a couple of topics in these short couple of minutes, but I think we'll start with really just what are the phases of clinical trials, because I think this is really key to this discussion. Clinical trials range from phase 1 all the way up to phase 3. My department and my clinical practice really focuses on phase 1 clinical trials. So these trials are really differentiated by what the major outcome they're looking for is. Phase 1 clinical trials, very frequently, we're trying to find an adequate dose, a so-called recommended phase 2 dose, and we're also trying to find the safety and tolerability of a drug. What this means is that very frequently, some of the drugs floating around my department are going to be quote-unquote first in human drugs. So these are drugs that have not been put into patients before. There's also going to be clinical trials that are combinations of new, plus or minus proven or FDA-approved drugs, and you're going to have dosages that vary across cohorts. Phase 2 clinical trials are really designed to look at efficacy. These are trials that are targeting FDA approval. They're usually looking for progression-free survival or some other kind of surrogate endpoint, and they may or may not have a control group. Phase 3 clinical trials really aiming to establish a new standard of care, and they're targeting full FDA approval. They are randomized and blinded, and they're looking for overall survival benefit. So phase 1 clinical trials, these are small trials, and I think that is one thing that is important to discuss and understand, because this can be a source of frustration sometimes for both clinicians as well as patients. So these are small trials with small cohorts. Traditionally, you're enrolling 3 patients at a time. You treat them, and you wait a period of time to look for any really severe side effects that you may not have known about or predicted. So what this really means for you as a patient is that a trial may be open. You may find it listed on ct.gov or what have you, but ultimately you may come to me or one of my other partners, or perhaps a physician also in the GI medical oncology group, and you'll be told, hey, you have to waitlist for a quote-unquote slot. What that really means is that we're waiting for enrollment into another cohort, perhaps another dose or what have you, and that you may have to wait a period of time before you can actually start treatment on this clinical trial. The dosing can also be variable. Phase 1 trials are very dynamic. They open, they close, they change. And so it really can be difficult to predict ahead of time before you come see a phase 1 physician what clinical trial options are really going to be there for you. That being said, though, one of the benefits of phase 1 clinical trials is that there's no control arm. If you come to my clinic and I put you on a clinical trial, one of the few promises I can make is that you will get study drugs. That is not going to be a concern. There's also really going to be very strict inclusion and exclusion criteria. As I said, phase 1 clinical trials are really looking for toxicity primarily, and we're trying to eke efficacy out of early phase clinical trials. I think a very common patient profile that I see is, patients come in, they tell me, hey, I am a normal person. I work, I do all my normal things, but all the doctors are just telling me I have this terrible cancer. When should you come and see your department? Probably any time. After first-line systemic therapy is going to be a reasonable time. Perhaps after second-line systemic therapy too is also a good time. And one thing to also keep in mind is that phase 1 clinical trials are not for everybody. They require commitment. You have to be able to travel, you have to be able to come here. And some clinical trials may or may not include reimbursement for travel. But that being said, I kind of hit you with probably some of the more negative aspects of phase 1 trials. I think we'll talk a little bit about why should you participate in phase 1 clinical trials. And like everything in medical practice, it really comes down to risk versus benefit. What are the risks I'm taking, and what is the potential benefit that I'm going to get in participating in phase 1 trial? There's probably 2 extreme viewpoints. I would argue that both of these are wrong, and that the truth of the matter lies somewhere in between. The extreme negative is that some patients say, hey, I'm not a guinea pig. I don't want to be the first person you test this drug in. You can't tell me this drug is going to shrink my cancer. And my time is precious, and I have to waste some of that time traveling, being poked and prodded as part of the phase 1 clinical trial. There's also an extreme positive view where some patients come in and they tell me, hey, I just want the latest, greatest, fresh out of the lab, whatever new tech is exciting. I just want early access to something for anybody else. And I don't want to do chemotherapy. It's too tough. The side effects are too much. I just don't like the concept of having an infusion of what is essentially a carefully calibrated toxin into my body. But we'll talk a little bit about, why I would say things are probably more in the middle. So this is data from a large meta-analysis looking at what is the efficacy. of second-line systemic therapy after gemcitabine and cisplatin. This is older data. This does not include, of course, our modern chemoimmunotherapy regimens, which is going to be gemcitabine, cisplatin, plus pembrolizumab or durvalumab. We can really see across very many different studies. You can see on the bottom right over there what's something called response rate. So in clinical trials, we tend to think of response rate as a tumor actually shrinking for patient understanding. It has to shrink a certain degree before we say, hey, this tumor is responding. But when you look at these meta-analyses, what you're really looking at is that your probability of FOLFOX working after first-line systemic therapy is going to be anywhere from 5 to 25%, depending on what study you look at. This does not include, of course, patients that have what we call clinical benefit rate. These are patients that have stable disease, which is, of course, the doctor tells you, hey, your tumor is neither shrinking nor growing. We keep going. But of course, 5 to 25% shrinkage rate is not really what anybody is looking for or hoping for. This is data from the phase 1 study of zanidatamab. This was a trial that had a lot of enrollment here. The lead PI was my chair, Dr. Fundermerit Bernstam. You can really see that in this phase 1 study, there were 21 biliary tract cancer patients, and the confirmed objective response rate was 38%. Of course, with a small n, your confidence intervals are going to be very large. But you can really see that, hey, this has a great potential to be better than FOLFOX, quite frankly, if you have HER2 positivity on IHC. But of course, then your next question is like, wow, zanidatamab is great. This is a fantastic drug. What is my probability of getting into some sort of clinical trial that is going to beat systemic therapy? Beat the standard of care, and is going to change how we practice oncology. This is also a statistical modeling. It's actually very difficult to get concrete numbers on exactly what the probability of different drugs progressing are. You can see that looking at large 186,000 trials, this statistical paper said that phase 1 to phase 2 trials, your probability is around 60%, which is decent. What that means is that if you come in, you join a phase 1 clinical trial, there's around a 2/3 chance that this drug is actually going to advance into phase 2. The drop-off continues, though, from phase 2 to phase 3, and then phase 3 to FDA approval. It's a 1/3 percentage each time. So unfortunately, though, when you're looking at the drug development pipeline from start to finish, a small amount of drugs are going to have the full FDA approval. So the key really is trying to find the right phase 1 clinical trial to participate in. And that's where we're going to move into the really solid phase 1 portion of this talk. And I'll go over kind of these large buckets of drugs that when you walk into phase 1, the doctor is going to be, hey, these are our general classes of drugs. Is there anything that is going to be of particular interest to you? Well, actually, I think one of the things that has already been brought up is really the importance of finding an adequate target. That target could be at the genomic level. So a lot of the targeted therapies right now that are FDA approved for FGFR fusion, for example, for IDH1, what have you, those are based off of genomic testing. You have some sort of mutation that is found in your DNA level at the tumor, and you target it with something. A newer class of drugs that has FDA approvals, but is still trying to break its way into cholangiocarcinoma is going to be antibody drug conjugates. These are therapies that look for a target on the surface of your tumor. One of the major drawbacks is that targets on the surface of your tumor cannot be tested in a high throughput manner. You have to meticulously go after one target at a time. And that also takes time. There's not a really great high throughput way to test this. But the advantage is that you have a marker on the surface of your tumor and you go after it, and that can be highly efficacious. There's novel immunotherapy. That is very frequently an area that we put a lot of patients into where we cannot find some sort of adequate targeted therapy or antibody drug conjugate type of therapy, just because the markers for response are probably more related to your fundamental immune system and tumor microenvironment than anything else. So, and probably a newer area too is also going to be intratumoral injections. This is having somewhat of a revival in the last year and a half or so. These are procedural based trials. So that appeals to you, the idea of, hey, I want to inject my tumor, I want to intervene directly in your tumor. These may be trials that you would find particularly interested. When it comes to target therapy and what's in the pipeline, these are targets that there are ongoing phase 1 and some are very quickly entering phase 2 clinical trials for. MTAP loss is an area near and dear to me, but that is an area that is showing great promise in a great variety of tumors, cholangiocarcinoma included. A lot of the phase 1 trials now are starting to focus on combination therapy, so not just targeting MTAP loss, but taking the fundamental drug and then combining it with an additional therapy to augment the potential response. There has been small headway in targeting TP53. This is a gene that is mutated in a large amount of cancers and is really one of those quote-unquote undruggable targets that scientists and physicians have been wanting to go after a great amount of time. There's small progress. R175H and Y220C are two mutations where we're starting to see phase 1 trials that are targeting going after these specific mutations. KRAS mutations, when you look at the landscape of what is exciting in GI cancers, probably it's this ability to potentially target KRAS mutations. There's great headway in targeting these mutations. These are, of course, have a decent percentage likelihood of being found in cholangiocarcinoma. SMARCA4 is something along kind of the larger genomic stability epigenetic change routes. Some of those are entering phase 1 trials really within the last 2 months. And then there's YAP-TAZ-T pathway. There's a group of genes that's involved in this pathway. These drugs are probably, I want to say anywhere from 3 to 4 companies that have phase 1 trials in this area already, and I'm actively enrolling patients into some of these trials. We'll move forward now to talking about antibody drug conjugates. So antibody drug conjugates, the basic idea is that instead of a naked molecule, so a chemotherapy that you're just infused into, you have some sort of antibody. Antibodies bind to a target, a surface target, and you conjugate it with something. So hence the name antibody drug conjugates. And one of the easiest ways to conceptually understand these is that you can think of these as second generation chemotherapies right now. So when the drug conjugate is a chemotherapy payload, which a lot of the FDA approved drugs are at this point in time, is very easy to understand. You have an antibody that binds to a surface target and it brings along some sort of chemotherapy payload. But there are actually very many different kinds of drug conjugates out there. All of these are really solidly in the phase 1 realm, though. There are antibody drug conjugates that are bringing some sort of immune modulator, some sort of degrader, and so on and so forth. So for the antibody targets, what are kind of in the phase 1 realm right now? These are all trials that are actively being opened and are actively in phase 1 right now. There's B7H3 or 4, CEACAM5, as well as CEACAM6. There's CDH6, there's Claudin-6, and there's MUC1. These are all surface targets. And then, of course, you can see on the right, there are targets with FDA approvals for antibody drug conjugates where the payload or the drug conjugate is a chemotherapy payload. HER2 is linked with trastuzumab deruxtecan. TROP2 is with sacituzumab govitecan, and Nectin-4 is with enfortumab vedotin. The point being that these are a class of drugs that have led to FDA approvals and has shown a lot of great promise. The trick, of course, is really seeing how we can apply them to cholangiocarcinoma. There are, of course, also novel immunotherapies. For cell therapies, there's 2 major areas. There's CAR T therapies as well as T cell therapies. These remain very niche, very complicated trials. How well they work in cholangiocarcinoma, I think, in solid tumors really remains to be seen. But this is also a very promising area of therapies in that you have a high upfront cost and that you're admitted, you're treated, you're infused, but then you might be off of therapy for a couple of months at a time. There's novel checkpoint blockade as compared to our FDA-approved checkpoint blockade, such as durvalumab as well as pembrolizumab. There are some early efforts in vaccinations. Again, in the metastatic setting, it's a little bit difficult to conceptualize where those are going to fit. And there's also bispecific immune engagers. These are newer classes of therapy. I throw out ivonescimab out there because that's a PD-1 VEGF that has shown great promise in non-small cell lung cancer. And that is a drug that our department is working on opening combination trials and expansion trials in. And there's also these other complicated PD-1 interleukin conjugates that are showing a lot of efficacy in different tumor types. I would end here just with intratumoral injections. The basic idea is that you have a large tumor in your liver. I want to inject that with some sort of irritant is the basic idea. A lot of these trials right now are oncolytic viruses. The idea is that you inject something directly into the tumor that causes a localized infection almost that lyses cancer cells. when you kill cancer cells, you have the potential to release a lot of these abnormal proteins into your blood. And the general idea is that you would follow up with some sort of immunotherapy to train your immune system to recognize the fact that these proteins are not normal. And the idea would be that you inject one tumor, and that by training your immune system, you're able to treat all of the metastatic sites in your body. There's 4 trials that are actively going on. These are very rapidly developing drugs that are now entering the combination phase, where it's not just the oncolytic virus, but also in combination with immunotherapy at this point in time. I'll just stop here. This is a trial that is opening up essentially next week or in 2 weeks from now, led by my chair, Dr. Van der Merk Bernstein. This is a NCI-funded trial, ADC match, where the major goal is to close this gap between targeted therapy, where you do high throughput genomic testing. You can find out the results for 10 different biomarkers at a time, with antibody drug conjugates, where right now you really have no high throughput way to test multiple targets at a time. The idea is that you take advantage of what's in between. Genomic testing is at the DNA level. Antibody drug conjugates we tend to think of at the protein level. Well, RNA, for those of you that remember their high school biology, is sitting in between. The basic idea is that when you look at genomic testing nowadays, Tempus, Caris, or what have you, very frequently you're not getting just DNA level testing, but also RNA level testing at the same time. So RNA links up with the protein level at a decent percentage. And the basic idea is that this is much faster. If you have a high overexpression rate of a certain target, in this case, these are all the FDA-approved targets, HER2, Nectin, TROP2, and that's why I brought up those drugs earlier. We're trying to link those with a antibody drug conjugate trial. And the idea just being that you really go and enroll patients really quickly and get them started on therapy quickly. I'll stop here. Thank you for your attention. And if you have any questions, please send me an email.
So our next speaker is Dr. Habib Al-Hagi. He's an associate professor of vascular and interventional radiology and the medical director of the vascular imaging lab at MD Anderson. He completed his residency and fellowship training at the University of Pennsylvania in Philadelphia and spent 2 years as faculty at UT Southwestern in Dallas prior to joining MD Anderson. He also started the percutaneous endobiliary interventions program at MD Anderson, and the title of his talk is going to be Management Strategies for Biliary Obstruction.
Thank you so much for the kind introduction. I think we're running a little bit out of time, so I may skip some of my slides just to be within the time, so I apologize for that. The most common cause basically for malignant biliary obstruction in general is extrahepatic cholangiocarcinoma and pancreatic adenocarcinoma. And unfortunately, a lot of times for these patients, primary curative intent surgical resection is not an option. Therefore, palliative and non-palliative drainage of biliary system through either percutaneous or endoscopic approach remains a key component of their management. So obviously, when we're looking at these patients and we are trying to work them up, for the procedure, it's very important for us to know what is the goal of the drainage, what is the patient's performance status, and we look for, comorbidities that could complicate the procedure or be a contraindication to it, such as having ascites or issues with coagulation system. An important part of the workup for these patients, getting really good cross-sectional imaging, because that could help us understand the anatomy, where the obstruction is, and both IR guys and the GI doctors, we can come up with an optimal plan for draining the patient. And obviously, getting an optimal plan, as other speakers, pointed out, is definitely a multidisciplinary approach, and we tend to talk to a lot of people before we make the decision. So the question becomes, between the endoscopic and percutaneous approach. So percutaneous approach is done, by IRs, and we go through the skin into the liver, and the endoscopic approach is done by GI doctors. So there was like a randomized control trial that was published a few years ago, and tried to compare, this in patients with potentially resectable tumors. They randomized 27 patients to each arm, and unfortunately, this study terminated early. So I just wanted to discuss this in case, you guys, come across basically this study. They terminated the study early because they reported multiple very bad outcomes in the percutaneous arm. And, so they concluded that the endoscopic approach is best. But unfortunately, so the issue here was that, the bad outcomes that they reported after the percutaneous approach is very rare, and we never see it in our practice. So that's something that we thought there's something really odd about this study. So me and my colleagues, really take the results of this study with a grain of salt. But there are some larger studies, we call them meta-analysis, and these studies basically combine the results of multiple other studies to compare procedures. And they have compared the endoscopic versus percutaneous approach, and all these studies, they have failed to show any meaningful difference in terms of success, both technically and clinically, and immediate bad outcomes after the procedure. But it seems like the percutaneous drainage seems to have a little bit higher bleeding rate. Endoscopic approach tends to have a little bit more infectious inflammatory complications such as pancreatitis and cholecystitis. So the question becomes, what is best for the patient? So one big element of these drainage procedures is patient comfort, and fortunately, after endoscopic drainage, patient comfort is a lot more. When we do these procedures, we tend to leave drains behind, and I constantly see these patients and kind of like patients don't really like these drains because understandably these are very uncomfortable. So in my practice, when I'm basically a patient is referred to me for drainage, if a GI person is not consulted, or if I think endoscopic drainage could be an option, I always call a GI colleague, always ask a consultation to make sure that option is considered before we do this. Choice of sedation, it can be done with general anesthesia or sedation. In my practice, I prefer general anesthesia, as these tend to be painful procedures. In terms of access, obviously we take into account a lot of considerations to make that decision. Obviously what the anatomy is, where the obstruction is, and where most of the normal liver parenchyma in the liver is, so we can target that to optimize patients' bilirubin and drainage. But if everything is kind of like similar, we tend to pick the left side access because it tends to be more comfortable for the patients. So once we get into the biliary system, if we cannot cross the area of occlusion, we tend to leave an external biliary drainage catheter. And the issues with these external drainage catheters is that they always have to be hooked up to a bag, and patients tend to lose a lot of fluids and electrolytes. So they may need basically frequent visits to the emergency room for electrolyte and fluid replacement, and it tends to be not very optimal. Luckily, if we go back in a few days, a lot of these drains, we can cross the area of occlusion and we can internalize them, so we can give the patient back all the fluids and electrolytes that they're losing. But sometimes this delayed internalization fails. In those cases, there are some more advanced techniques that we can try. I just want to, show you guys basically this case. This was a patient who had a right-sided drain that was successfully internalized, and there was also like a left-side drain that, despite multiple attempts, we couldn't internalize it. So in this patient, I was able to basically place a balloon in the right system and use a small needle through the left to target that. So we were able to create a small channel and get a wire into the small ball and successfully internalize, this drain. So we basically created a false lumen where it didn't exist. And this patient, had to come to the emergency room every week or so to get fluids replacement. And by doing this, she didn't really need to do that. So I would like to think, we made her life a little bit easier. I'm gonna skip, this case. So once we successfully internalize these drains, we basically tend to, wait for a few days until the bilirubin normalizes or goes down before we try to put a cap on them, so everything is drained internally and the patient is not losing any fluids and electrolytes. If the bilirubin basically level doesn't come down, Then we start thinking about additional drains, upsizing the drains, and things like that. And we tend to do everything we can to optimize the drainage for the patient to get to the goal that we were looking for. The other thing that I wanted to discuss was, for the patients, basically who have these drains, there are, things that we can do, through these drains. So one of the things that we can do is we can deliver treatments, through these drains. One of these treatment options is intraluminal high-dose brachytherapy. Studies have, looked into this, and it seems like it helps with overall local tumor control and the patency of these drains in this patient. There was a systematic review that looked at 17 studies, including 340 patients. The systematic review concluded that there's a trend toward better overall survival, better overall local tumor control, and better patency in the drains and stents of the patients who get the brachytherapy. The other thing, once patients get these drains, an important thing, especially in patients who are not a candidate for surgery, is basically stenting. And the goal over there is for us to remove as many drains as possible and make, basically bring more comfort to the patient. Some of these, drainages, these stents can be placed either via endoscopic or percutaneous approach. IR is kind of very helpful when endoscopy fails or in some of the patients with more complicated obstruction patterns. Studies, have looked into this. Usually, it's very successful, up to 90%, success rate. But we have to keep in mind that, some of these patients may come back with, recurrent occlusion and may need additional procedures. A newer concept, basically in stenting, patients with cholangiocarcinoma is just primary percutaneous stenting without leaving a drain or without going across the ampulla. So a prospective study was performed, and they reported, overall good outcomes using this technique. Right now, they are performing a randomized controlled trial and comparing it to endoscopic drainage. So that study is still recruiting. So once the data becomes available, we will see how it looks. It's a little bit more complicated than just drainage itself, but I think in experienced hands, it can be done very safely. So I'm going to skip this as well. And finally, I just wanted to take a second to talk about, tissue sampling in patients who have these biliary drains. If there's a patient and, we are having trouble making a diagnosis and the lesion, is not amenable to endoscopic biopsy or percutaneous biopsy, sometimes in the patients with biliary drains, we can get in there, use a small scope, identify the area. For example, in this patient, you can see, there was tumor recurrence at the site of surgical anastomosis, the small bowel. So we couldn't really access this through the skin, and for endoscopy, because of altered anatomy, this was not possible. So I was able to place a scope into the system, and you can see this abnormal tissue here that we sampled, and it came back positive for disease recurrence, unfortunately. And just, quick word about the outcomes. So when we do these, drainage procedures in all comers, up to 50% of the patients, we are able to get the bilirubin below 2 so they can get, their chemotherapy. I think for patients with extrahepatic cholangiocarcinoma, the numbers should actually be higher, but obviously, there's room for improvement here. I think in conclusion, clinical outcomes of endoscopy versus percutaneous drainage is very comfortable for both perioperative and palliative purposes. But obviously quality of life, in patients is very important and remains an issue for percutaneous drainage. So we really prefer the endoscopic approach if that's an option. Thank you so much.
Yeah, thank you so much for the presentation. So we have a little behind, so we have 10 minutes, but why don't we invite our speakers to come out and get questions. Any questions to our speakers?
studies that are taking place, does the actual cohort size of the study?
Please use the microphone in front of you. There's a small little tag, just hold and press. Well, no, there's no, I do have microphones.
In terms of the cohort size of the study, I guess throughout.
I do have microphones if you want to do that.
The cohort sizes throughout all the phases are, how does this size impact how we think about where the research treatment may fall as to, you know, frontline, secondary, tertiary care? I've noticed in some of the academic studies, you know, as it relates to sort of broader, more popular cancers, that they're relatively small. But does a cohort of, you know, 100, 200, you know, does that limit how we think about these treatments? Or do we say, you know, we have this group and it showed efficacy in this small population and we're going to fit it into the timeline of treatment? Would we like, you know, is there an optimal cohort size where we really could see that, you know, the treatment being studied really could now have greater impact?
Cohort size really has to do with. So if you have a very large cohort, 100 to 200 is actually a very large. That would probably be somewhere in the phase 2 on that point in time. And it has to do with what you're doing. If you're looking for an overall response rate benefit, say 30%, right? And you're trying to beat out.
Please turn the microphone on. There's a switch right above it on top of the mic. There you go. Thank you.
Sorry. And if you're trying to beat out something that say has a 20% chance, you're trying to tease out statistical significance in a difference of 10%. And so for that, you're going to potentially need a much larger cohort. So when you're trying to get into very nitty-gritty differences, you have a very large cohort. And that gives you statistical power to argue to the FDA, for instance, that, hey, my drug is better than this. So a cohort size of that large, very frequently, that's going to cost 10, 20 million maybe. That's a lot of money for a clinical trial. And so when you get to cohort sizes that large, you do have the advantage of statistical power, which is needed for FDA approval. But that's going to be much later in terms of phases of clinical trial. Small clinical trials, for instance, phase 1 clinical trials, which is what I run, you were never really able to get any statistics, quite frankly, out of them. And that is one of the major limitations of phase 1 trials, is that it needs to pass on to phase 2, which is a lot of what my GI colleagues here do, for any sort of statistical outread on benefits. And so the cohort sizes really impact what you can conclude from a clinical trial.
Extent. So this is a real problem for us with extrahepatic cholangio, as you know. If the patient cannot have the stent endoscopically and they have a PTC, at what point do you say that do you have one PTC, 2 PTCs, 3 PTCs? At what point do you say that it's simply not drainable?
So even in terms of like normalizing the bilirubin?
Yeah.
So that's a really good question. So I think what we look at is, you know, we try to, I think the studies that have looked into this is like, in order to get the bilirubin really, you know, down, you need a few things. First of all, like the underlying liver function, you know, when we start to work, you know, has to be, you know, kind of like in a relatively good location. Then what we aim to is we try to at least drain 75% of, you know, whatever liver is left for the patient. So when we start doing these, we try to place the first drain somewhere where we kind of like, you know, maximize, you know, the drainage. After 2-3 drains, you know, at that point, if the bilirubin is still not down, I would usually get like new cross-sectional imaging. And if there's like a really significant area that, I can put a drain in there and help the patient, we, may consider that. But if, everything is kind of like drained and you don't really have like a major territory that's like, left undrained, at that point I would, because just adding more drains at that point, it just is adding to the discomfort and to the patient, and I don't think it's really reasonable to do.
Dr. Valley, could you talk a little bit about, you said that patients should get a liquid biopsy and a tissue biopsy, and that they should be repeated. So when they ask their doctors or clinicians to repeat a biopsy, should they be doing both at the beginning and then also when they're repeated?
Yeah, thank you, Lisa. I think it's important that when we are thinking about a rebiopsy, we need to be answering a very specific question. So I'm not saying that we should just be doing this, willy-nilly. I think it's important that it is done at the right time. So in general, it would be at the time where maybe a treatment has been working very well and then it stops working, the cancer starts getting worse. That may be a time when we need to, let's understand what's happening in the tumor. Which lesion to biopsy, because sometimes there are different places that you can biopsy, is then something that needs to be discussed with the tumor board. Is it what's safe is usually the most important. But sometimes we also want to go for one of the cancer spots that seems to be behaving differently to the others, the one that's getting bigger compared to others that may be responding. So it is a detailed conversation that happens both with the patients and clinicians, but also with the person then doing the biopsy.
Hi, I'm sorry. So I have a question about related to immunotherapy. So basically, at my home, a lot of patients I know, they refuse to accept immunotherapy because they kind of afraid of the phenomenon called hyper progression. So because like in other cancers, like lung cancer, there's a phenomenon around like 10% of people who received like PD-1 or PD-L1 inhibitor develop like a rapid progression in their tumor. So I was wondering this because from when I was reading a paper in Keynote 968 and 1201, I don't think they mentioned this phenomenon. Can we interpret it that the risk of hyperprogression is so far is quite low from the observation? Is that the correct interpretation?
Yeah, thank you so much for the great question. Yeah, I mean, we do see so-called hyperprogression from immunotherapy. I treat both liver and bile duct cancers. I quite commonly see hyperprogression. So hyperprogression means tumors progress really quickly, basically progressing rapidly. I do see hyperprogression uncommonly for liver cancer because these patients receive immunotherapy only. But for biliary tract cancer, immunotherapy is also given with chemotherapy. So there are medications running to suppress the tumor with from chemotherapy, and also we do immunotherapy. So from my own experience and other literature suggests that the chance of getting hyperprogression is quite small for biliary tract cancer. At the same time, benefit outweighs the potential hyperprogression, other immunotherapy-related side effects.
The last question, yeah.
So a question just about if you have multiple targetable mutations, like just, then how do you as a patient, or how does the medical care team decide what clinical trial would be suited for you? Like, are there determinations that, I'm not sure if I'm asking the question right, but yeah, which one is most beneficial based on the mutations you have?
That's a great question. I think we also don't know the full answer there. So I think a lot of times what we do is when we look at the report, you probably see multiple pages, a whole list of mutations. What we call currently actionable or targetable mutations are mutations that we currently have drugs either within a clinical trial or standard of care. And so as clinicians, it's our job to look at that list and say which one of these would probably be the most effective treatment for the patient. Having said that, I think there's a lot of mutations that patients see on their reports that we don't currently have drugs for, but that doesn't necessarily mean we won't have them in the future. So when we're talking about the 56% of patients that don't have actionable mutations, it's just right now. I think in the future that number is going to change, and that is the hope that with phase 1 trials, kind of drug discovery, we'll be able to really close that gap in the future.
Thank you very much to the panel. Thank you very much. Okay, I'm going to ask the next moderators to come down, Dr. Zhang and Dr. Kodali, to chair our second session of the morning, which is localized biliary tract cancer going for the cure. I know there may be more questions for these experts, so please feel free to approach them during lunch or dinner tonight to ask them questions. I know Dr. Zhang and Dr. Kodali will do a great job keeping us on schedule. Thank you.
All right. Well, I'll definitely try to get us back on time. I'm Sudha Kodali. I'm going to start off the session by welcoming everyone again. And we'll get started with the first speaker. Rosie has been fantastic, and I really want to thank her for agreeing to come and speak today about her journey, especially her journey as a cholangiocarcinoma patient and also her experience receiving transplantation. Thank you so much, Rosie.
Thank you so much, Dr. Kodali. As Dr. Kodali mentioned, my name is Rosie Giacosa. I am so honored to be here today to share my story. The story is that it's not just my story, but that of the small army of family, friends, and medical professionals, some of which are in this room today, that were there with me during my journey and without whom I would not be here today. On June 17th, 2021, my world turned upside down. A CT scan showed a mass in the hepatic duct that was causing an obstruction. The diagnosis was confirmed: cholangiocarcinoma. What was cholangiocarcinoma? We had never heard of it. No one we knew had ever had this form of cancer. I was immediately admitted to the hospital. That would be the first of many hospital stays. Here's a few slides from that time. Oh, sorry. No, this is not the right slideshow, but that's okay. We'll keep going. I was a healthy 52-year-old woman living in Miami with her husband and 2 kids. My son was away at college and my daughter was a working professional. I had never had any health concerns. I lived a clean, healthy lifestyle and exercised regularly. People would tell me after my diagnosis, "You are the last person I would have thought would get cancer." But here we were in this battle. When we received this devastating news, we did what most people would do. We Googled. Immediately, we found the Cholangiocarcinoma Foundation. We started to educate ourselves with the wealth of information, resources, and support CCF provided. We were very blessed to have found such an amazing organization. The race to save my life was on. I would not let my doctor speak of stages or survivability rates. I told them that that was the past and I was the future. We only spoke of the plan, and that's how we proceeded. The next 6 months of my illness were a roller coaster ride. Chemotherapy, directed MRI radiations, multiple stent replacements, 4 sepsis infections, biliary cath replacements, and multiple transfusions were a few of the curveballs that life threw at us during that time. But after all of that, in November of 2021, my scans did not show any improvement. The tumor was still inoperable and it was wrapped around an artery. My body had taken such a beating from all the infections and the chemotherapy, and the doctors were discouraged. My doctor told us it was time to pivot. We will keep you on GEM, and he said, go out and find clinical trials or other options. And that's exactly what we did. I always tell people that we took our show on the road like the circus. We visited 4 medical institutions. There were clinical trials available, but at this time, the latest scan shows that the GEM was working and keeping my tumor stable. And the recommendation was to wait and continue on the GEMs. At each appointment, we would ask the question, what about liver transplant? And each time we were told that that was not an option for me. I could understand why they had concerns about giving a cholangio patient a liver that could go to another patient with better odds. MD Anderson was our 5th and last stop on our road trip. We met with Dr. Jobli. And during the discussion of my case, he asked us if we would consider transplant. I said, I've been told 4 times that I am not a candidate for transplant. And he said, well, I think you should give Houston Methodist a try. I'm going to refer you over to Dr. Kadali, and let's see what happens. That moment was the pivot we were hoping for. Our prayers were answered on in April of 2022. We started the testing with Dr. Kadali at Houston Methodist. She is the embodiment of kindness and empathy. With every test and scan, we held our breath and prayed. In August of that year, I was officially put on the transplant list. 1 week later, I got an offer for a liver. Unfortunately, I was still in Miami, and I was not able to receive it. We were heartbroken, and we said never again. The next day, my husband and I packed up the car and moved to Houston. We left our entire family and support system. It was so hard to leave the place you had lived in your whole life without knowing when or if you would return. Leaving my daughter was excruciating for me, but she had met a wonderful man, and I knew that he would be her companion during this difficult time. We arrived in Houston a couple of days later. Our short-term rental was 9 minutes away from Houston Methodist. We established medical care at MD Anderson, and we waited. My disease continued to be stable. During the next 3 months, I received 2 more offers that did not work out. For one of the offers, I was prepped, intubated, anesthetized, and in the operating room, but the liver was not viable. Each time I thought, that's okay, that wasn't my liver. Time continued to pass. Being in Houston without my family over the holidays was hard for everyone. I was having a difficult time emotionally because I felt that I was getting sicker, and the liver just wasn't coming. In my darkest moments, I thought, maybe I'm not going to be here next Christmas. But I knew my daughter was probably getting engaged, and I would pray every day to allow me to be here to see her walk down the aisle. On January 9th, 2023, I had my regular scans. The news was terrible. It was as I feared. The cancer was active again. My husband and I were devastated, but we decided that night that we were going to continue fighting. Then, my miracle happened. At 6 a.m. the next morning, my phone rang. When I saw the number on my phone, I knew that that was my liver. It was Vita, the same liver transplant coordinator that had called me 3 times before with other offers. Rosie, we have a liver for you. Are you in Houston? I said, I'm 9 minutes away. Where do I go? She proceeded to tell me some facts about the donor. There was nothing that she could have said about that donor that would have led me to say anything other than I accept. My surgery took 2 days. For me, it was as if it had taken 2 minutes. There were some good drugs there. But I know that for my husband, who was in Houston by himself, and my family and friends that were waiting anxiously for every bit of news from the transplant team, it was excruciating. Dr. Goviel and his team were amazing. Dr. Connor, Dr. Saharia, Dr. Hodecki performed my surgery. The first 5 days post-transplant were the most challenging for me, but each day afterwards I improved exponentially. I was in the hospital for 10 days and I went back home to our rental to heal. these are not the right slides. Let me see what else is up there. This is my mother coming to visit when I was on my 9th day at the hospital. This was the first time that they stood me up post transplant.
Hello.
This was another picture at the hospital. This is actually before. This is me waiting for my transplant.
Hello.
In February, we got a wonderful surprise. My daughter's boyfriend came to Houston to ask us for her hand in marriage. The emotion was too great to put into words. Now with my new liver, I had the opportunity to be there to witness their happiness and their future life together. My prayers had been answered. On April 8th, my scans came back and they showed no indication of cancer. My cancer markers were normal and I was in remission. There were moments when I never thought I would hear those words. On April 29th, we were homebound, sitting in the same car that had brought us to Houston 9 months earlier, and feeling so blessed to be going back to start a new life. Today, I stand here almost 2 years post-transplant and thriving. Every day is a bonus day that I am embracing with a heart full of hope. Facing cancer taught me that strength knows no bounds, and each challenge is a chance to rise. I am so grateful for this second chance. I dedicate my time helping others embrace their health journeys with hope and resilience, campaigning for organ donation and promoting awareness for liver transplantation as an option for cholangiocarcinoma patients. A million thank yous will never be enough. I always tell people it took a small army to get me where I am today. My 3 medical teams fighting for me all along the way. My Miami medical team that kept me on the roller coaster ride in those early days and that were honest with me when it was time to pivot. My MD Anderson team, Dr. Javali, you are so special and amazing. Thank you so much for being the pivot we were looking for and for bringing me Patty, my angel, always advocating for me. Dr. Gadali for believing in me and giving me a chance and always being so kind. Dr. Gabriel and all his doctors and nurses at Houston Methodist. Too many things to mention there. We'll be here till tomorrow. And lastly, thank you for your patience in hearing my story and for all of your efforts to continue to help patients like me have hope for the future. Thank you. Yeah, sorry. You're welcome.
Thank you so much, Rosie, for sharing your story, your fight, your challenge, but of course, the story of hope. I really appreciate you coming over here and talking about it. Thank you.
Well, I feel bad for the next speaker to follow that. Oh, it's my partner. Hey everyone, I'm Ching-Wei Zhang, one of the surgical faculty at MD Anderson. I have the pleasure to introduce the next 2 speakers. The first is Tim Newhook, who's an assistant professor here at MD Anderson. He's going to talk about surgical considerations for perihilar cholangiocarcinoma.
I don't know, they just wanted, so then I think I need to switch over to the slides. So how can I switch over to the slides? I'm trying to find it. Would it be an issue if I switch it?
I don't know this program. What program are they using?
It's in production.
What program are they using?
That's gonna have to do with it. I mean, that's
okay.
That's a good
The conference.
Yeah.
So you got the podium PC?
But that's podium PC.
See, then there's no way to send it.
No, this one. So I need to send this. Whatever.
It's not going. Okay, so what program is it? Just web conferencing?
Well, that's a tough act to follow. Thank you very much for the opportunity to speak, and what an amazing story. Thank you to Ms. Chiacosa for that
overwhelmingly emotional talk. It really shows how important it is to have a good team through a really difficult journey.
This guy wants to talk.
Let me get this going here. Like I said, my name is Tim Newhook, and I unfortunately have to follow that mic drop. We talked about the other way to manage this very complex disease through surgical resection. And surgical resection versus transplant, the decision about that is extremely complex and not something that I'm going to cover today. But I wanted to talk a little bit about how difficult decision-making really is in this disease, particularly from a surgical perspective. And the stuff I'm presenting today is a culmination of an extremely complex team effort, not just my own data, but the entire team here at MD Anderson particularly. So what's the problem? I don't really have to talk about this too much to this audience, but the surgical management, whether it's any type of surgery for this disease, is extremely complex. This disease is unfortunately often extensive, advanced at presentation, and a lot of this is because it occupies a very central location in the liver with a proximity to really complex vascular structures. Even an area, and I describe to my patients, the size of your thumbnail includes a tremendous amount of complex things that we need to consider. Complete surgical resection via hepatectomy, so removing the cancer with liver, it often extended to the segment 1 or the caudate lobe with resection of the bile duct. Removal of all of that is the only potential curative option, and that can be achieved through complete surgical resection, but also transplantation. And that's a hepatectomy, obviously. Unfortunately, resection overall is associated with high morbidity, so complications, as well as, unfortunately, mortality. Every step along the way, from the initial diagnosis, as we just heard about, to the postoperative period, as well as surveillance, is critical for the best outcomes we can possibly achieve. So these are things I'm going to talk about today. So we're going to start out with surgical outcomes and safety. Now, this data is from a surgical resection standpoint. This is an important graph to see. A few years ago, published in a very, very high-impact surgical journal, Annals of Surgery, detailed potential benchmark values. So what should we shoot for outcomes for patients who undergo resection of perihilar cholangiocarcinoma? And this came from 24 expert centers, and we can debate the definition of that. But as you can see from here below, all the centers that were included in this publication had their number of cases that were underwent resection in the time period, which is just over 5 years. And then if you look at the proportion of cases in the black part of the bars that ended up being benchmark cases overall, is incredibly varied and not uniform. So even high volume centers on this graph had a low proportion of operations that fit even the defined benchmark margins. Just goes to show you that it's not necessarily a volume outcome relationship, but also that complications are difficult and frequent. So if we dive deeper into the actual data from this, you can see that unfortunately there's a lot of complications, and this is what leads to the disparate outcomes. The rate of major complications in this publication was almost 80% median. Almost everybody had something. A benchmark rate for liver failure, what we should shoot for after resection, was under 35%, including the highest grade being under 10%, grade C, which is what leads to really bad outcomes. And a benchmark value of under 8% was what we shot for in-hospital mortality. That is during the same index operation. Clearly incredibly complex. And that's highlighted here in this data, as you can see. So clearly a difficult problem. So what are some advances in perioperative management that we see, at least in our institution, that we think are critical to improve these historical outcomes? So in 2015, a publication from an institution led by my mentor, Dr. Vote, evaluated our experience at MD Anderson for the time period beforehand. We saw that patients who undergone resection of perihilar cholangiocarcinoma at our institution had a rate of 55% of major complications. So thank goodness, at least early on, it was lower than the benchmark, with an 11% 90-day mortality. And that's for all different causes, but a lot of it had to do with liver failure. So we were interested in finding out what were the causes of this and the factors that we could potentially mitigate. And what we found in this publication was the only factors in our experience that were associated with liver failure-related mortality were having a volume of liver less than 30%, so leaving enough behind to support you after surgery, but also the presence of infection of the bile, which is called cholangitis, while you underwent surgery. So if you look at the figures to the right here, the first one, these are in patients who did not have enough liver left over to support them. And the impact of bile infection in this cohort was extremely profound. As you can see, for patients who had cholangitis, had a significantly increased risk of hepatic insufficiency, so your liver limping along, but also death due to liver failure. But in patients who had over 30%, which is the graphs to the right there, having enough volume left over, that mitigated the impact of bile infection on outcomes, and the rates of hepatic insufficiency and death due to liver failure were similar between the two groups. A lot of this has to do with what we heard earlier as well about drainage and opportunities for differential drainage protocols. And this was initially our algorithm that we had designed in our group, that we thought that whether to undergo endoscopic drainage or drainage via percutaneous approach should be really defined based upon the tumor anatomy. So the Bismuth-Corlett criteria, which is classifying the tumor based on where in the biliary system there's cancer. And maybe we could have a savvy approach to drainage to reduce the opportunities for infection of the bile. But turns out, and this doesn't look like it's worked well on my Apple, I'm sorry. But if you look at what we looked at here was our drainage practices in our most recent publication, and you can see that actually most patients even beforehand had what's called an EBD, or an endoscopic biliary drainage procedure. And then if you look closer from that, in the most recent time point, patients who had both an external biliary drain and a percutaneous biliary drain significantly decreased in our more contemporary period, showing the evolution of ability to undergo drainage through an endoscopic approach. So it turns out most patients undergo an endoscopic approach now in our institution, and that's actually been helpful for patients convenience-wise. So some key principles here are that overall the enemy is cholangitis. We have to avoid and eradicate bile infection. A lot of that has to do with optimizing drainage, but also minimizing attempts at biliary drainage, because every one of those attempts is an opportunity for bile infection, as well as ensuring that we have enough liver left behind to support the patient during recovery. So what about a situation where a surgeon and a patient have the opportunity to go either way? And what I mean by that is highlighted here in the boxes are schematics of the bile tree. So you have the right and left hepatic ducts. What about when the tumor goes equally on both sides and you could potentially remove either the left or the right side of the liver? And I will tell you that in surgical training, it was always the test question answer to remove the right side of the liver. And that was sort of surgical dogma, that oncologic outcomes would be better with a right-sided surgery for lots of various reasons that are beyond the scope of this talk. But what happens when you can go both ways? What should we do? So I'm going to skip this for time. But let's look back at that initial paper that I talked about with the benchmark data here. As I said, lots of complications, unfortunately, lots of doom and gloom. And if you look in the bottom square here for the patients who underwent in-hospital mortality, and go further down here below that, you can see that patients who had a left-sided operation had much less death due to liver failure and better operative outcomes. So maybe there's a signal here that we should be considering a left-sided resection more often. And that's because the right liver is usually larger. Yes, we have two livers. We have a left liver and a right hemiliver, but they're not always the same volume. Typically, the right liver is much larger and the left liver is smaller. So naturally, just by selecting a right-sided resection, when you can go both ways, we're already leaving less liver behind. So perhaps if we started to remove the left side of the liver more often, we would right off the bat be leaving a lot more liver behind to fight the potential impacts of cholangitis and other operative outcomes here. And this was shown very early on in terms of volumetry, that the right and the left liver, as you can see, the right liver is typically 65% on median of the total liver volume, compared to the left liver being 33%. So double the volume left over if you were to remove the left. So add that to our key principles, beyond avoiding cholangitis, having a volume over 30% left over, but maybe we should consider left-sided resections when possible. And I will tell you that that seems to be the trend. So moving on here to our more recent MD Anderson experience. we reevaluated our perioperative outcomes for patients who underwent resection of perihilar cholangiocarcinoma at our institution after our last publication. So how do we take that data and apply it to our practice to improve outcomes? So we have a past cohort and a recent cohort. And what we found is exactly what we just discussed. A significantly higher proportion of patients underwent a left-sided surgical resection. And I will tell you that now when we consider resection for this disease, we're always trying to remove the left if we can, based on the ability to have a negative surgical margin, because we know that volume really matters. And what ended up happening is that in our most recent cohort, in the last 10.5 years compared to the prior publication, we've had 0 cases of liver insufficiency. In fact, actually, since 2015, we've been very fortunate to only have had 1 patient who we lost in the perioperative period, and that was actually just a few months after the last publication, so very early on. In the last 10 years, thank goodness nobody has passed in the last 90 days after surgery. And a lot of this has to do with what you see here, a significantly decreased risk of liver insufficiency, liver failure, and perioperative mortality. In other centers, particularly in Asia, surgeons strive to have a volume over 30%, actually over 40% is their cutoff. So we wanted to see if maybe we should optimize our volumetry and try to offer surgery to patients who had more than 40%. So when we looked at patients who had between 30 and 40% liver left over versus over 40%, we've actually found no statistical difference in any complications, liver insufficiency, or mortality. So it turns out that we think that 30% over really is the sweet spot for otherwise resectable patients with resectable disease. And if you look at our survival curves here, as I said, our overall survival has significantly improved in the last decade since our publication. So thank goodness the quality improvement has occurred, recognizing that these things are important, with a median overall survival that has not been reached in the last decade compared to 33 months in the prior cohort of patients. But what's important to look is at the very beginning of this curve here. If you zoom in on the survival curves here, you can look that in the dark line, that's our past cohort. A significant number of patients unfortunately passed very early on, and we hypothesized a lot of that has to do with perioperative outcomes, death from liver failure and cholangitis, and that is what results in the improved survival that endures throughout the survival curve. So the early perioperative period, at least focusing on quality improvement with regards to those indices, really matter for outcomes going forward and the ability to continue with your cancer journey. As I explained to patients, you have way more options when you're safe. That should be our focus. So summary and main points. Outcomes following resection of perihilar cholangiocarcinoma have, thank goodness, significantly improved over time. And a lot of this may actually have to do with selection and optimization for surgery, whether it be transplant or resection. That's just a fact. In our contemporary experience, we have had less patients with preoperative cholangitis. We have fortunately not had any patients with post-hepatectomy liver insufficiency while applying these criteria. And we've had a higher proportion of patients undergo left-sided resections, which may be more complex, but clearly are important. So in conclusion, resection of perihilar cholangiocarcinoma is very complex. I hope I've shown that. But with a good team, with significant preparation and selection for what's the optimal treatment, outcomes can be improved. A lot of this has to do with preventing and eradicating cholangitis. The importance of the liver volume that will be left over to support patients after surgery cannot be stressed enough. And a lot of that has to do with considering left-sided resections when possible. And again, we didn't talk about this much, and hopefully we'll talk about it more going forward, but preoperative chemotherapy really may provide time for optimization. More patients in our contemporary experience undergo some form of preoperative therapy. This allows for more time to eradicate cholangitis, optimize drainage, and get stronger for whatever the path may take. Thank you very much for the opportunity to speak, and looking forward to the rest of the questions.
All right, thanks, Dr. Nihuk. Well, on the same topics, we'll be talking about more surgery. The next topic will be by Dr. Yunshin Chun, who's my partner, professor in surgical oncology. She'll be talking about a very common debate, whether to cut or not to cut first for cholangiocarcinoma.
Well, thank you for the opportunity to participate in this symposium. And thank you especially for the chance to quote Shakespeare in public. So after to be or not to be, that is the question. Hamlet said, whether 'tis nobler in the mind to suffer the slings and arrows of outrageous fortune, or to take arms against a sea of troubles and by opposing end them. So these two scenarios can be analogous to neoadjuvant therapy versus upfront surgery for cholangiocarcinoma. So to cut or not to cut first, to illustrate this dilemma, a patient had a 4.3 centimeter intrahepatic cholangiocarcinoma. PET scan showed a second smaller liver lesion that lit up on PET scan. CA19-9 was normal. Should this patient undergo neoadjuvant therapy or upfront surgery? To answer this question, we need to know the definition of neoadjuvant therapy, what defines resectability and hepatobiliary surgery, the rationale, pros and cons of neoadjuvant therapy, and currently available data. So first definition of neoadjuvant therapy. Emil Frey was an oncologist who worked at MD Anderson, then Dana-Farber in Boston. In 1982, he gave a lecture on cancer research, and he described a new therapeutic strategy known as neoadjuvant chemotherapy. In this strategy, systemic therapy is employed prior to surgery or radiotherapy. What is the definition of resectability and hepatobiliary surgery? First, there should be no distant metastasis. The liver needs to have enough blood going into it via the hepatic artery and portal vein, blood going out of it via the hepatic vein, adequate biliary drainage, and sufficient liver volume. So liver has a remarkable capacity to regenerate after resection, but you have to leave enough of it behind to avoid liver failure. What is the rationale for neoadjuvant therapy? So in Dr. Frey's lecture, he described regression of the tumor, which he called upstaging. Today, we call this downstaging or downsizing. So the chemotherapy can allow the tumor to shrink and potentially allow smaller surgery. Neoadjuvant therapy can also treat micrometastasis. These are cancer cells that are not detected on CT scan, MRI, or PET scan. Neoadjuvant therapy can be also used to evaluate response of the primary tumor to chemotherapy. This can be useful when deciding what to give after surgery. So if the chemotherapy worked well before surgery, then it's expected that it would work well afterwards. On the other hand, if the chemotherapy does not work well after surgery, then you should consider different drugs after surgery. The clear advantage of upfront surgery is that surgery is the only potentially curative treatment for cholangiocarcinoma. However, there is a low rate of cure due to high risk of recurrence after surgery. Also, patients may develop postoperative complications that prevent them from receiving chemotherapy afterwards. The pros of neoadjuvant therapy, as stated by Dr. Frey, is to downsize the tumor. This can potentially reduce the magnitude of the surgery, increase chances of negative margins at time of surgery. Other pros are to treat micrometastasis, avoid futile surgery, and potentially reduce recurrence risk, and improve survival. The cons of neoadjuvant therapy is it may not work, and thus you lose your window for surgery. Toxicity. Patients can have postoperative complications increased because of neoadjuvant therapy. Patients with biliary stents can have cholangitis during therapy, and they may become too sick on chemotherapy to undergo surgery. We also lack high-level evidence on the efficacy of neoadjuvant therapy and which agents to use. Ultimately, the goal is to reduce recurrence risk and improve survival. So what is the risk of recurrence after surgery? The BILCAP trial was a landmark trial on chemotherapy after surgery, and it enrolled patients with all types of biliary tract cancers. The median recurrence-free survival after surgery alone was only 17.4 months. So in many patients, less than 2 years after surgery, their cancers will come back. Clearly not what you want to hear before a major operation. What are the risk factors for cancer recurrence? In the BuildCap trial, a positive margin and metastatic lymph nodes led to worse survival. In addition to lymph node metastasis and positive margin, vascular invasion, larger tumor size, higher CA19-9, multiple tumors for patients with intrahepatic cholangiocarcinoma, and high-grade poorly differentiated tumors are risk factors. So the goal of neoadjuvant therapy is to reduce recurrence and improve survival. A retrospective series of the National Cancer Database of over 4,000 patients who underwent resection of intrahepatic cholangiocarcinoma between the years 2006 and 2016 found an association between improved survival and neoadjuvant therapy. A retrospective analysis of our experience at MD Anderson with neoadjuvant therapy for intrahepatic cholangiocarcinoma identified 45 patients between the years 2003 and 2019. The most commonly used regimen was gemcitabine and cisplatin. Major pathologic response, defined as less than 50% viable tumor cells in the resected surgical specimen, was identified in 36% of patients. Median recurrence-free survival was 11 months, median overall survival 45 months. The fact that overall survival was more than 3 times longer than recurrence-free survival means that patients, even after the cancer comes back after surgery, can still be treated. So retrospective data has several limitations, especially bias. Prospective studies have fewer sources of bias and in general provide higher quality evidence. NeoGAP is a prospective multi-center study on intrahepatic cholangiocarcinoma. The study enrolled 30 patients who received gemcitabine, cisplatin, and nab-paclitaxel before surgery. Their tumors were technically resectable, they had no distant metastasis, and they had locally advanced tumors defined as either a solitary tumor more than 5 centimeters, multiple tumors in the same lobe, major vascular invasion, or node-positive disease. The primary endpoint was completion of chemotherapy and surgery, which was achieved in 73% of patients. Partial response to chemotherapy was seen in 23% of patients, stable disease in 67%, and progression in 10%. The DEBATE trial was a prospective study conducted in 2 centers in South Korea. This trial enrolled 45 patients and randomized them 2-to-1 to receive durvalumab with gemcitabine and cisplatin or gemcitabine and cisplatin alone. This study enrolled patients with all types of biliary tract cancers, and the primary endpoint was negative margin resection rate. There was no difference in the primary endpoint of margin negative resection rate. However, the response rate and percent of patients who could undergo curative intent surgery was higher in patients who received durvalumab in addition to gemcitabine and cisplatin compared with gemcitabine and cisplatin alone. When you look at the best response rate achieved with neoadjuvant therapy for cholangiocarcinoma, it's only 36%. Only 36% of patients have an objective response. In the NeoGAP trial, only 23% of patients had a response. Compare this with metastatic colorectal cancer, where 65% of patients will have shrinkage of tumors with chemotherapy. In efforts to improve our neoadjuvant strategies, there are a number of ongoing clinical trials. Pembrolizumab added to gemcitabine and cisplatin neoadjuvantly is being studied at MD Anderson for potentially resectable intrahepatic cholangiocarcinoma. The primary endpoints are recurrence-free survival and major pathologic response. Dr. Trankau is the principal investigator. Dr. Trankau is also the principal investigator of a multi-center study of durvalumab with gemcitabine and cisplatin for high-risk intrahepatic cholangiocarcinoma. The primary endpoint of this study is proportion of patients who complete neoadjuvant therapy plus surgery. So in summary, surgical resection remains the gold standard treatment for biliary tract cancers. However, postoperative recurrence rates are high. High-risk features are lymph node metastasis, vascular invasion, positive margin, larger tumor size, high CA19-9, and multiple tumors. Retrospective data show associations between neoadjuvant therapy and improved survival. Prospective studies show the feasibility of neoadjuvant therapy. And enrollment in clinical trials is critically important to identify better systemic therapies and treatment strategies. So going back to the patient I presented at the beginning, she received neoadjuvant gemcitabine, cisplatin, and durvalumab. Her surgery was delayed due to a blood clot. Surgical pathology showed that the second small liver lesion was actually benign, and thus her tumor was stage 1, and she's currently well with no evidence of disease. Thank you so much.
Thank you, Dr. Chan. That was a great presentation. Moving on, I'd like to invite our next speaker, Dr. Ashton Connor, who's a transplant surgeon at Houston Methodist, and he will be speaking about oncotransplant for cholangiocarcinoma. Where do we stand?
All right, fantastic. Thank you so much. Let's see, which is the forward one? There we go. All right, so thank you so much for the opportunity to speak today. I'm very happy to hear that the Cholangiocarcinoma Foundation is now translating from Canadian, which I will be speaking. I think if I had to explain Canadian to folks, I know Dr. Newhook understands the language, but I think it would be if William Shakespeare that we just heard about and Mark Twain had a baby, and then that baby grew up to marry a French person. That would be something like Canadian. So I have no other disclosures other than my language impairments. So this is the outline of what we're going to speak about today. It's a little bit different than what you've heard about so far. Everything you've heard about so far has been sort of in the medical oncology and surgical oncology context. So we're going to talk, this session is we're going to speak about transplantation as an option for treating cancers. So it's a large topic to fit into 10 minutes. I'll do my best. This is the pathway that most patients with transplantation go through, as we heard from Rosie, this is the journey that our patients go through. And I will break up the talk into these different topics. So we speak about each of them in turn. These are my old slides, actually. These are my new slides. So if I had to describe liver transplantation briefly to you, because it's probably a surgical approach that, I can try to, let's do it. There we go. Hold on, sorry. Where do you think you're going? It doesn't matter. We'll just keep going. If I had to describe liver transplantation to you, many of the surgical concerns that Dr. Newhook described in his last slide are superseded in transplantation because the entirety of the liver is removed, and it is entirely replaced with a new liver. So concerns about tumor number and size as obstacles to removal of the tumor are somewhat overcome, as long as the tumor is not found at the edges of the tubes that go in and out of the liver. So it would make more sense if I had the company photo. But the blood vessels that go in and out of the tumor and the bile ducts, as long as the tumor is not found at those edges, the entirety of the liver can be removed with those tubes, and the new liver can be replaced there. Now, the main concern when it comes to whether or not such a surgery should be undertaken really becomes if there is tumor beyond the liver, meaning outside the liver in some other organ, be it the lungs, the bones, etc. And so our considerations for surgical treatment are a bit different. Now, what volume of patients undergo liver transplantation for cancer? This is the experience at Houston Methodist, and work very closely with MD Anderson. I would say by far the largest proportion of our cancer patients are treated jointly between ourselves and MD Anderson. We're very proud of that relationship. You can see here the number of transplants performed at our institution over every year, and the plot on the left. And the gray are patients who are transplanted for non-cancer indications. They still make up the majority of patients who undergo transplantation, but an increasingly large proportion in the minority undergo transplantation with cancer as a main indication for their transplantation. The green is patients who undergo transplant for hepatocellular carcinoma, which is more common than cholangiocarcinoma in the liver. But the blue on the plot on the left is the people who undergo transplant for cholangiocarcinoma. That blue is expanded in the smaller bar plot on the right. And you see that we color code it now by whether the cholangiocarcinoma is in the hilum of the liver, what we call perihilar, or within the liver, what we call intrahepatic, or if it has features of both cholangiocarcinoma and hepatocellular carcinoma. And that's a histological thing, but those tumors tend to behave more like cholangiocarcinomas than anything else. Now, these are our numbers up until the end of 2023. I can tell you that as the program has continued to grow, our 2024 numbers far exceed these. I would have to expand the size of the y-axis if I were to include our sample size of 2024 at the present time. We've transplanted close to 20 people with cholangiocarcinoma this year alone. So what are some of the feature, and the year is not yet done. I think Dr. Chia is on call this week, and she's looking to set new records. So if we go through screening and diagnosis, so this is obviously where the care path begins. How do we identify people with cancer? So people who come to us with liver disease for transplantation, they tend to have chronic scarring in the liver due to chronic inflammation, what is referred to as cirrhosis. That's a term passed down from Hippocrates 2,500 years ago, and we continue to use it. Cirrhosis, unfortunately, predisposes people to cancer. So it's important that we be able to identify who has cancer with cirrhosis. People with cirrhosis are at increased risk of cancer because, number one, the liver is no longer doing the things that it was intended to do, which is to clear out, amongst its many functions, growth factors from the bloodstream. And so you get accumulations of estrogen, insulin, and other growth factors that can lead to cancerous growth. And then the things that lead to cirrhosis, be it alcohol, hepatitis B, etc., in addition to being directly toxic to the liver, they're also directly carcinogenic. So people that we treat with liver disease are at much higher risk than the average population for developing cancer. How do you screen for cancer in this population? There is some evidence, it's not what we will call level 1, but there is some evidence for the use of imaging and blood tests every 6 months. Unfortunately, for many reasons, many of them healthcare system reasons, we're not able to get this care to many patients with liver disease. Less than 25% of people with cirrhosis will undergo appropriate cancer screening for hepatocellular carcinoma. There is no accepted cancer screening, unfortunately, for cholangiocarcinoma. So that is an issue that we are trying to address. I'm fortunately privileged to work with some very smart people at Houston Methodist on this and at MD Anderson, but I don't have any research to show you in that regard at the present time. This is another thing that I want to emphasize, that even after you make the diagnosis of cholangiocarcinoma, although you can get these very pretty pictures from Nature, which is where I borrowed this picture from, and from other journals, as we've seen so far today, that will classify the tumor into intrahepatic or perihilar, which are the two types of cholangiocarcinomas that we can currently offer transplantation for. When you're dealing with a patient, it is very difficult to tell these two apart. So the cross-sectional CT scan on the right shows you a large tumor at the center of the liver. I'm not sure how to activate the pointer on this, but it shows a large tumor at the center of the liver. I don't like to show patient photos, but this is an image of a patient that received a transplant at our center. And you would be very hard-pressed to describe this as either intrahepatic or perihilar. And so it's been shown that in about 30% of patients, the diagnosis gets changed over time. So now we can talk a little bit about transplantation and adjunctive therapies, so perhaps convince you about the use of transplantation for this condition. And I want to emphasize, this is from the American SEER database from 2007 to 2017. If you look all the way at the bottom of that chart, it shows a number of patients with either hepatocellular or cholangiocarcinoma who have received a liver transplant in the United States during that period of time as their local control, and it's unfortunately very low. It's less than 2% of patients with cholangiocarcinoma that are known to have that, and less than 5% of patients with hepatocellular carcinoma. There are actually more patients in this time period in the United States being treated with local control by interventional radiology as their definitive local control than with transplantation. And of course, I respect very much interventional radiologists, I don't mean to single them out. We're very dependent on them to provide care, but it's not, their modalities are not curative. So unfortunately, there are less patients undergoing potentially curative treatment with transplantation than there are getting local control with interventional radiology. And hopefully we can continue to influence that. So this is a meta-analysis. I don't mean for you to get through the granularity of it, but this is a meta-analysis of liver transplantation for perihilar cholangiocarcinoma. Transplantation for perihilar cholangiocarcinoma is much more established. The first papers came out in the year 2000, and the experience has continued to grow since then. There are now 20 studies. There's no level 1 evidence, but there are 20 studies. The cumulative evidence at this point in 2021 is about 430 patients, 150 of whom have been treated at a single institution, which is the Mayo Clinic in the United States. So the Mayo Clinic should be very proud of the efforts that they have made in this area. And the 3-year survival is approximately 55% for patients. Now, I would say 55% 3-year survival for many other cancer types, such as breast cancer, colorectal. you would be dismayed by that, but for perihyaloid cholangiocarcinoma, that is excellent 3-year survival in patients who cannot otherwise undergo the surgical resections that Dr. Newhook described for us. So this is excellent. Now, what they also emphasized in this is that surgery alone is not enough. So patients have to have chemotherapy and radiation before transplant, and increasingly they're having chemotherapy after transplant in order to achieve these numbers. If you are not able to deliver those adjunctive therapies, then the outcomes are unfortunately not as good. Now, this is work that we've done at our center in collaboration with MD Anderson. This shows that radiation is difficult to deliver in the preoperative period to these patients. It makes the surgery more difficult. The drop-off rate on the wait list is around 30%, depending on which study you look at. So we have attempted a chemotherapy-only approach to neoadjuvant therapy for these patients, and we have achieved equivalent outcomes in terms of wait list time, overall survival, recurrence-free survival, as you've seen here. And this is a very small waterfall plot, but in terms of percent necrosis in the tumor upon an explant. So we're very proud of that, and that's been accepted recently for publication. Now, what about for intrahepatic cholangiocarcinoma? This is another recent meta-analysis published at around the same time as one for perihyaloid. For whatever reason, the culture has been antagonistic towards transplantation for intrahepatic cholangiocarcinoma. But this shows that there's an equivalent number of studies, 18 studies, again, no level 1 evidence, almost the same number of patients, 350 patients included in this meta-analysis, and the 3-year survival, again, at 55%. So I find it peculiar that there's an antagonism towards transplantation for intrahepatic, because in meta-analyses, the outcomes are equivalent. Now, what do you need to do to achieve good outcomes? I'm going to skip over that study, but this was a study from UCLA, which I think was very groundbreaking in this area. It showed that if you give both adjunctive therapies before and after transplant, as opposed to adjunctive alone or no therapies, you achieve the best outcomes. And we have also they have re-emphasized this themselves in a 10-year follow-up study, and we have shown this as well in a study from our institution that was published recently in the largest liver transplantation journal. And this is additional data from our center. That last paper was 2 years ago, so obviously our volumes have increased considerably since then, and we're able to show similar results with the use of both upfront and post-transplant therapy in order to prolong survival in our intrahepatic cholangiocarcinoma patients. So now what about post-transplant care? So the one caveat to liver transplantation is that you're receiving an organ from another person. The DNA, the RNA, the proteins are different. Your immune system will recognize those differences, and if in the absence of therapy to numb your immune response to the transplant, you will inevitably reject that organ. In liver transplantation, that doesn't typically occur very quickly. It tends to occur in a more prolonged fashion than with the kidney transplant, for example, in the absence of immunosuppression. But nonetheless, it will occur. And when it comes to immunosuppression, there are 2 general classes of agents that are used. One targets a pathway called calcineurin. Another one targets a pathway called rapamycin. The names are not so important. The important thing is that in vitro studies, and there is some human evidence to support this, the calcineurin inhibitors are thought to be pro-carcinogenic. So if you take them, it can increase your risk of cancer, presumably because it decreases immune surveillance for cancers. Whereas the mTOR inhibitors are thought to perhaps be anti-carcinogenic, because they are also FDA-approved drugs within that class, not the same drugs that we use for immune suppression, but drugs within that class are actually FDA-approved to be cancer agents, so chemotherapeutic agents for some other cancer types, renal cell, lung cancer, etc. So there's been a lot of thought about whether patients who are transplanted for cancer should take mTOR inhibitors as their primary modality of immunosuppression. There have been a lot of studies for that in hepatocellular carcinoma. I would say I'm enthusiastic about them, but the evidence is not conclusive. So if there is an effect size, it's small. This is the evidence for mTOR inhibitors and cholangiocarcinoma, very small series. There's a lot of preclinical data to suggest it might be useful. Now, we looked at our experience. As it turns out, for many reasons, insurance company, any approvals, etc., about half of patients get mTOR inhibitors after transplant and half don't. So I wouldn't describe this as a randomized trial, but it is sort of a prospective look at patients who are given one therapy or another. They are well balanced for their cancer risk factors. I'm not going to show all that data here, but this is actually out for review right now. And what we showed is that actually the patients who are treated with mTOR inhibitors, immunosuppression, have much better recurrence rate and overall survival. But I don't want anyone to get overly enthusiastic about that, because that's been shown previously in hepatocellular carcinoma, and subsequent studies were not as enthusiastic. So what is the quality of life like after liver transplantation? I think it's a very important thing to consider, because it's a very big surgery for people to undergo. Again, I made this on a Mac, and as with Dr. Newhook, it doesn't seem to have projected very well. There's supposed to be many more dots on this slide, but essentially every row is a patient, and every dot is something that happens in that patient's care pathway, and it's normalized to their date of transplant, which is the thick purple line in the middle. And what you can see is that patients before their transplant, there's a lot of dots. There'd be even more dots if they all projected. And after transplant, there are very fewer dots. So I take that to mean the quality of life is improved for patients after liver transplantation with cholangiocarcinoma than if they were treated by other modalities. We're very interested in exploring this further. I'm very fortunate to have a physician working with us by the name of Dr. Simon, who's interested in exploring this. So if there's anyone interested in participating in quality of life studies, we would welcome your participation in that. And then what is the future? We've heard about this already from our first set of speakers. Molecular profiling is very much the future. It is not, or if not the present. Certainly I'm for that. I did my PhD in this. And it has not made as many inroads in the area of transplant oncology as it has in medical or surgical oncology. We're hoping to change that. This is our experience with the first 30 patients in whom we did a liver transplant, and the tumor after the transplant was sent for molecular profiling. We found a very high incidence of prognostic alterations. What to do with that, is not quite clear. Actionable alterations in a quarter of patients. So if the tumor was still there, there'd be potential clinical trials that patients could be enrolled in. What actions you can take after transplant, we're still trying to sort that out. But we were able to find action. We were able to take action about 4 of our patients. So we're very excited to continue this program. We're hopefully going to move towards pre-transplant liquid biopsy approaches because tissue biopsies are relatively contraindicated in the area of transplantation. So hopefully this is where we're heading. This is a summary of the things that I've already said. So cirrhosis, unfortunately, a precancer condition. There's no effective screening currently for cholangiocarcinoma, but we're very happy to be working on that. I'm very happy that many intelligent people are working on that. The anatomical classification of cholangiocarcinoma can be challenging in practice, but fortunately for transplantation, it's not as important because of the surgical approaches that we take. Unfortunately, only a minority of patients are currently undergoing liver transplantation, and we aim to continue to ameliorate on that. 3-year survival for transplantation is quite good, but it has to be married with adjunctive care. And waitlist attrition has to be monitored. We're looking at that more thoroughly now at our own institution. There's limited evidence to guide immunosuppression, but I think an mTOR inhibitor is probably a good idea at the present time. And we're working on molecular profiling. So thank you very much. This is the team.
Thank you so much, Dr. Connor. The last talk for this session before lunch is defining the role of the robot in liver transplant by Dr. Yuli Chia. She is one of our transplant surgeons and heads the robotic transplant program. Thank you so much for coming, and looking forward to your talk.
Hi. Thank you so much for inviting me to give a talk today. Of course, the last talk before lunch has an IT issue that Dr. Here. Yeah. Okay. Thank God, let's help me sort this out.
Thank you.
My name is Yuli Chia. I'm the director of the Living Donor Liver Transplantation program at Houston Methodist Hospital. This talk is going to be about the role of the robot in liver transplantation. And just to warn you guys, there's going to be a video at the end. Where's Dr. Javed? He loves surgical videos, I just heard.
It's hard to get out, right? Yeah, I know. It's so difficult.
We got one.
Great.
So it's a full screen.
Awesome. Thank you.
I can just stay over next.
Okay. I think first we need to start by defining the role of living donor liver transplantation, or we'll call here LDLT. In living donor liver transplantation, a living donor is a healthy individual who volunteers to donate part of their liver to the recipient. And during the operation, a portion of the living donor liver is removed and then moved to the recipient and transplanted into the recipient after their diseased liver have been removed. By the numbers for liver transplantation in the United States, there are a lot of numbers here. I'll point you to the ones that we want to talk about. 25,000 people on the waiting list, 1,000 deaths on the waiting list per year, which means 3 patients die every day while waiting for a new liver. There are also patients who don't die, but instead they're removed from the waiting list because they become very sick. That's about 10% of the waiting list. And of these patients who are removed from the waiting list because they are sick, about a third of them will die within 60 days. One of the solutions to increase the number of liver transplantations and offer organs to patients in need is to do living donor liver transplantation. In the United States, living donor liver transplantations make up about 5% of all liver transplantations performed in the nation, the majority of which are related donors, but there are a significant number of directed non-related donors. LDLT is possible because the liver is the only solid organ in the body that regenerates, and this was shown in the story of Prometheus, who was punished by Zeus because he gave mankind fire, and he was chained to the mountain for centuries, and an eagle ate his liver every day, but the liver kept regenerating, so he kept surviving, only to have the eagle eat it again the next day. In modern studies, this is a study on regeneration of a living donor liver, and it shows that living donor livers regenerate to up to about 100% 1 year after donor surgery. Now, the living donor is a very special individual because they're healthy individuals who are willing to accept risks to their own health and life in order to save another person's life. Donor safety is paramount and well-being should be optimized. This is a post-donation quality of life where they survey all living donors who have donated the liver 3 to 10 years prior. And it shows that in 15% of patients, they report poor bodily pain scores after 3 to 10 years after the donor surgery. And of these population of patients, 22% complain of hernias and 9% complain of incisional discomfort. This is another quality of life survey of living donors, and it shows that these are some of the symptoms that they tend to complain about, and about 34% of them actually complain of incisional discomfort because of those 2 incisions that you see before. And despite all these physical symptoms, when they are surveyed, 85 to 100% of donors say they would donate again because they are incredible people. Now, is post-donation quality of life better with minimally invasive surgery? Minimally invasive surgery means, another word for it is like keyhole surgery, either laparoscopic or robotic surgery. This is a study by our colleagues in Korea where they evaluated donor wound satisfaction after laparoscopic donor hepatectomy. As you can see here, this is a conventional L-shaped scar, this is the upper midline, and then this is full laparoscopic. And they showed that for a body image scale, the cosmetic scale, and self-confidence scales, the laparoscopic group performed much better than the open or the modified open group. So what about robotic living donor hepatectomy? There are several centers in the world that have reported series of totally robotic living donors being performed. And they span Korea, Taiwan, Saudi Arabia, India. And they have generally reported pretty good outcomes so far, and definitely outcomes that are comparable with open donor hepatectomy. This is the outcomes so far. We have 34 patients of totally robotic donor hepatectomy, and our complication rate is 17.6%, of which most of them are minor complications. We have 2 patients of 5.9% of major complications. This is a 19-and-a-half-year-old donor who donated his left lobe to help one of his friends, and he returned to school within 2 weeks. He had a totally robotic left lobe removed. And this is one of our recent patients who also donated to his friend. He donated his right lobe, and he returned to work after 12 days, which was a bit of a shock to me, but that's what he did because he felt so well. What about the learning curve for laparoscopic versus robotic living donor surgery?
Well, when we evaluate learning curve in surgical practice, we generally look at this thing called a Q-sum curve, which is a curve here like this. And basically, when you start learning a new approach or a new surgical procedure, the slope goes up until it reaches a point where you have met proficiency. And then after that, you can continue to mastery. Sometimes there's a dip as you accept more complicated cases, and then you achieve like mastery somewhere along here. So the laparoscopic learning curve was also evaluated by our Korean colleagues at Seoul National University Hospital, and they found that for laparoscopic right donor hepatectomy, which is probably the most difficult of donor hepatectomies, it took them about 60 cases to achieve their learning curve. We evaluated our own robotic learning curve for right donor hepatectomies, and this is a combined study between our friends in Korea and us. They had their name center 1 and their name center 2. And we found that for them, their learning curve was at about 17 case, and for us, we were at about the 9th case. Why were we a little bit faster? Because we learned the procedure from them. So they already knew all the different tips and tricks to make the operation go a bit faster. Now, this is a case I want to show you. This is a 19-year-old young man who donated to his ex-classmate, a 23-year-old who had PSC. This 23-year-old had a PSC and had a MEL score of about 18, but what was worrying us was he was decompensating a little bit faster than we expected, and we were very concerned that he was about to develop cholangiocarcinoma, which, as you know, is a complication of PSC. So when this young man met his sick friend at a reunion and was shocked by how bad he looked, he immediately offered to be a living donor. So we evaluated him. He passed the donor evaluation process, and because his friend was a smaller size, his left lobe could fit his recipient. Now, how much liver a recipient needs is highly dependent on their body size. So someone like me will probably need something smaller. Someone like Dr. Ashton Connor will probably need something bigger. So what we do is we do a 2D reconstruction of the donor's liver to look at all the vascular structures so that we can plan our resection. And we also look at the volumes of the left lobe and the right lobes. And this is the bile duct. You've seen the portal vein, hepatic artery, and the hepatic vein. So this is the proposed graph here, the left lobe, which will leave him with quite an adequate amount of right lobe left. So we start the operation by dissecting the top of the liver near where the hepatic veins drain into the IVC. So this is the IVC here. Some of the hepatic veins are seen here, and this is the liver. So this is right at the top of the liver. Some of these veins will have to go with the graph, and I'm marking the top of where I'm going to start cutting the liver later. Next, we're going to mobilize the left lobe of the liver from the back attachments. This is mobilizing the left lobe from the caudate. Again, you see the IVC here. We're just releasing some ligaments here and creating a space between the left hepatic vein and the posterior aspect of the left lobe, because this is where we're going to aim for our dissection during our horizontal transection. A gallbladder is removed. That's traditionally removed routinely with all donor hepatectomies. And now we have to dissect the blood vessels that are going to supply this graft. This is the artery here. This is the left hepatic artery, usually found on the left side of the hyrum. And this donor had one hepatic artery, which will make it a little bit more straightforward for recipient anastomosis. So this hepatic artery will be sewn into the recipient hepatic artery to establish arterial flow to the left lobe. These are some of the lymphatic tissues that we will cut away from the artery to make it easy for transection and reconstruction. Now we encircle the hepatic artery that's nicely cleaned out. And next, we're going to go to the second inflow of the lobe, which is the portal vein. And that is the portal vein here. We're going to ligate some of the branches. And you can see this is the robot instrument. I'm actually sitting remotely at the console in the same room. There's another experienced surgeon at the bedside helping me. Again, we are ligating some of the vessels so that we can free up a significant chunk of the left portal vein, and we're going to encircle it just like the artery. So those are the two things that we're going to ligate later to take with the graph. Now we're going to do a demarcation of the liver. We're going to know where the left lobe meets the right lobe, and we do that by injecting some dye that's going to create fluorescence like you see here. So there's a nice demarcation here. So we know exactly where we're going to cut. For ultrasound, just to make sure the veins are on the correct side of the transection line. And all this technology you can do with this robot. And then we're going to start splitting the liver between the left lobe and the right lobe using some of these energy devices that are available on the robot. Now, when we do the splitting, we actually do it without clamping on any of the blood vessels because we have to make sure that the graft continues to be well perfused with blood during transection. Our anesthesia colleagues will keep the CVP pretty low so that there's no excessive blood loss. And you can see there's not that much blood loss being seen here during a parenchymal transection with this technique. Now we slowly split the liver from the bottom all the way to the top. The liver gets a little bit thicker the higher up you go. There'll be some tiny little veins that we will have to transect. Usually we clip the veins before we cut them. Our assistant here at the bedside will provide suctioning help, irrigation help. I know there's a little bit of bleeder here, so we can suture pretty easily using the robot. This is pretty intuitive, which is also the name of the company. I don't work for them. Don't worry. So here we are. That looks nice and clean. So we'll continue along. These are some of the veins that you will see crossing between the right and the left lobe. So we have to carefully dissect them, clip them, divide them so that we can keep continuing to transect the liver between the right and the left lobe. Okay, so we'll continue transection and then I'll show you a little bit more of the... So now we're gonna divide the bile duct, which you can see there. Using fluorescence, it will show us the image of the bile duct without us having to do an actual cholangiogram. You see here, this is the left bile duct here that we're getting around. That comes with the lobe as well so that it can be, see right, left and right bile ducts there. So it can be re-anastomosed to the recipient because, you know, most of the time the recipient bile ducts will all be completely removed. It's in the case of PSC or cholangiocarcinoma. We're going to transect here. That bile duct stump is suture ligated later. You can see the nice single bile duct here for recipient anastomosis. Next, we're just going to finish transecting the lobe here by separating it from the caudate lobe. You see all the vessels are still kept intact here, so the liver is still well perfused, and we're towards the end of it, we're reaching the left and middle hepatic veins. Almost done here with transection. And then we're just going to encircle these veins here. Now these veins drain the left lobe and they will be taken with the lobe and they'll be sutured to the recipient's IVC to provide drainage to the graft. See here, all the vessels are kept intact. And now we're ready to take the graft out when we receive news from the recipient room that they're ready. So all the big vessels are either clipped or transected with a stapler. The graft is put in the bag, it's packaged up after it's flushed with preservation fluid and put on ice, and then it's literally wheeled into the recipient room. And here we're cleaning up, making sure there's no bleeding, suturing up the bile duct, and then we're going to leave a drain after we do an ultrasound to confirm that the vascular supply to the right lobe is still intact. And that's all I have to say today. Thank you very much.
Thank you so much, Dr. Shia. We'd like to welcome all of the speakers up to the podium, please, and then we'll take some questions before the lunch break.
Okay, so while everybody makes their way down, there will be a lunch served outside. You're welcome to take it into the room and eat here and chat, or conversely, there's some tables outside. Feel free to sit there as well, okay?
Hello there. I just have a question. I'm an ultrasound tech, and I'm just curious why there is no screening for cholangiocarcinoma. Is there anything on the rise or any talk about potential, like, I know I do HCC follow-ups every 6 months, but is there anything on the horizon as like we're getting more sensitive with ultrasound, or is it just we're not the modality?
There we go. All right, we found the button. I don't want to pretend to be an expert in population health. What I would say is that a lot of factors go into effective cancer screening. The most important, one of the most important is the incidence and prevalence of the disease. And cholangiocarcinoma is fortunately uncommon from the perspective of the general population, but from the perspective of screening, that's an unfortunate feature of the condition, is that it is uncommon. And so finding effective screening to find what is you could think of as a needle in a haystack, that is difficult. To find a test that can be used effectively in the entirety of the population or identify a rare condition. The other thing is, I mean, there's cost that has to play into that from the government's perspective or from whoever the payer's perspective is. Although, to be honest, from my perspective, I'd much rather pay for healthcare than pay for bombs or what have you. So I don't think there's any problem with healthcare costs. I think the more you spend on healthcare, the better it is. But that is my opinion. That's a singular opinion. Obviously, the majority opinion is that we have to be more conscientious of healthcare expenditures. It's been in the news lately. The other thing that I would say is that there's unfortunately a lack of effective biomarkers that can be translated into a screening test for cholangiocarcinoma. Cholangiocarcinoma is unfortunately lethal at a relatively small size, and biomarkers tend to be in higher abundance when there's a higher burden of disease. The proportion of the biomarker tends to be proportional to the burden of disease. So the burden of disease in cholangiocarcinoma is effectively relatively low. We talk about dangerous tumors being just 3 centimeters in size. So it's a very small thing. CA19-9 is not, which is the most commonly used biomarker, has not been shown to be effective for screening. And is not expressed by all tumors and not expressed in a sufficient amount by tumors at smaller sizes to be translated into an effective biomarker to be used at the population level. So unfortunately, there are many features of cholangiocarcinoma, both as a cancer and as a prevalence in the population, and if it's biology that are currently preventing the implementation of effective screening for the condition. You can focus on populations that are increased risk in order to increase the prevalence and the incidence rate and increase the cost effectiveness by decreasing the number of people in whom the testing would be implemented. People at increased risk are perhaps, for example, patients with primary sclerosing cholangitis, patients with cirrhosis are at increased risk. But there's, again, even when you look at just that population, the lack of an effective biomarker continues to hinder the development of effective screening in those patients. So there are a lot of barriers that need to be overcome.
I have 2 questions. One is radiation effective on peritoneal metastasis? And the second question is PIPAC available for peritoneal metastasis?
2 very, very good questions. None of us are peritoneal surface malignancy surgeons or practitioners here. I think, I don't know. Ethan, you want to answer that? We have an expert here. I just noticed you. And there's Eugene up there. All right, Dr. Coy's there too. So first of all, PIPAC, for anyone in the audience might know what she's asking about, is a therapy for the intraperitoneal, so your abdominal cavity. And I describe to patients that your abdominal cavity is a room and all the organs live in it, and the entire room has wallpaper. And the peritoneum is the wallpaper. So when the disease is advanced, unfortunately, it has escaped its local environment and taken up residence on the wallpaper. That is peritoneal disease. And PIPAC is when we can instill basically like a gas with chemotherapy or agents inside it that would bathe the wallpaper, similar to what's called HIPAC, which is a liquid form of chemotherapy to bathe the wallpaper to try to treat disease. We don't do PIPAC as of yet for peritoneal surface malignancies at MD Anderson, as far as I know, and that's an investigational therapy at this point in time for all cancers, let alone cholangiocarcinoma. And then with regards to radiation, I think we might hear about it later, but we have some experts that could maybe give a talk about that real quick.
Thanks, Dr.
May I make a comment?
Go ahead, Dr.
You know, both these Canadians here are younger and a lot smarter than I am, but I'm going to challenge a little bit of what they said. There is no screening for cholangiocarcinoma per se. but the screening we have is for liver disease. So, we have some young people who work with me and they've looked at the incidence of what we used to call fatty liver or steatosis. Almost half the patients have that. So, and if you look at sonogram, a simple sonogram, which costs like $100, I think I anticipate in the future we'll be doing those for a lot of our middle-aged patients, like we do mammograms for women to look at their livers, not necessarily for cholangio, but to screen for liver disease, to screen for risk of cirrhosis, liver cancer, things like that. I suspect it's coming. Screening for PSC, for cholangio and PSC, for want of better words, I use the word crappy, because the patients I see are on the screening program, And as for Dr. Newhook, again, a very smart, yes, much smarter. I have done a couple of patients, referred to them for HIPEC. Some other people have. The surgeons are very reluctant because the data is very limited. But I think if you find the right patient, I don't rule it out. So I've referred a couple of patients and done well, but it's something to learn.
HIPEC, peritoneal treatment in general is a complex thing that requires specialized centers, and obviously we want to offer that to patients with great response and a disease that's treatable, right? Obviously. But the question was PIPAC, which is a specific thing which is different than HIPEC. And then radiation is an important question.
For sure, I'll chime in on radiation. Usually they keep the radiation oncologist in the basement, so now we're up in the nosebleeds. But I think in terms of both radiation and IR-based therapies like ablation, on rare occasion, we are able to treat small spots or defined spots in the peritoneum. And I just sent off an email about half an hour ago saying, we're trying this more and more with some efficacy. So I think in the very select settings, oligoprogression, some spots growing, but everything else stable, it's something to consider. But as a broad rule, no, we don't often treat with local therapies in that way in the peritoneum.
Thank you to all the speakers. There was a couple of slides that I noticed about treatment post-curative intent resection for intrahepatic cholangiocarcinoma. And forgive my team here, because I always ask the question when I'm with you guys. But what are some of the considerations versus giving capecitabine post-resection versus continued frontline treatment with gemcitabine? I noticed there was one slide that showed capecitabine as sort of the standard of care post-curative intent resection, and then another one, I'm not sure if Dr. Trankow was on your study, but continuing gemcitabine post-resection. I'm curious there. And then if anyone wants to talk about it, I'm curious, how does the role of AI impact some of the studies that we're doing as well?
I think the question of capecitabine versus gemcitabine, Dr. Java is probably best positioned to ask that, and it depends a lot on the pathology report and the histology side as well. But,
Sorry, could you summarize in one line?
So the question is post-surgery, if they receive gemcitabine pre-op,
got it.
how do you decide gemcitabine or gemcis versus capecitabine?
Yeah, the current standard, the practical issue is that we're not going to get insurance approval post-surgery for maintenance therapy, for durvalumab. That's just how it goes. But the standard is still capecitabine or Zalora, like the BILCAP trial. So that's what we use post-treatment or clinical trial. But there's no real standard right now. I have a question for you, Rosie. Now, Rosie, you had a wonderful outcome. Unfortunately, most of my patients are not candidates for transplant. But if there's one lesson you have learned from this journey, what could you tell all of us and what could you tell the patients?
Well, I think that, as you saw in my story, when we took our show on the road, it was a story of persistence and continuing, even when you did not hear the answers that you wanted to hear. It's basically don't give up, continue to look for answers, to speak to people. There are significant differences between
institutions and obviously medical teams and so forth. So I always tell everybody, not just in cholangiocarcinoma, but in any health challenge, to, challenge what you hear and keep going until you, basically hear what you want to hear.
Do we have time for just one more quick question?
All right, one last question and then box lunch outside.
Okay, so I know at Methodist we see both, but is there any research to support doing RUS first duct-to-duct anastomosis in these patients with cholangio or PSC or those types of things to affect recurrence rates?
The question was what type of bile duct anastomosis to do? I couldn't hear the beginning.
If RUS would support like any reduced recurrence as opposed to doing the duct-to-duct.
I'm curious to hear Dr. Chia's thoughts on this as well. I would say that there isn't evidence for people, for example, people who undergo liver transplantation with either cholangiocarcinoma or with primary sclerosing cholangitis, which is a predisposing condition for which patients often undergo liver transplantation, but it does predispose highly to cholangiocarcinoma. There is no evidence that whether you should do a direct biliary reconstruction, so an anastomosis of the donor bile duct or recipient bile duct, or if you completely remove the recipient bile duct all the way down to the duodenum and then bring a loop of intestine up to the liver. We typically do in what's called a Roux-en-Y fashion, or there are other ways of anatomically reconstructing that to allow direct biliary drainage from the liver to the intestinal tract. The advantage of removing the entirety of the recipient's bile duct would be that you would, in principle, reduce the risk of developing new cholangiocarcinomas in the future. I would say that we know from a choledococele experience, which is another predisposing condition to cholangiocarcinoma, that even in that situation where you remove the entirety of the biliary tree outside the liver, you do not completely eliminate the risk of cholangiocarcinoma because there's always going to be some component of the biliary tree which is within the wall of the duodenum that will remain. And then if you do an intestinal reconstruction, that you are greatly limiting your ability to monitor the residual recipient duct because it is no longer amenable to direct endoscopic intervention. So there are theoretical benefits and theoretical harms to connecting it in two different ways. The other thing I would say is that typically when it comes to cancer, the cancer that you're most concerned about that threatens the patient's life is the cancer they already have, and not so much the cancer that they may develop in the future. I don't, for that reason, there probably isn't great evidence to my knowledge to support that.
I think it's more straightforward when you have cancer. Then the answer is you have to take out the entire duct. And sometimes when you're worried that your margins are still not clear, you take out the lid of the pancreas with the liver transplantation, right? You do a combined liver transplantation at a Whipple. And in Methodist, we've done about 5 or 6 of those cases where we combine a liver transplant with a Whipple in order to get clear margins. I think the controversy is when it comes to PSC without clear evidence of cholangiocarcinoma. I've been in an institution where we routinely resected the entire bile duct, or we go as low as we can in order to leave very little of the native bile ducts within the recipient, because there is a chance that he will develop more PSC in that 1 to 2 centimeter of bile duct left in the distal area, and he may develop then cholangiocarcinoma in that segment of bile duct. Now, we have a case in Methodist where there was a duct-to-duct that was performed on a patient with PSC. This was a deceased donor graft, and 4 years later, the patient actually presented with a biliary stricture, and that came back as cholangiocarcinoma. So that was a very interesting case, and we did a Whipple because it was diagnosed very early. It was a T1N0 tumor, and he's doing very well so far. So I think the controversy is when you have PSC, should you or should you not? And technically, is it more difficult to do a Roux compared to duct-to-duct? There is a little bit more complexity to it, but
All right, everyone. So here's what we're going to do.
Box lunches. Again, feel free to eat out there or come back in here. We will restart the program at 1 o'clock as scheduled. So we're going to cut into the lunchtime, but you can eat lunch in here during the afternoon session. There's going to be more networking time after So between 3:30 and 5. And there's a dinner tonight between 5 and 7.
Yes.
Okay, thank you.
Hey, let's see you good in person.
It's like so rare.
I know.
Thanks for coming.
Hey, how you doing? Good to see you. Well, I hope it comes out of it. It'll be loud.
Well, let's try the fantastic. Let's see. We'll talk about. Did you ever stop? We were talking about whether to stop that.
Bachelor of Science in Biology, and he's a retired sales representative with over 35 years of experience in the specialty chemicals industry, focusing on the pulp and paper and hydrocarbon refining sectors. Since retiring in 2019, Fred has dedicated his time, and I'll add talent, to volunteering with the Cholangiocarcinoma Foundation, serving as a research advocate and a patient mentor through the Cholangio Connect program. And I can say that once you meet Fred, you will absolutely love him and the people he mentors. It's a gift to have them. So, Fred.
Thank you, Lisa. I am not worthy. So I appreciate the opportunity to talk about my story, but the story isn't just about myself. My story goes along with my caregiver, my wife.
Recognize all the caregivers that are here today. Real quickly, I will overspeak, so I'm limited on time, but could we give a round of recognition if all the caregivers would stand up, please, including you? They have the toughest task by far. And I know Jill is just putting up with me for over 43 years. So let's get going. I was diagnosed in October
2019, I had a MRI performed after I had one of my annual or every 4-year kidney stone. I live in Mobile, Alabama, and there's a belt that runs from Mobile all the way through Georgia, and it's the kidney stone belt of the United States. We eat wrong. We eat a lot of calcium oxalate food, peppers, dark greens, drink a ton of coffee, tea, Coke, and as a result, I'd get kidney stones from underhydration. I went in and I knew I'd passed the kidney stone, but there was a large image on my liver. And a hepatologist at the University of South Alabama Medical Center said there's a very good chance that you have cholangiocarcinoma based on the location and the size. Well, needless to say, he was right. We had a biopsy performed, and immediately they scheduled me for a Baird port to get me on my journey. My first scan showed stage 4, and in Alabama, they don't recognize the metric system. We recognize, thank you, we recognize size of tumors based on inanimate objects. The big tumors basically 4 sticks of butter, the 17 by 7 by 8. Everybody in Alabama can relate to that. The other tumors are the 3 large ones are the size of Titleist golf balls. And a disclaimer, I'm not paid by Titleist or Land O'Lakes butter. I'm getting no royalties for these comments. So, and then I had a little over a 2 centimeter in my L3 vertebrae, a couple spots in my rib and my pelvis. So, and possible, they suspect in my lungs. So ready, set, chemo. The standard initial treatment for cholangio is, at the time, Gem-Cis. Alabama, you know, there are 8,000 of us at the time recognized as being diagnosed. I did the math. Lower Alabama, where the Mitchell Cancer Center is, I calculated that they probably see 3 of me in a year. And recognizing that, I took further action. In 2020, through the direction of the foundation, I got in touch with Malin Jobley, and my journey began. He was confident in my treatment, and they said, go ahead and run your course on Gem-Cis, which is basically what we do, and continue chemotherapy at USA Mitchell Cancer Center. And I received my scans at MD Anderson at the time every 2 months. Well, November 2020, and as we say in Alabama, no mo chemo. So I had to stop due to a combination of impact on my bone marrow, low platelets, low red and white blood cells, and Dr. Jobley had a plan. And the first plan of attack is to introduce me to Dr. Eugene Coy, to handle the large tumor in my liver, the Land O'Lakes sticks of butter. And I had 15 rounds over December 2020 of precision external targeted beam radiation. And it was very successful. Other than fatigue, I didn't know anything had happened. Let's see, in December, I had it and traveled home New Year's Day. After a little purge out time on the radiation and follow up with what's the drug I had for chemo? Whatever, it's not important. I started, and very fortunate that I was identified as being FGFR2 fusion mutation, which is kind of like winning the lottery in cholangiocarcinoma. Earlier in the end of 2020, pemigatinib was introduced as FDA approved. And April 2020, I went on to treatment for my FGFR mutation, and that Didn't shrink my tumor, but much like the chemo, it controlled things. And that is a victory when you control your cancer and doesn't spread any further. However, I'm a competitive person and I want to destroy the stuff, but I digress. So after multiple side effects, which I tolerated, by January 2022, my large tumor was now scar tissue. The radiation was very successful, and I can report at this time, it's half the size of it was originally, even a little less than that, and it is pure scar tissue. That large tumor has been destroyed. So I'm blessed that the FDA approved the second FGFR2 targeted therapy, futibatinib, also referred to as Litgobi. And after the 2 months on the drug, I had my first scans, and I'd had about 20% reduction in the size of the tumors in my liver. 2 scans later, I was down to 40%, and I love to push Dr. Javli. When I knew I got it as low as I did, I already wanted to do something different to destroy it. And I mentioned to him maybe doing ablation therapy, and he had already kind of had me down that path to schedule it. So I had in November those three tumors microwave ablated, and those tumors are now gone. As of this year, through most of my scans, I don't think a stage 4 can ever be described as NED, but my body is relatively free of any active cholangiocarcinoma, not only in my liver, but there's not a lot of hot spots in my L3 vertebrae, my ribs, and the last scans look encouraging, although I'm seeing some potential activity. I've been on futibatinib now for 22 months, which is, I can't say it's a record, but I'm living testament to the technology for FGRF2 fusion treatment. So, Jill and I are blessed. We've had a miracle, and it started with my first introduction to cholangiocarcinoma. Quick story. We are sitting there waiting to get the official word. My wife picks up Conquer magazine, which is a cancer magazine, and most oncologists have it in their office. She's reading about breast cancer and runs in her family, and when she finished it, she turned it over to the next page, and there was a 4-page article on the Cholangiocarcinoma Foundation. Pictures of both Melinda and Stacy, Lindsay, and Jill called it a God wink. And he set us on the path. He reassured us that I've got this covered. So I immediately contacted the foundation and talked to Melinda. She said, Fred, you need to get expert help, and recommended I go to MD Anderson in my journey with MD Anderson, with the godfather of cholangio here, Dr. Malin Javle, started my road to, for lack of a better term, kicking the can solidly down the road. After my Pemazir ran its course, he put me in touch with Dr. Eugene Coy, and these two guys are my miracle workers. I mean, I don't think I'd be here if it wasn't for that early responsiveness to handle my large tumor, because it was encroaching both upon my main common bile duct out of the liver, and then also a hepatic vein. So it's time to give back, and that's what I intend to do for the rest of my time here on Earth. I immediately, through some mentoring of my own, one of my mentors, which is Dr. Javle, contacted Patty and said, you know, Patty, Fred might be a good advocate through the Cholangiocarcinoma Connect program to be a mentor. And that's basically where I am now. I know I have several of my mentees here in the room, and I'm proud to be able to provide them any help I can. I actually also advocate as a research advocate. I've been Facebook illiterate until the last year, and I've found that there's a lot of great warrior websites for both cholangiocarcinoma, histotripsy, and all the new advances that are coming out. Participate on those. I've done several educational films through the foundation, and I've done a podcast through the University of South Alabama Mitchell Cancer Center, which I've been surprised at the response that I've gotten from patients, not only in the U.S., but also internationally. And I've got one mentor up there right now from Saudi Arabia who's getting some encouraging news on his father. So it's time to get back and continue that as I journey on. This is a photograph of all my current mentees in the U.S. And then obviously I've got a strong relationship in Saudi Arabia as well as in Ireland. And I lost one of my mentees, the red triangle up there in Birmingham, Alabama last week, which breaks my heart. So thanks. A lot of folks to recognize. First is the foundation. Couldn't do it without y'all. The information you provide is unbelievable. MD Anderson, that's my team here. Can't say enough about them, and they know how I feel about it. This is my team at the University of South Alabama Mitchell Cancer Center. I hate to say it, but they're learning a lot about cholangiocarcinoma through me. But that's a good thing. And they are in communication with Dr. Javle. I get blood work with them every month, an injection of Exgeva to help protect my bones. And that is Dr. Abdallah, Nurse Jamie, and our physician's assistant Jazz. So very, very proud of all the support they give me. One of the things with particularly FGFR2 fusion drugs, they do have the potential to impact your vision. And I have Dr. Stuart Ball in Mobile, who's a retina specialist. I see him routinely every 2 months. I think I'm at a 3-month schedule now, but there were times when he's really grasped cholangiocarcinoma and targeted therapy. It's very new to these physicians. And he talks to Dr. Javle if he has a concern. And there's been times when I've gotten off the drug for a week, 2 weeks, or right now I've reduced the dosage from initially 20 milligrams down to 16. I can't thank enough about the pharma folks, Insight, Penazir. It gave me over a year and a half of kicking the can down the road. And it followed right behind it with Tio and the futibatinib. And that's the first drug I've taken that actually shrunk my tumors. Everything else has been hold the game. And I'm satisfied with that, but I'm very competitive. I want to kill this bastard cancer out of my body. I mean, and I want that for everybody. So I like to be aggressive with the treatment. I'll push my oncologists to let's think outside the box. The hundreds of global cholangiocarcinoma researchers, and real quickly, I'm sure there's some out here, if you don't mind standing up for recognition. Without you, the development wouldn't be there. There's new treatments coming out the pipeline. Just in the past 5 years, I think you saw some of the charts that at the time, the only first-line treatment was GemCis. Now we got GemCis with immunotechnology, and you give us cholangio patients hope. I want to thank all the warriors out there, which I know many of them here. And our goal is to keep on fighting. And I'm doing that as a mentor with the Cholangio Connect group. And like I say, my last breath will be, thank you, Cholangio Connect. This is why I fight. When I started, there were only 6 of us. Now we've got, I lose count, Joe. but there's a bunch up there. And I'm not supposed to say it, but we're gonna have another grandkid coming up, so. I've gained a grandchild and a daughter-in-law, so. Here's a little sales campaign as I'm a salesman. I hope this is being recorded and people that have the means will donate to the foundation. You couldn't ask for a smaller, more devoted group to participate with to find a cure for this god-awful cancer. Fred's Dream Team. I grew up south of Green Bay during the Vince Lombardi years, so I think a lot of my drive to succeed is based on that. But I also, after football season was over, was a big basketball fan. And I was a huge Boston Celtics fan with Bill Russell and Casey Jones, Sam Jones, John Havlicek, Bob Cousy. And then later on came the Dream Team. So Fred has decided to start drafting his Dream Team. And I'd like real quickly to ask Melinda and Dr. Coy to come down because I got a little special gift. These are my inaugural first draft choices for my Dream Team. Melinda, I wasn't sure what team you like, but you're in Houston, so. Thank you. And I asked Dr. Coyne, he said he's a Dallas Mavericks fan, so. For better or worse. Yeah, no, it's better or worse, but I can't thank these guys enough. There's my contact information. Hopefully you have time to pick my brain. I'm a positive person, and we will defeat this someday. Probably not my lifetime, but we will do it. Thank you.
Thank you. I gotta say, Fred, you mentioned that, Fred, you mentioned that we learned that your folks in Alabama learned a lot from your case. Frankly, so did Eugene and I, because you're just such a smart guy. And the questions you ask, first he comes with his big spreadsheet, but the CA99 is going at this log, so what should the cancer is going in this way. So he's very mathematical and very analytical. And he brought it up that we are getting this FGFR therapy, but why can't I have liver-directed therapy? Why can't I have radiation in addition? So I think we learned a lot from your case that actually helped us manage this disease better. So thank you very much.
Okay, our next speaker is going to be Kirsten Hernandez. Kirsten is a hepatobiliary and pancreatic clinical nurse with the GI Colorectal Center at MD Anderson Cancer Center. She graduated from the University of Texas Medical Branch with a Bachelor of Science in Nursing in December of 2018. She worked initially as an inpatient orthopedic trauma nurse for 2 years prior to beginning her career in oncology. She has worked closely with the cholangiocarcinoma patients as an outpatient nurse since joining MD Anderson in 2021. She is currently working on receiving her oncology nursing certification and is a member of the Oncology Nursing Society. Thank you, Kirsten, for being here.
Hi, thank you guys for having me. So today I'll be going over managing biliary tract cancer treatments and their side effects. So I wanted to do a brief overview of the three main types of treatment. We have our chemotherapy, immunotherapy, and targeted therapy. Chemotherapy is non-specific, and it goes for really any type of cell that grows quickly. And it includes agents like gemcitabine, 5-FU, oxaliplatin, and it's often given in combinations like FOLFOX or gemcitabine cisplatin. Immunotherapy uses immune system functions to target cancer cells. It includes agents like antibodies, immune checkpoint inhibitors, and vaccines. The most common treatments that we'll see for biliary tract cancer will be durvalumab and pembrolizumab. Targeted therapy aims for specific mutations in the tumor itself, and these mutations can be found through molecular testing. The two mutations with approved treatments are FGFR2 inhibitors and IDH1 inhibitors. And I'll be going over the general side effects for all three treatments today. Starting with chemotherapy. So the most common symptom that patients will face while on chemo is fatigue. There can be multiple reasons why patients will develop fatigue. So it's very important to work with your team to identify what might be causing it, especially if a specialty referral is needed. Oh, it's quiet. I'm just gonna put it a little closer. Okay. Thank you. Is that better? Yeah? Good? Okay, great. So other ways to manage fatigue include getting your body moving with exercise, getting high quality sleep. Now it's starting to ring a little bit. Okay. Good nutrition and hydration, because nutrients are the building blocks for energy. And then if that doesn't work, medication can be considered, like low-dose corticosteroids for short-term, or psychostimulants like Adderall. Sometimes even after trying to treat the fatigue, it still persists. So it's important for patients to really know how to save energy throughout the day. So we aim to plan out the day, save important tasks for whenever you have the most energy during the day, and try alternating heavy energy tasks with light energy tasks. Pacing yourself, going at a moderate pace throughout the day to prevent burnout, or setting up a routine helps your body get used to day-to-day activities. And then resting when possible. So scheduling breaks between tasks, or if you can delegate tasks to another person, like if you have to do chores, maybe your kids can help. Doing that can help you catch your breath throughout the day. So the next symptom we'll talk about is nausea and vomiting. Nausea severity can depend on what type of treatment that you're receiving. Cisplatin is one of the high-risk drugs for nausea, so we'll often treat nausea through prevention. We'll do a combination of drugs to be given on the day of treatment to help prevent the nausea, and then manage any breakthrough nausea using medications like ondansetron or prochlorperazine. Some ways to manage nausea without medication include staying very well hydrated, avoiding strong smelling foods or fluids, because that smell can be a very big trigger for nausea. If you have to drink something strong smelling, you can consider drinking a cup with a lid and straw to prevent the smell from reaching your nose. Ginger can help some patients, like ginger chews or ginger tea. Sipping on carbonated beverages can help settle the stomach. And then for some patients, in combination with medications, acupressure or acupuncture can actually help. And I've put a little diagram on here for pressure points on the wrist that can help alleviate motion sickness and nausea. And there's even some bracelets that press on those points to help with motion sickness. Vomiting is managed very similarly. But the thing is, because you are losing fluids, it's important to keep an eye out for any signs of dehydration. So talk to your team if you start feeling lightheaded or dizzy, because you might need some additional fluid replacement. So for the next symptom, we'll be talking about diarrhea. It's important to keep track of loose or watery bowel movements, because it can also lead to dehydration. It's important to keep an eye on how often and how much you're going, and report to your team if you have any increased amounts, or if you have any additional symptoms like fevers or chills or pain. So to manage diarrhea, the most important thing is to stay hydrated. We want to aim for drinking plenty of clear fluids with electrolytes, not just water, avoiding caffeinated drinks because that'll make you go to the bathroom more, sticking with a bland diet, like a brat diet, and avoiding irritating foods and fluids like spicy foods, greasy foods, and dairy. If needed, you can also consider over-the-counter medication like Imodium, just following the instructions on the box. And if that doesn't work, again, talking to your team in case more medication or treatment is needed. Another effect that chemo can have is overall decreased blood counts, which is why it's very important for patients to get labs before and throughout treatment. For decreased red blood cells or anemia, it can make patients feel very weak and tired and sometimes even short of breath. Management will depend on the severity of the anemia and can range from iron supplementation through diet or pills to a blood transfusion for more severe cases. For decreased white blood cell count or neutropenia, it puts patients at a higher risk for infection. So it's important to practice, first and foremost, good hand hygiene. Avoid large crowds if possible, avoid raw fruits and vegetables, and wearing a mask, especially if you're around people that you think might be not feeling so well. If needed, it can be managed using an injection or a booster shot to help bring up your white blood cell count. And lastly, decreased platelets do increase the risk for bleeding. This is called thrombocytopenia. And because of the increased risk for bleeding, we want to watch out for signs like bruising, coffee ground vomit, tarry stools, and if needed, a platelet infusion can be considered. If your counts are persistently low throughout treatment, you might want to discuss with your team to see if a treatment dose reduction, a treatment break, or stopping treatment altogether might be needed. And you'll see with a lot of the side effects for the rest of the presentation, a lot of times the option is to take a break from treatment. So neuropathy is the numbness or tingling and burning sensation that patients can experience, especially in the hands and feet. It usually happens with treatments that, like cisplatin, oxaliplatin, or platinum drugs. The severity, there are no preventions, unfortunately, but there are some tips to manage neuropathy, and that includes moderate exercise, like a progressive walking plan or a strength training program. Avoiding high repetition or high impact activities like running, chopping, typing, and using gloves when you're handling hot or cold items, or doing activities like washing dishes or gardening. If needed, medication like duloxetine can be prescribed as well. Sometimes with neuropathy, the symptoms can emerge or even worsen even after stopping treatment. So it's important to keep that in mind. So next is our immunotherapy related side effects. And just as a reminder, immunotherapy are treatments that work with your immune system to fight cancer cells. So in a normal setting, immune systems will often trigger inflammation as part of the healing process. Since immunotherapy can increase the immune response, there's also a high chance for different body systems to become inflamed. This is known as an immune-related adverse event. Because any body system can be affected, it's important to know what your normal is. How often are you going to the bathroom? Do you have any pre-existing conditions like asthma or colitis or IBS? Because these things can get worse while being on immunotherapies. Knowing your baseline also lets you report to your team if you're noticing any changes or worsening symptoms. And it can be managed by treating the symptoms or a course of steroids, either IV or oral. And severe cases may need a referral to a specialist, like a gastroenterologist, ophthalmologist, or pulmonologist. This is just a diagram to show the different types of immunotherapies can have different IRAEs at certain points throughout treatment. So moving on to targeted therapy, these are the treatments that target mutations in the tumor. Starting with our FGFR2 inhibitors. These are drugs that target the FGFR2 mutation, which can be, again, found through molecular testing. There are two improved inhibitors for cholangiocarcinoma, which is the pemigatinib and futibatinib. I know on the diagram here it also lists erdafitinib at the top, but that hasn't been approved for CCA just yet. So the side effects for these drugs can vary based on which type of drug you're taking. And it can affect your mouth, your skin, your eyes, and nails, to name a few. But because of the side effects, patients are monitored through regular lab work and a baseline ophthalmology appointment to catch for any changes in eyes throughout the system, throughout the treatment. As Mr. Neubauer mentioned, he works closely with his ophthalmologist because one of the rare side effects for this drug can be retinal detachment. So you want to make sure that we're keeping an eye out for that and catching any changes early. Be sure to notify your team if you notice any changes or worsening symptoms, of course. I think you guys will be hearing me say that a lot, especially if they start affecting your day-to-day life. I also wanted to touch on FGFR2-induced hyperphosphatemia or high phosphorus levels. This will require close monitoring of labs, again, throughout treatment. The management of high phosphorus levels kind of depends on the severity. So for our slightly elevated phos levels, we look at a low phosphorus diet, which in the next slide, I'll show an example of kind of different foods that we can look at and different substitutes as well. For higher levels, we can consider a phosphate binder like sevelamer to help take any excess phosphorus out of the blood and out of the body. It's important to note that you should only be taking the binders and maintaining a low phosphorus diet while you're on the FGFR2 inhibitor. If you need to take a treatment break or if you're scheduled in for a break from the pills, you do not need to be taking the binder or maintaining a low phos diet. Often patients will continue with the binders and sometimes their phosphorus levels will actually drop the other way, and we do not want that. Here is a diagram showing the different foods that are higher in phosphorus versus lower in phosphorus. You'll see there's a lot of foods to avoid, like processed meats, some seafood, nuts, and dairy. And substitutes could be more leaner poultries, almond milk, rice milk, and then, of course, sticking with lots of fruits and vegetables. It's also important to be sure that you're checking the labels on your foods because any ingredients that have the word phos in it, PHOS, usually indicate that there's going to be high phosphorus in it and should often be avoided. And for our last targeted therapy, we have the ivosidenib for patients with IDH1 mutations. Symptoms in this case can be a bit vague. I've listed them up here: nausea, diarrhea, fatigue. It can be rare, but ivosidenib can cause an abnormal heart rhythm known as QT prolongation. So monitoring throughout this treatment includes regular lab work, of course, and ECG at the start and throughout treatment. We also want to make sure that we're ruling out any other causes for symptoms first before making any changes to your treatment. Here's references. So in conclusion, for any treatment that you're receiving, if you start having symptoms that affect your day-to-day activity, talk to your team. While we want treatments that are effective and to work, we want to make sure that our patients can live a life that they're able to enjoy. Thank you all again for joining us today, and thank you to the Cholangio Foundation for inviting me to speak, and especially the Nursing Advisory Board.
Our next speaker is Amber Jackson. And Amber, I apologize, I did not get a bio for you, so I'm going to let you do an introduction. All I know is you are a social worker at MD Anderson, and we're so appreciative that you're here.
Hi, everyone. Thank you again to the foundation, as everyone has said, as well as our team and the GI Colorectal Center for inviting me to be here. I don't think I followed the instructions and gave that bio, so I'll tell you a little bit about myself. I am one of 6 social work counselors in the Gastrointestinal Center. I hold a bachelor's degree in social work from Louisiana College, and my master's degree in social work is from the University of Houston. I am happy to celebrate almost 4 years at MD Anderson next month, but I have spent the majority of my 19-year career in social work in healthcare, which is a real passion of mine. So I want to talk to you today a little bit about psychosocial support and mental health and how social work is a very important and active participant in the medical team for our patients. Okay. So just a little bit about social work at MD Anderson. We have approximately 90 team members that work throughout the institution. That varies and thankfully is increasing as all of our, our patient needs increase and the patients that continue to come and see us here at MD Anderson. We're positioned throughout the institution. We have social workers on the inpatient setting. So if someone is hospitalized, of course, in all of our outpatient clinics, in the ambulatory setting, in our acute cancer care center, our emergency center, and we even have coverage on weekends. So 7 days a week, 365 days a year, and that includes holidays. Social work is in the building to help support our patients with their needs. So, of course, as a focus of social work, we look at our patients. We provide cancer care for the whole person. We encompass the whole person, complete psychosocial assessments, because we know that cancer does not define an individual. In addition to this diagnosis and the challenges that our patients are experiencing and our caregivers, along with that, we're also managing family, jobs, insurance barriers, which is very challenging and provides a lot of anxiety for our patients. So we want to make sure that our patients know that they're not a diagnosis and they're not a medical record number. So we approach each patient individually. You may be sitting next to an individual that has the exact same diagnosis, has had a very similar treatment path, but we also know that your needs are individual and your experiences are individual, and we want to provide your care with that at the forefront. So the services that we provide and how we help our patients in social work, providing that psychosocial support as well as the emotional mental health care. We do supportive counseling for our patients, whether they're in a hospital bed or they're there in the clinic seeing providers. Because of the scheduling process, of course, that's kind of short term. If we have patients that need that longer term service, we collaborate with our psychiatry team, our supportive care team, or we can even refer patients, out to the community for that longer term support. Of course, touching on, stress, anxiety for our patients that have children, ages 5 through 18, we even have tangible resources that we can hand them in the form of these kid kits that are backpacks that have MD Anderson teddy bears, and they also have proven coping tools, including journals for teenagers or bracelets they can wear that talk about their emotions. If they don't feel like they can verbally talk about their emotions, their parent can know how they're feeling when they look at the bracelet they're wearing and address it later. So we also do, we have support groups that are facilitated majority by our social workers during the day. Some of them are in the evening times. They didn't bounce back in person after COVID, so they all are virtual. But you can certainly look into that on our website. And also we have support groups for caregivers. So it's not just our patients, it's also their loved ones, our caregivers, because we know in order to be a caregiver, you can't give if your bucket is full. So you need to take care of yourself as well. We do advanced care planning. Lots of referrals from the medical providers for medical power of attorney, living will, different medical advance directives. So we do help with that. Legacy planning for those individuals that want to do letter writing or passing down recipes for the next generation. So we have lots of tools in our toolbox and social work for that. And then of course, we do address end of life care, providing support to patients and caregivers, connecting with, should it be palliative services, hospice care, whatever that may be, that the medical team is recommending. For resources and referrals, this is such a big piece for me because I feel like I've built the best rapport with some of my patients through this piece. Because being here at MD Anderson, patients are not just in Houston, they're in Alabama, they're in Mexico, they're in Alaska. And so one of the bigger stressors is, how am I going to come to Houston? How am I going to stay in Houston? How am I going to pay for the hotel room for 3 months for, chemo, radiation, whatever it may be? And so this is a huge point of rapport building and We have lots of resources that we can refer out. Angel Flight that will fly patients across the country. The Hope Lodge is right up the road where we can make referrals to help with lodging resources. So this is a big component of what we do here at MD Anderson, along with the mental health piece. I know that this is a scary slide and it can be scary to think about or even hear, but unfortunately this is a reality for some of our patients that they experience, that they may have death ideation or they may have thoughts of suicide or wanting to take their own lives. So this is social work is frontline mental health for this. And so we're here in clinic, in the hospital, in the emergency room to address patients that may feel like they found themselves at in a position or in a point where they're not sure how much further they can go. So we do provide in-person, response to these and work with our medical teams as well as our psychiatric teams for any patients that may feel like they found themselves at a point of feeling like they cannot continue and maybe having some type of ideation. The points of vulnerability, in collaboration with our just really fantastic medical teams, we want to ensure that our patients know that their emotional health is a priority at MD Anderson. And so we have lots of feelings of guilt, of anger, fear, just being overwhelmed from a diagnosis, back to what I spoke about earlier of where am I going to stay and how am I going to get back and forth to Houston for my care? And so these are just kind of different points of vulnerability that our patients may experience. Of course, it's not inclusive. There's lots of feelings and experiences that they may have, but that skin anxiety number 2 there on the list, it's huge. I have one patient that's like, Amber, I'm okay. But when I have my scans, can I call you that week? Can we just talk? Can you just be there to talk me through it? Because I'm feeling hot, I'm feeling anxious. And while of course I can't, make any changes of what the result is going to be, and I can't necessarily take the full anxiety feeling away, we want them to know that we're here. And of course, helping with, validation of those feelings and that this is a normal process. And we're going to walk alongside you with your medical team, through all of those feelings that you may be feeling. And this is not just in person. Of course, we see our patients in clinic and in the hospital, but if you're back home, we can talk to you on the phone. Some of our social workers are included in virtual visits with patients. But then also my chart, some of our patients prefer, like, I don't have time to talk on the phone, or the phone is just not really, my avenue of communication. Email, my chart, we're there on all those points of contact to meet the patient where they are. I think a big thing too is to kind of help talk about, helping set expectations and boundaries, because sometimes patients come in and they may have a diagnosis. I spoke with a gentleman the other day and he didn't get the result that he had hoped for. And he was so overwhelmed with the fact of going back home, and all of his friends were waiting for an update because that's what they expect. And that's what he's always done for them. And he's like, I don't know what to do because I'm just not ready to tell them that I may not have surgery and I may need to have more scans done. And so just talking to them about putting themselves first and that it's okay and that our loved ones are going to understand, and, finding a way to set those healthy boundaries to ensure that, they are the priority. Their mental health is the priority. I'm very fortunate to work in the GI Colorectal Center. I am so glad to have landed there almost 4 years ago because the medical teams are just fantastic. They reach out to us, they communicate with us. It really is a well-oiled machine. And so we want you to know that if you're speaking with social work, that, we're also in touch with the medical team, or they've been in touch with us, and that we just want to ensure that, the care is as seamless as possible. So this is just, some examples of how we collaborate with the medical team. I've been in visits with physicians to be emotional support, but then also following up after, or even seeing a patient before. And so of course, helping coordinate and triage referrals to psychiatry or supportive care, some of our other team members that help with various needs for our patients. So lastly, I just wanted to say how we get referrals. Social work is referral based. And while we would love to touch every single patient that comes through MD Anderson, it just doesn't happen. So what I ask of you as caregivers, as patients, as providers, if you have someone that potentially has a need for social work, please reach out, talk to your doctor, talk to your nurse, call the Department of Social Work, because if there's a need, we want to know, we want to be there, we want to respond, we want to be involved. I tell my patients all the time, I would much rather you reach out to me and I have to be the person to say, right now, it doesn't look like this resource is going to work out, or right now we may not have, the funding to help with X, Y, and Z, versus you not reach out, and then we don't know that there ever was it. And so I'll wrap it up there. I think I ran through that kind of quickly, but I just want to let you know that we're here. And again, I thank the foundation, our providers in the GI Colorectal Center for including social work and realizing how important mental health is.
Yeah, go ahead.
Amber, sorry. Stop you. And Kirsten, if you guys want to come down, if there's any questions, we'll do a quick Q&A.
So just
before we switch over to the next panel.
Melinda, just to mention that the mics on your tables work. You just have to hold it down. When you want to speak, it will turn green. You have to hold it the whole time it's down. There are 2 mics up at the top. So if you want to ask a question, you can just go up to the top as well.
Thank you.
Any questions? And then I do. Kristen, for you, for side effects, what would be your recommendation? I hear from patients all the time about the side effects. When should they call the doc? Who should they call? Do they go to the, like, where do they start? Is there a pathway, and when should they be concerned?
You keep them ones and loyal to you, then ones and you grow with them. You ain't gonna be every day. If you want to go out and be
Hello? Oh, great, okay. Yes, so I just have a thing with quietly. Okay, that's a fantastic question. Again, one of the things that you want to keep in mind is what your normal is, right? Anytime you start noticing that you're straying away or you're starting to have worsening symptoms, if it's not emergent, like it's not something that is bleeding out like an emergency, sometimes it can wait until your next visit with your provider. I think if it starts affecting your day-to-day activities, like if you're not able to get up and work like you do anymore, or if you're not able to do the hobbies that you enjoy, it's time for you to mention something. And sometimes even earlier than that. It's always worth mentioning if you have any changes in your condition, especially if it's something that we can address early on, like neuropathy.
I have a question for Kirsten. Sure. So what do you do with, as a patient myself, you're afraid to report side effects because you don't want to be taken off of a medication or a drug? What signs do you look for, and how do you deal with patients that are apprehensive of reporting symptoms?
Especially on clinical trials. Well, so our top priority, I think, for all of our patients is that we want you guys to be safe. We want you guys to be able to have a balance between getting these treatments and still being able to live a good quality life. I know having to take yourself off of treatment is scary, but it's a matter of what's the risk versus the benefit. If we're going to continue on this treatment and you're going to have permanent side effects that you have to deal with for the rest of your life, it can definitely be scary, but sometimes it is a necessity.
Yeah, from a patient standpoint, to build on what Kirsten said before, as a new patient, when you first go through chemo, you don't know what you know. And you go through neuropathy, and you mentioned it, but little do you know, you ought to be a little bit more vocal about it early. I dread cisplatin. Cisplatin is a is a nasty drug, and that's what causes the neuropathy in your feet and hands early on. And they, if you don't say anything, they keep on keeping on, and you can adjust the dosage on that. And another issue I had that I didn't bring up was the steroids they give, which kind of induced me into stage 2 diabetes, and that can be just, I handled chemo very well. My body did eventually, but if I had gotten off of a high dose of steroid, I think it would have let me navigate a little bit longer until at least comfortably.
And that's another thing to consider too, is we often focus a lot on the treatments that we're receiving, but sometimes the medications that we take to help with the side effects from treatment can have their own side effects, like especially if patients already have constipation. Something on Dancitron can sometimes make that worse. So it's important to let your team know when you start noticing these changes.
And then I have a question for you. What, the journey is not the patient alone, but also the family. A lot of our patients are young, they have young kids. So what resources do you have for families and relatives affected with the disease?
So we in social, can you hear me? Okay. So we in social work not only provide support to the patient, but as well as the families. So spouse, adult children. We don't have we don't provide therapy directly to minor children, but we certainly do have resources that we can refer out. We do have those tangible resources that we can provide, as well as our support groups that we have. And so we have that active caregiver support group. And then our psychiatry team also now will see caregivers who are coping specifically with, who are having challenges coping specifically with the cancer diagnosis. And so that was a huge thing that's, I think, happened within the past year or so, that they could also provide the support for their loved ones as well.
Yeah, it's Green. I guess for the new patients and the caregivers in here, I just, I think it's really critical to really aggressively self-advocate as well, and for the caregivers to aggressively advocate as well. I know when I'm still going through treatment, and there really is no dumb question, and sometimes our physicians and the other folks in our network are really in their lane, and sometimes they welcome the outside questions that they may not have thought about. So as daunting as the diagnosis can be, it's really important that you come prepared to just ask anything and everything, as silly or as embarrassing or as strange it might seem. Just ask the question, and make sure your caregivers also advocate for you, because you may discover something new that wasn't discussed before, or another option. So it's really, really important to also advocate for yourself aggressively.
I have a question for social work. When someone comes from out of state, or can you talk to me about the housing and how they would know? You mentioned the Hope facility. Can you talk to me about how one gets that information?
Yeah, so the Hope Lodge is actually an American Cancer Society facility. So a lot of patients may be familiar with it if they're just doing their own research, but they also may not. So what we encourage is to please reach out to social work, because there are a lot of resources that patients are just not aware of. And Hope Lodge, for instance, requires a referral from social work. So we certainly do want you to reach out. That way we can work with you on when you have appointments, or like I've had patients that have called and said, well, Amber, I'm coming in February, but I'm really not sure. And I'm like, okay, well, let's keep in touch, because we have to have those actual appointments scheduled in order to make that referral. So what I tell my patients is, you call me, but I'm also going to put a calendar reminder to myself to call you as well. So in addition to that, there are community resources that help with hotel stays. I think I mentioned as well, Angel Flight that helps with free non-medical flights across the country. They're not alone. There's Corporate Angels, there's Mercy Medical. There are a lot of resources that some patients do find in their own research, because like this gentleman said, they're themselves or their caregivers are advocates, and they are going through it. But we certainly ask that you call, and that's our job, is to start digging through things for you as much as we can.
Thank you.
To add on to that, if you're ever not sure whether you should reach out to the team or to the social worker, ask your nurse. Our biggest job is to figure out, if we can't answer your question, which person we need to get you to. And oftentimes that includes me, so.
All right, very good. Thank you very much. Thank you. I'm going to call Dr. Kudali to come up along with Michelle Bell and Gina Garris for a special panel on transplant and navigating care at a tertiary care cancer center.
So we'll get started with the mini session before the break and the last session for the day.
Yes,
I think very important part of the patient journey.
Get the camera, the mics apart. Thank you.
Sorry,
Yeah,
sorry
thank you.
about that. Is also, once the diagnosis is made, navigating and trying to figure out where to go, who do you see and what to do. So we thought that this would be a very important topic to cover. So Jenna is going to talk about navigating care at a tertiary cancer center, and then Michelle Bell is going to talk about part of that, also what happens at a transplant center. So please go on. Thank you.
Can you hear me all? Thanks. Just want to first thank the Cholangiocarcinoma Foundation for having me and Dr. Jovli for holding me for this. I don't have much time to discuss this. Soon you'll discover I'm not a great PowerPoint maker, but I am a physician assistant here. I'm also an APP supervisor in the GI Medical Oncology Department, and I have a lot of experience with accessing our center and MD Anderson and helping patients planning for their first visit, getting the most out of their first visit, and continuing their journey after that first visit. So I just wanted to first cover what you'll see when you search MD Anderson. This is our front page, and in the right-hand corner, you're going to see a request an appointment. And that is the button you pick, and this will show up. And basically, you'll put in your normal information, including your diagnosis information. This is really important because it is going to provide our patient access centers the information that they need to put you in the correct clinic with the correct specialists, providers. So most of you will be picking at least the gallbladder bile duct cancer diagnosis, but some of your answers may be different as far as what are you interested in. There's some other options, and if you have a confirmed diagnosis but have started treatment, there's also options to pick there as well. Of course, you'll put in your insurance information so that that can be further evaluated. So just recently, our institution has implemented patient navigation, which we're hoping will improve the new patient and established patient experience. We have a pre-intake navigator, but we also have an intake navigator, and they are going to be helping you collect your necessary medical records so that your team will have what they need when you are seen during your first visit. But I quickly wanted to go over what your team is going to be interested in having for your first visit. Also on the front page, you're going to find how to prepare for your first visit. And that is going to be very instrumental, but so you can kind of peruse that on your own. But having my chart set up is very important. A lot of the teams, their only communication, or the majority of their communication with their patients, is going to be via my chart. You'll get notifications of appointments, appointment changes,
You can glean result data from that. So you definitely want to get my chart. So now we're going to go to what medical records your physician will want. And while this can vary from team to team, universally this is pretty true. Your team is going to want your pathology results, confirming your diagnosis via a biopsy, a brushing, or even surgery. So not only your report, but your actual tissue to confirm here at MD Anderson the diagnosis, because we have certainly had some disagreement with outside pathologists and want to make sure that you are in the correct place. Scans, not only the scan reports, but the actual images, so that the physicians and team can review for themselves what has been going on prior to treatment, during treatment, your most recent imaging, extremely important to the team so they can help make the best next treatment decision for you. Most recent lab results, including blood counts and your chemistries, especially liver function tests, kidney function tests. You all probably know those are really important when you are diagnosed and need treatment. In this new age of genetic testing and genetic sequencing, that plays a key role in treatment planning as well. And if you have had that done prior to coming to MD Anderson, we definitely want to see those results. And if you have not, then you'll likely be having that testing done. So a lot of our patients, and I think this was touched on previously, are not local. They are either a few hundred miles away to a few thousand miles away. So I just wanted to give this breakdown on how we try to help logistically with patients who are not going to be receiving care at Anderson and just coming for intermittent scans. Now, I will tell you that typically we want our patients to undergo treatment, if at all possible, regarding surgery or radiation here at Anderson. But if they are going to be doing chemotherapy for any period of time, we certainly are happy to coordinate with local physicians. So big picture items are when you're getting hooked up with a local physician, my best recommendation is to ask friends or family members. You may ask your physician at MD Anderson if they know anyone close by, but chances are they won't. So having someone trusted that your friends and family members have used before, that they felt very comfortable with, is a really good place to start. That physician will be managing your day-to-day care, and your MD Anderson team will be managing your big picture items. So say you go home and you receive 4 cycles or 6 cycles of chemotherapy, and then you come back to MD Anderson where we do the scans, we do the lab work to see how you've responded to treatment, and then make kind of the next step in plan is kind of what our role is. You certainly can reach out to MD Anderson. I think Kirsten kind of mentioned this. We want to know how you're doing. As someone who answers a lot of my chart messages, we truly want to know if there's any change in status. We don't want to find out 2 months down the road that you've been taken off of treatment and we didn't know because you were having a side effect. So please keep us up to date. But again, your local doctor is going to be responsible for like day-to-day changes. If you have any updated medical records from your local team, we definitely want to see that as well. Bring that to your visit. So any scans, the results, and the imaging would be great. I think I wanted to also harp a little bit on just being an advocate for yourself. Oh, that gentleman left, I think. Being an advocate for yourself while you're trying to get into Anderson, and when you are an Anderson patient, staying at the forefront of your care or having your caregiver stay at the forefront of your care. And I tried to do that as speedy as possible. I think that's it. We'll have time for questions in a moment.
That was great. Thank you, Jenna. I'm going to ask Michelle Bell, who's the manager of clinical operations for the Liver Transplant Center at Houston Methodist, to share a little bit of the steps that are involved in when a patient gets referred to us, the transplant path, and other things that are important. Thank you.
Hi, thank you. Thank you so much to the Foundation for having me and Dr. Kadali for asking me to speak today. So yes, very quickly, we just wanted to kind of give everyone a brief kind of overview on how things work at our center. So here we have our team. This is our J.C. Walter Jr. Transplant Center team, and also our Sherry and Alan Conover Center for Liver Disease and Transplantation team. Several members are actually in the audience today. Okay, so our liver cancer program, which functions under our Center for Liver Disease, we have a dedicated liver cancer clinic. Dr. Sudha Kadali is our director, and in this clinic, we actually have a multidisciplinary team with oncology, hepatology, and our transplant liver surgeons. Every week, we have a multidisciplinary tumor board that meets to review imaging and determine best treatment plans and make recommendations. We also, any patients that are deemed appropriate for liver transplant, we can funnel and refer directly to our J.C. Walter Jr. Transplant Center. A little bit about a referral process. So either a patient can self-refer or the actual physician office can contact our referral center. This is the main number here. We also have information on our Houston Methodist website as well. Step 2 will be insurance clearance. So we make sure that insurance-wise, you're good to go to come to Houston Methodist. Just sort of an update with some challenges that we do have in regards to cholangiocarcinoma. So currently, Medicare, Community Health Choice, Blue Cross Blue Shield, and Cigna do not cover transplant for a diagnosis of intrahepatic cholangiocarcinoma. We are actively working, actually our center has put a proposal together to Medicare to try to get this adjusted. So we are hopeful that soon Medicare will change that, and with that, we hope that we'll kind of have a domino effect to some of these other insurance companies that do not offer coverage. The next phase is we do request imaging and medical records, so our team can review and also present to our tumor board conference so we can look and see exactly what's going on and the best course of action. You'll then get an appointment in our liver cancer clinic, which we will collaborate with your local oncologist if you already have one. We work very closely with the MD Anderson team and partner with them and actually have weekly meetings with them to discuss our cholangiocarcinoma patients and make sure everybody's on the same page for treatment. If you don't have an oncologist, then we will refer you to one and make sure we have them on board. Next, kind of out of that plan, if you're deemed transplant eligible, then we will refer you to our transplant center for a liver transplant evaluation. Or if transplant is not an option for you, we'll make sure, like we said, you've got an oncologist on board and we discuss treatment plan options such as chemo, radiation, and local regional therapies. This is just a brief kind of quick overview. I won't go super deep into this, but just so you kind of see if transplant is where you're headed, this is sort of an overview of what that evaluation process looks like. It is done in a couple of days where you'll meet with our entire transplant team, undergo some testing and workup, and then ultimately be presented to our medical review board to determine the best next steps. I think, you know, the big thing with this is that we want to make sure that we're doing the best for the patient and that we find the best treatment option, and that doesn't always look the same for every patient. Some sort of statistics for transplant. So at Houston Methodist this past year, we've done 249 liver program in the region and the #2 liver program in the nation. This year, in 2024, we are right now projected to do about 290 liver transplants. Our first transplant for cholangiocarcinoma was in 2012. And since 2012, we have actually done 100 transplants for patients with the diagnosis of cholangiocarcinoma or intrahepatic cholangiocarcinoma. Here you can see the breakdown of our cholangio transplant volumes. Dr. Connor spoke just a little bit on this, and you were correct. We are at 19 year to date, as I pulled this 2 days ago for 2024. But you can see since we started in 2012 with our very first patient, who is still alive and well today. She's very involved, not here today, but very involved in the Cholangiocarcinoma Foundation, our program. But we went with one, and you can see we've slowly been trending up to this. So we really hope that with our team's effort, our research, our ability to transplant more patients, that we can also work towards getting the insurance companies and things on board for this. Another little tidbit too is for liver transplant. UNOS has changed some guidelines. So now for a diagnosis of hilar cholangiocarcinoma and intrahepatic cholangiocarcinoma, if you meet certain criteria, you can get exception points for your MELD score. So what that is additional points kind of on the list to help you get to transplant faster. So that's really exciting. Okay, and that's it. Thank you.
That was great, Michelle. Thank you for sticking to your 6 minutes allotted time. We'll take some questions. Both actually summarized very well the process and how patients go with the patient versus to us. Similar to actually have options. Want to see if anybody else has any questions.
Why had that to a five-star restaurant?
I have a question. So, Gina, you know, what you do is very smooth and very natural, but it's not natural to many patients. If you're being treated in the middle of Texas, you have an oncologist over there, and then you have an oncologist here. They're seeing Dr. Krankau, a surgeon. And so how does this, what do you tell your patients? Like, how do you navigate that?
So we're very lucky in that we often have very open communication with local oncologists. So what we typically will recommend is either a APP, so that's our advanced practice provider, or our physician will actually call your local oncologist, or the local oncologist can call them and give them their cell phone number and have an open conversation about what's going on locally with you. But usually that will take a step by the patients. So I know that may be a burden that you don't necessarily feel that you need to have, but sometimes that will have to be initiated by the patient, and that's just kind of a cruel expectation.
So patients often ask me, I'm getting referred from MD Anderson, I'm going to be here at Methodist for the transplant testing. How do you guys navigate through this process? And I'm going to see you all different times, especially for other state patients. And I always tell them that, we've developed this partnership over years. It works really, really well. We try to avoid multiple unnecessary visits, scans, blood work, etc. We work with our interaction team very well. So for example, if a patient gets a scan there, we just request a scan and we review them. We also look at the blood work that everything is available every day. So it's actually a much smoother process once you're referred. But of course, I think the initial process of getting referred and trying to figure out who the doctor is seen where, I think that's really more stressful and for the patients. But I think it's fantastic that we have two hospitals like across each other that we
Yeah, and the teams are always in close communication. You may not believe that, but we have each other on speed dial, so to speak.
I know onion chips. What's this?
All right, thank you very much to this panel. Unless there's other questions. Yeah, please, go ahead.
So do most patients list with
more than one institution? And what are the benefits and downfalls of that?
That's a great question. So typically, if it's a patient from out of state, they can be listed in 2 different centers and they can get an offer from any center. But if you're in the same region, it doesn't really help a lot to be listed in 2 different hospitals across the same state or same institute. So we tell patients that they're happy to put them to another evaluation or get them listed, but there's really no benefit in that case. But for out of state patients, yes, they can be listed at more than one center.
To come to MD Anderson next week. And the reality is it's not necessary. These are wonderful places, you know. I think cholangiocarcinoma and biliary cancer is better treated at a tertiary center. And of course, I like Anderson, but it doesn't have to be us. If they go to 2 places and 3 places and 4 places, it's an unnecessary expenditure of resources and time for everybody, and it delays their therapy. So it's best to get, if they come from Cleveland Clinic, Lisa is there, I refer them to Lisa, she'll navigate. They can get good care there, and they're welcome to get a 1 or second opinion. But, you know, we don't have anything great that each institution will offer multiple opinions. Yeah.
I'm going to disagree with that. I'm sorry. And Rosie's story is a perfect story. She went to 4 different places, and on the last place she went, she had a completely different experience. And I think Melinda would agree, we have many, I'm not saying that all of these centers aren't good. They all have good things. But if you feel like you need to go outside of your center to find something, then you should. But the other thing I will tell you, and I see this often because I'm on text threads with a lot of the clinicians, is I see them reaching out to each other. If Millen doesn't have something here for you, he's reaching out to Mayo, he's reaching out to all his colleagues at the others. Does anyone have something for this patient? Here, do you have something? And I see them all doing this all the time. They are working for you behind the scenes, not just with what they have available at their institution, but outside their institution.
Very good. Thank you very much. Okay, we're going to move into our last session of the day. I'm going to ask Dr. Coy and Dr. Zhang to sub in for Dr. Saharia to moderate this session focused on liver-directed therapy.
Go ahead.
You want me to pull up your slides?
No, I got it.
I don't even have no competition out here no more. It's all, nobody knows.
Well, thank you, everybody. It's been a fantastic
outfit with the joys. Come on, family, put it together. It don't blink.
Agent Coy, I'm one of the radiation oncologists here at MD Anderson. And our first speaker will be Dr. Cholangiocarcinoma speaking about historytrypsy, which is the suite du jour.
Okay, again, thank you very much, everybody, for being here. Hope you've learned some things. And I'm going to talk about historytrypsy. Who in this room has heard about historypsy? Yeah. Right. That's a hot new thing, right? So really, this talk here is about clarifying for you some of the facts about historypsy, what we know about it, what we don't know about it, which is a lot, and then where we go from here. So I'm sure you've seen articles come out either in the news or your local kind of media about historypsy, including one piece here about MD Anderson. We acquired the historypsy machine earlier this year. We have started using it. So the question really is, what is historypsy? So historypsy, really, it's about breaking down tissue. And it is a non-invasive technology that uses focused ultrasound energy to mechanically destroy tumors. So this is not about generating heat to destroy tumors with thermal energy, like the HIFU system or the ablative techniques that we have. It is mechanical destruction. It was developed at the University of Michigan starting in 2001. So it's been a 20-year kind of process. Histosonics is the one company that has the system commercialized now. It's the Edison system, which you see there on the screen. they gained FDA approval in October of last year for treatment of liver tumors, very broadly speaking. How does it work? So what you see here on the screen is the treatment head. It is a focused ultrasound energy that is produced by this treatment head, transducers essentially, that then converge ultrasound energy to create pressure within the targeted tissue that then causes gas bubbles to expand and collapse. And in turn, what that does is that it stretches and then ruptures the cells, causing what we call acoustic cavitation, mechanically destroying and liquefying the targeted tissue at the subcellular level. There is no denaturation of the tissue, so there is preservation of antigen-presenting capability. As I said, it is different from HIFU. Some of you might have heard of HIFU in the past, where people used to try to use ultrasound energy to destroy. That unfortunately kind of didn't really work. Again, that mechanism was really focused on thermal destruction of tumors, and it didn't work very well. Histotrypsy uses a different type of energy, still ultrasound-based, but to create mechanical destruction. So to talk you through the process, what happens is the patient still comes to a setting where they have to be under anesthesia, intubated, oftentimes paralyzed, and that's because you want the tumor to stay as still as possible while you're delivering the treatment. You're gonna lie on the table, and then while you're asleep, an ultrasound is used to detect and start treatment. And during the treatment, essentially these ultrasound energy is delivered to the targeted region, and there's a live picture that shows you the treatment in effect under ultrasound visualization. Once you complete the treatment, you can see that the treatment zone corresponds very, very precisely to your mapped out zone. And over time, what people have studied this, what is generated from the destruction from histotrypsy is an acellular lysate. Everything is kind of liquefied and turned into this kind of soup without any kind of live cells within it. And over time, the treatment zone will involute over time and shrink to scar tissue. So what has led to the FDA to approve this technology? 2 studies, and both of them very small, both of them very, very basic, both being a feasibility trial more than anything. So the Teresa trial was 8 patients, 11 tumors, including 1 patient who had cholangiocarcinoma metastases in the liver. The primary endpoint was technical success defined by, on imaging post-op day 1, showing an MRI that shows that the treatment zone corresponds to what you had planned for it. And that was 100% successful in 11 tumors. The secondary endpoint was safety, and there was no adverse event or that was serious related to the histotrypsy. Now, keep in mind, follow-up period was only 8 weeks, and the median histotrypsy zone was only 2 centimeters. So for Fred, that means a big peanut for you, okay? 2 centimeters, so not very big. The second study was a whole for liver study. This was conducted out of Europe and the US, 44 patients in total, 49 tumors in total. The primary endpoints, again, were technical success and 30-day procedure-related complications. So again, you can see here on the screen, you start with identifying the tumor, you map out your treatment zone, you treat it, and then this is after treatment, you can see that the treatment zone corresponds pretty well to your mapping treatment area. So how did they do? The primary endpoint, again, was technical success. They set their goal at 70%. They reached 96%. Safety, they set their goals at 25%. Safety, meaning complications, procedure-related major complications, they had 6.8%. So on both fronts, they were successful in achieving their goals. So on the basis of these 2 studies alone, simply based on technical success and simply based on safety, it gained FDA approval. So the experience for histotrypsy so far, you can see here, this is as of November 14th. I got these numbers from the company itself. They've treated 611 patients. They're available at 29 institutions, including us here at MD Anderson in Houston. You can see that the users are primarily surgeons interventional radiologists, and 1 radiation oncologist. And up to now, it's 56, although the updated number is 71 cholangiocarcinoma tumors. And most of the tumors are in segments 3, 4, 5, and 6. So on the right side, that's the mapping of the liver for you. And you can see that most of the tumors that were treated were in the 3, 4, 5, 6. And the reason for that is because 3, 4, 5, and 6 are part of the liver that are showing beneath the rib cage. So let's go into the limitations of histotrypsy. You can only treat what you can see on ultrasound. And because of that, bony structures like the rib cage will get in the way. There are ways to kind of mitigate that. You can put the patient at a different angle. You can go between the ribs, but it does present challenges. Also, gas will deflect and interfere with ultrasound transmission. And so if you have the lungs in the way, if you have gas-filled organs like the bowel in the way, you're going to have a hard time treating successfully the tumors. There's other limitations, depth limitation. So the ultrasound waves do have a limitation as to how deep they can penetrate. So it'll go from 2.5 centimeters from the skin surface or the skin layer with the abdominal wall down to 14 centimeters. And 14 centimeters is reaching. Size limitations, really, the treatment zone is not really intended to treat huge tumors. So in general, small tumors less than 3 centimeters are what's best treated. And then, like I said, very limited data beyond safety, beyond feasibility. We don't have long-term survival data. We don't have long-term outcome data. That's very important to keep in mind. That said, there is no question that this is a very enticing and promising technology. For one thing, it does seem to have preservation of collagen-rich tissue. So whereas we cannot ablate a tumor with heat near a bile duct because you're going to cause entry to that bile duct, there seems to be safety in using histotrypsy for tumors near a bile duct because the bile duct will be preserved. Now again, no long-term data to support that, but in preclinical models, animal models, that's been the case. So again, this technology may allow us to treat tumors near critical structures that we want to preserve. And then this is probably the hottest kind of thing that people hear about. I think the thing that gives people the most hope, but also is really overblown to this point, I have to say, is this abscopal effect. Abscopal effect means you treat one tumor with histotrypsy, and then the non-treated tumor, the off-target tumor, start shrinking, start responding. And the thought is that histotrypsy releases antigens that then allow priming of your immune system to better fight the cancer. This was proven in preclinical model immunocompetent mice where they measured CD8 cells and things like that. And they showed that, yeah, it seems like by treating one tumor with histotrypsy in the mouse, the other tumors may be able to shrink. And this is the mechanism. It reduces immunosuppressive cells. It does seem to enhance immunity in the tumor microenvironment, as well as systemic anti-tumor immunity. In the patient, however, there's been only one reported case out of all the cases that have been done so far that has documented this abscopal effect. This is the case in question as part of the Teresa trial. They treated one tumor, and you can see that the yellow, the green, the blue arrows point to tumors. A is before treatment, panel B is right after treatment. You can see that those tumors that are highlighted by the arrows show some enhancement around them, and then subsequently they start shrinking. And you can see that the tumor marker, the CEA, also started going down, suggesting that there is something to it. And importantly, this patient didn't get any systemic therapy in the meantime. But again, beyond this one anecdote, we don't have any strong data to support that this is in fact going to be something reproducible or that's going to happen time and again. So at MD Anderson, we have the machine. We have established a multidisciplinary steering committee to overlook this machine and to use it selectively, to use it in a very rigorous way to treat tumors, including cholangiocarcinoma. Currently, we use it primarily where we do not have a good alternative like surgery, like ablation, like Y90 for radiation, due to anatomic, biologic, or physiologic constraints. So we use it only when we think it is appropriate to do so. We are going to have upcoming clinical trials to rigorously investigate the value of histotrypsy, especially with regards to this abscopal potential. So in summary, histotripsy is a new and definitely promising technology that utilizes focused ultrasound energy to deliver non-invasive local therapy. The application currently is limited to small tumors that can be seen on ultrasound. Very little is known about long-term success or outcomes. The actual benefit of histotripsy is anecdotal at this point, and the plural of anecdotes is not data, so we need the data, right? So use of histotripsy to treat liver tumors must be carefully studied and investigated on clinical trials, which we at MD Anderson plan on doing, hopefully through our network, but also with the assistance of the Cholangiocarcinoma Foundation and through the research consortium. I want to thank the entire team. There's a lot of people that make the program work. I also want to thank, of course, our patients and families, of which there are too many to list. We do have a foundational philanthropic gift to help us study this technology, the Cholangiocarcinoma Foundation as our partners, of course, and so many more. Thank you very much for your attention.
Thank you, Dr. Karen Cal. We'll take questions at the end. I'm going to introduce our next speaker, Dr. Colin Court from UT Health Sciences in San Antonio. He's going to be speaking about hepatic artery infusion.
Awesome. Well, thank you. Thank you for inviting me. I have no disclosures other than the one that apparently most people have, which is that I too am Canadian. And I suppose I suppose I should also mention, especially given where I am right now, that I trained at Memorial Sloan Kettering, which is where the pump is from, which, as someone from MSK in an MD Anderson setting, I figure I should at least mention. So this slide is something that everyone here knows. Intrahepatic cholangiocarcinoma is rare and is often advanced or metastatic at diagnosis, and that at least historically, survival kind of beyond 3 years was rare in this setting. And the cause of death in biliary tract cancers in general is something that is a little different than many of the other GI cancers that we see, in that it's really the primary tumor progression that is often the cause of death due to liver failure or cholangitis or other causes from the primary tumor, even in patients with metastatic disease. This is at least one study from the Netherlands showing this. About half of patients end up dying due to their primary tumor progressing, not from metastatic disease or other causes. And there's another study outcoming from the same group showing it may be as high as 80% when you really dig into the data there. So moving on, what I'm talking about today is hepatic artery infusion chemotherapy. And this is basically a pump that's placed on the abdominal wall under the skin and infuses a substance called FUDR, which is a 5-FU derivative that has 99% hepatic clearance. So basically it's completely metabolized by the liver and never goes systemically. And what this allows us to do is really physiologically and pharmacologically isolate the liver. So very, very high doses of 5-FU, 100 to 400 times the dose we would ever consider using systemically. And it just goes to the liver and never goes elsewhere. So much better quality of life while on pump chemotherapy because that you're not having the systemic side effects. This is something that's been an approved therapy since the 90s for colorectal liver mets, and that's for colorectal cancer, something that we have 1,000 patient studies on at this point in time, showing efficacy there. There's now over 60 centers in the U.S. Where there are pump programs, and that's really been something that's evolved in the last 10 years. Going back to the early 2000s, there were really only 5 centers that were doing this. So this is a fairly new thing overall. And I think really the reason for that is that systemic therapy for metastatic colorectal cancer has become much more effective. And so there's more of a need to control that disease in the liver. Because of this kind of increased interest in this, there in the last 5 years or so, it's been an increased interest in using HII therapy for intrahepatic cholangio as well. So moving on to the pump itself, it's, again, being Canadian, a hockey puck-sized disc planted under the skin, weighs about 5 ounces, and it's connected by a long catheter to the hepatic artery, and that's where the drug is directly infused. There's no battery. It uses body heat and atmospheric pressure to power the pump and deliver the drug. So there's no need to change batteries, and these things will work for basically as long as they're being refilled. So I think the longest I've heard about is 15 years that one has been working. So potentially can last even longer than that. There are some contraindications to HAI therapy. Extrahepatic disease, which I'm going to talk about a little at the end here, because that's something that is being actively investigated. Obviously, a history of 5-FU toxicity. And the final one is any scuba divers or hot tub enthusiasts. And again, the pump runs based on body heat and atmospheric pressure. So anything that increases body heat or increases atmospheric pressure is going to cause that pump to run faster and potentially run dry. And because it's running into arterial pressures, if it runs dry, it will clot off. And we really only have one good place to put this, which is the gastroduodenal artery. And so there's not really an easy way to do a second one. It's possible, but doesn't work as well. So I wanted to quickly kind of go through the data that's out there about this. And again, like I said, there's really good data for this in colorectal liver mets, but only recently have people started investigating it for cholangiocarcinoma. And the first of these studies, kind of with a renewed interest in this, was published in 2019. It was a joint study from Sloan Kettering and WashU. 38 patients without any evidence of distant disease treated with FUDR, that's the drug that goes through the pump, as well as GEMOX. And you can see the responses here, which were fairly dramatic at the time. Again, this is prior to TOPAZ-1 and other studies coming out that have shown a better response than GEMOX alone. And 11% of the patients were able to be converted to resection. Overall survival in this study, median overall survival was 25 months, and 90% of patients were alive at 1 year. So that was kind of the initial study that came out. And then kind of moving forward from there, there was a meta-analysis of some smaller studies as well that was pulled together by the group from the Netherlands with 154 patients, again, showing median survival of about 29 months. And the thing I really want to highlight here is this 3-year overall survival, showing almost 40% of patients alive at 3 years. And if we compare that kind of to the historical controls from the ABC trials, where there were no patients alive at 3 years, this is a fairly dramatic improvement here. Looking forward, again, the group from the Netherlands did a retrospective study looking at 268 patients, again, with liver-only disease, so no evidence of any metastatic disease. And they found that 192 patients were treated with this combination of HAI or HAI and systemic, and compared it to 76 patients that received GemCis. And here we can see on the survival curve here, with data extending out to 5 years, just much better overall survival, as well as what you're starting to see there is kind of a tail to that curve where we're seeing some real durable responses in long-term survivors here, which is obviously something we don't necessarily see with historic chemotherapy alone, just GemCis. Also, same study showing that, it doesn't really matter if the patients have had other chemotherapy in the second-line setting. We see kind of similar results here. So looking specifically at kind of the situation we're in right now with the data that's out there from TOPAZ-1 and KEYNOTE-996, the immunotherapy trials, we're again kind of seeing, as you can see here, which one of these is that one? There we go. This kind of tail of the curve coming here, where we're seeing some of this durable survival versus even, looking at TOPAZ-1 or Keynote, there does seem to be this increased rate of durable response. And that is what we see in metastatic colorectal cancer too. When we can get these patients to resection. Again, it's only about 10% of patients that are getting to resection, but those patients in particular, we're seeing this kind of durable response, which is really nice to see. Now, all the oncologists in the room will tell me you're never allowed to do this, which is I'm directly overlapping the two survival curves, and it is true. Statistically, you are not supposed to do this, so I apologize for this. But what I wanted to show here by doing this was that if we compare that PUMP2 trial data for the GemCis patients to the PRODIGE 38 trial, which was comparing GemCis to FOLFIRINOX, we see that the outcomes with systemic therapy alone were basically the same. And you can clearly see that the data for HAI plus systemic seems to be better. Again, this is not a statistical test. This is just more of a thought exercise showing where we think this data is going and why we're enthused about this as an option here. So I wanted to go back to this slide that I showed earlier about the cause of death here. And, this is something that Dr. Korkamp, who's the one who was kind of leading these studies from the Netherlands, talks about a lot, which is that, when you have a cancer where the cause of death is that primary tumor, control of that primary tumor, control of the liver itself, it is really the important thing. And I think that's what HAI is allowing us to do. We're getting very high doses of chemotherapy directly delivering. We're not preventing metastatic disease. We're not treating metastatic disease with this, but it allows us to get control of that primary tumor. And I think that's where the survival benefit from HAI comes from. So I wanted to share the story of our first patient we treated in San Antonio with intrahepatic cholangio. So was diagnosed last May. Did not have any targetable mutations, was treated with gem carbo durva due to a cisplatin shortage. This is a picture of the tumor here at diagnosis. Here we are after 9 cycles of gem carbo durva. This is the original scan of diagnosis. This is after treatment. So again, had an absolutely excellent response to that TOPAZ-1 regimen. At that time, was still deemed unresectable, so we went ahead and placed a pump. There was still viable tumor on the biopsies I took in the OR there, and then we treated with 6 months of FUDR GEMOX after that. Here we see, so this is after the gem carbo durva here. This is after HAI therapy, and again, the question there, that's the left portal pedicle coming up there, and at this point in time, it was unclear if it was still involved there or if there was a chance we could go in and resect. I talked to the patient about that and we decided to go ahead and at least try. And we came so close. This is the tumor right here. We were able to get, this is the portal vein here. That's the artery there. And unfortunately, the bile duct had just been sucked up in this tumor and there's no distal target that we could reconstruct it. So unfortunately, we were not able to get it out. However, I took many frozen sections in the OR. None of them showed any viable tumor left. This is obviously from 2 days ago, so I'm still waiting on the final pathology, but my hope is that with the combination of both the TOPAZ-1 and the FUDR, we were able to get a complete response here. As we'll talk about here, our plan is to now go to radiation therapy to finally, hopefully kill this thing off. So conclusions, again, this is a promising treatment option for patients with unresectable intrahepatic cholangiocarcinoma. I should mention very select patients. This is not for everyone. This is, for patients who qualify for this. It's currently approved for patients without extrahepatic disease. As I mentioned, I think that's something that will change based on some studies that are coming out showing that control of that primary tumor is really the benefit of HAI. And that even for patients with low volume metastatic disease, it may be a good option. It does require surgery to implant the catheter, and it requires a refill every 2 weeks while on HAI therapy, and then every 2 months when not, when we can fill it with glycerol. And then finally, it's powered by body temperature and atmospheric pressure, so no hot tubs, no scuba diving, also no hot packs after surgery. Thank you very much.
All right, thanks, Dr. Court. Next, we have liver-directed therapy for localized unresectable disease, what, how, and when by Ziad Nidwam, our interventional radiology faculty.
Hi, good afternoon, everyone. Thank you for the invitation to talk. And, I particularly appreciate the patient stories and you all sharing with us. That's really helpful to hear from our patients. And we learn so much from our patients. So I really appreciate that. Thank you. So I'm an interventional radiologist. So I'm going to talk to you a little bit about when to get IR involved and what we do in our practice. So typically the point where an interventional radiologist gets involved in the care of cholangiocarcinoma patients is typically once we have disease control on systemic therapy, ideally if we're treating something with Y90 or ablation, if it's an isolated lesion, that's also an ideal candidate. Sometimes we will treat patients who have extrahepatic disease if the disease is liver dominant, and that's the primary site of disease. And occasionally we will get involved in treating recurrent or residual disease after a patient has had other therapy like radiation or recurrence after surgery. And less commonly, we will treat patients who are potentially being considered for surgery or maybe even transplant as a bridge to that therapy. So I'm going to talk briefly about some of the evidence. A lot of the evidence is for our local therapies is retrospective, so not the highest quality of evidence, but I'll just touch on a couple of the studies. The first study I'll mention is a meta-analysis of about 900 patients who received radioembolization or Y90 for intrahepatic cholangiocarcinoma. This is across about 20 different studies, and the overall progression-free survival in that meta-analysis was 8 months, with an overall survival of 13 months. For the first-line setting, there was one study that was a very small study, only 24 patients, that looked at that using Y90 first-line before a patient even got chemotherapy, and patients were allowed to get chemotherapy or radiation after they progressed. In that study, the overall survival was 19 months. And in the patients who responded, who had either stable disease or some kind of a response at 3 months, the overall survival was as high as 37 months. So that's some of the data that we have for using Y90 in intrahepatic cholangiocarcinoma. As far as ablation, this is another tool that we use a lot in the IR space for treating patients with cholangiocarcinoma. The first study I'll mention is a study that looked at patients with either primary or recurrent intrahepatic cholangio. This was about 100 patients in about 170 tumors. The progression-free survival in that study was 9 months, and the overall survival was 28 months. And then lastly, I'll mention a study that looked at comparing surgical resection and ablation for recurrence. And in that study, we had they had about 100 patients, about 55 got ablation, about 60 got surgery. And you can see the numbers were overall very similar. So in the recurrent setting, ablation is maybe favored over surgical resection because of the lower complication rate, but the overall survival numbers were similar. So overall, what is our practice? Our practice is, as I mentioned earlier, patients who are stable or have some response on systemic treatment, that may be a good window for us to intervene in the IR space. Ideally, if we're doing an intraarterial therapy, we want the tumors to be hypervascular, particularly if they're multifocal, and we're treating a larger area of liver. There is some evidence to help us that treating bulky central disease may be helpful to reduce the risk of liver failure. For ablation, typically we're looking at lesions that are less than 3 centimeters in size. And in some settings, if a patient is actually progressing on systemic therapy, but it's an isolated site of progression, we might consider trying to do an IR therapy like ablation or even Y90 for those cases. So to kind of illustrate these these situations, I wanted to show a couple of cases. As much as I'm sure Dr. Coy would love to debate the merits of IR therapies versus radiation, I think we actually can work better when we're using a combination of these therapies and picking and choosing these therapies based on the patient, based on their specific situation. Many times patients will receive multiple therapies from IR and radiation. So this particular woman is an 82-year-old female with cholangiocarcinoma. She was treated with chemo for about 6 months. You can see the large mass on the first image on the left there, about over 10 centimeters in size. She got radiation therapy, and you can see she had a nice response. The mass started to decrease in size and enhancement, but then developed a new lesion on the image on the right, that 1.7 centimeter lesion there. So this was kind of her clinical course, and we got involved at the point where she developed this new lesion. It was fairly small, so we decided to go ahead and treat it with ablation. It was the only site of active disease for her at that time. Unfortunately, 3 months later, she developed another lesion. This one was 1.2 centimeters, so again, less than 3 centimeters in a favorable location for ablation. So we treated that lesion. And then at that point, she actually stopped chemotherapy. She was, like I said, she was 82, wasn't really doing very well on chemo, and just stopped treatment altogether. About 6 months after that, she had a PET scan that showed some viable disease at the site where she had previously received radiation. So now we're at about 2 years after her initial diagnosis. We went ahead and treated that spot with Y90, and actually she's now a year out from the Y90, or 3 years out from diagnosis, off treatment, and no active disease on her latest scan. So you can see a combination of different treatments can be effective in some patients for controlling these recurrences. And this is, sorry, I forgot to scroll through these. This was the ablation cavities you can see before and after the lesion was treated. Here's another example for recurrence after radiation therapy, another place where Y90 can be very useful. This is a 42-year-old woman with cholangiocarcinoma. She had 7 months of systemic treatment, was referred for Y90 radioembolization. We performed an angiogram, but her anatomy at that time was not really great for treating with Y90, so we referred her to our radiation colleagues. She received radiation. Unfortunately, there was an area that we were monitoring on the scan that sorry if I could show this. So right here, there's a little bit of an enhancement there. So that's an area that was felt to be residual active tumor. So then we treated that area with Y90, and you can see where the orange there on the image on the right, that's where the Y90 was deposited, right where that area of recurrence was. So this was her clinical course. I won't go through all of it, but suffice it to say, some of these patients will get multiple therapies, and we can intervene with IR therapies even after a patient has had radiation therapy, and potentially get the patient to a point where we get the control of the primary tumor. And you can see this is her tumor here, no evidence of active disease in the tumor on imaging, and she's about 1.5 years out from Y90 at this point. And lastly, I'd like to show a case of a bridge to transplant. This was a 66-year-old male with hepatitis C cirrhosis, cholangiocarcinoma. He was felt to be potentially resectable, but he did have stage 1 to 2 fibrosis on a liver biopsy. So instead, we elected to treat with local therapy. He was treated with Y90 to 2 separate branches. We got a very high dose in there. This is the tumor here that has the circle on the far left image. You can see it's a relatively hypervascular tumor. The first image on the left shows where the Y90 was deposited, and then you can see in the middle image that the tumor is no longer enhancing. So this patient, after the Y90, 4 months after, had a complete response on his CT scan. About 3 months later, he actually had to stop systemic therapy because he started developing some signs of early liver failure, developed ascites. 5 months after that, he continued to have, so 1 year after the Y90, he continued to have complete response on CT, and then 6 months later was actually successfully transplanted and had his liver failure as well as the primary tumor addressed. So to summarize, as far as liver-directed therapy, for unresectable disease, ablation and Y90 can be effective for local tumor control. It can be combined with systemic therapy, and it can be very useful in the setting of recurrence after surgery or radiation. Thank you.
Thank you, Dr. Medwali. On to the same theme of local therapy. Dr. Ethan Ledmere, radiation oncology faculty, will speak on radiation for metastatic
Is this the one?
That's perfect. All right, terrific. My only disclosure is I am not Canadian. I appreciate it. Thank you for having me this afternoon. My name is Ethan Lindner. I'm a radiation oncologist. I wear a few different hats. I'm also a statistician, so whenever I see trial curves and things like that, I get very excited. There's a reason they really do keep radiation oncologists in the basement, so much so that we like to repeat the same jokes, even twice in one conference. I want to talk today briefly about the expanding role of local therapy in the metastatic setting, and I'm really pleased that my colleagues before me, Dr. Matwali, Dr. Court, really alluded to this as an emerging frontier, because it really does change the paradigm of how we think about cancer writ large. So topics for today: external beam radiation in the treatment of cholangiocarcinoma in general, why we think about local therapy in the treatment of metastatic disease at all, omics, because we have to have some good science here. I'm looking right at Dr. Valle. I really do need to have good science here. What outcomes matter to our patients and how that informs the future. So external beam radiation for intrahepatic cholangiocarcinoma is something that has really emerged as an exciting and effective technique for ablative dose treatment of patients with cholangiocarcinoma. A seminal series published from MD Anderson back in 2015 in JCO demonstrated that if you can get enough of a high dose into these tumors, which our technologies have increasingly allowed us to do with both advanced X-ray and proton-based radiation, you can meaningfully improve local control and meaningfully improve survival. And this has been validated a few different ways, both with population data across the United States, as shown on the right, but also through an ICRN CCF supported initiative in which institutions across the country have pooled their data of cholangiocarcinoma patients, and we encourage everyone to look into these resources that CCF provides, and demonstrated this is exciting data that really median overall survivals are improved by an average of 11 months with the addition of ablative dose radiation for patients with cholangiocarcinoma. Now, I have to qualify this. To the hammer, everything is a nail, right? So I'm a radiation doctor. I like radiation. I think radiation works great. And to Dr. Matwali's point, we really do work well when we work as teams, and each of our techniques are differentially useful in the way that different tools in a toolbox are useful. So what makes radiation attractive? Well, I'll tell you, large tumors don't scare us off. We treat tumors, or as Dr. Coy and I like to call them, supermassive tumors with frequency, with durable and long-term local control. Tumor that invades into blood vessels doesn't scare us. We know that radiation therapy is inevitably the most effective local therapy in this setting. The vasculature or vascularity of a tumor doesn't scare us off either, in that we don't need a specific arterial flow to the tumor to deliver our therapy, and it's non-invasive. You come in and you leave. And this speaks to Mr. Neubauer's point from his story a couple hours ago. There are still downsides to radiation. We don't gloss over those. Patients have to be here for a week to 3 weeks, sometimes even longer, getting their therapy. The radiation is delivered Monday through Friday, 5 days a week. And there are other downsides in terms of different toxicity profiles, depending which local therapy you end up using. Taking a bigger step back, and this echoes what Dr. Court talked about, an important question that we have to keep coming back to is how do we improve quality, quantity, or both of life for our cholangiocarcinoma patients? And that takes us through an exercise of how does cholangiocarcinoma cause death? Well, in 80% of patients, the pattern of death is due to the primary tumor itself involving the biliary or vascular structures of the liver. The liver is high-priced real estate. The center of the liver is exceedingly high-priced real estate. If tumor starts pressing on blood vessels and causing sepsis and cholangitis, starts invading vasculature and causing liver failure, ascites, and liver decompensation, these are the primary pathways by which patients with cholangiocarcinoma die. And we wanted to ask whether that same paradigm exists in the metastatic setting too. It matters in the non-metastatic setting, but even if the cat is so-called out of the bag, you've got metastatic disease elsewhere in the liver or outside the liver, in the bones, lymph nodes, lung, can local therapy matter? So, in our experience here at MD Anderson, a collaborative effort from all the folks you've heard from today, Dr. Javli, Dr. Coy, and many others, we identified patients for whom we delivered local therapy, radiation to the dominant site of disease at the center of the liver, for patients with metastatic disease outside the liver. And what we found was that the addition of local therapy meaningfully improved their overall survival times from an average of 9 to an average of 21 months. There are caveats to these data. The other hat I wear is I'm a statistician. In God we trust. Everyone else has to bring me data. So you should look at data with a critical eye, right?
So here we're in the pre-Topaz and pre-Keynote era. So these patients were not yet treated with durvalumab or pembrolizumab. And if patients were going to get radiation, these are patients who were already selected. They had done well enough on chemotherapy to make it to this point. But even controlling for all those factors, doing propensity matching and landmark analyses and all sorts of fun things statisticians like to talk about, we saw that that overall survival benefit was preserved. People live longer. And I want you to call your attention to that endpoint, overall survival, not progression-free survival, not response rate, overall survival. Because the other thing I believe ardently is whatever you do for patients, make sure it benefits their quality of life, their quantity of life, or both. So I like overall survival because that's asking the simple question of, did patients live or did they die? So we seem to help people live, God willing, longer. The question is, if they're already metastatic, how is radiation helping at all? And we turn to how patients actually died. In terms of patients with liver failure, 82% of patients with metastatic disease, 82%, despite having metastatic disease out of the liver, died because of liver failure due to the primary tumor itself. That number, when you add radiation, drops to 47%, and the time to liver failure goes from 9 months to 18 months. So we have a mechanism by which radiation may help in the metastatic setting or local therapy writ large, and a reason for which it may improve patients' overall survival. Now, the question we kind of come back to is who might benefit, and there's some neat science that goes into this too. A lot of patients ask when they get any local therapy, and I'll defer to my colleagues in IR, I know we've all heard this as well, is when I get a local therapy, is my tumor going to shrink? Am I going to see a response? Is it going to be like the Death Star in Star Wars? You'll hear Star Wars themes. We're, nerds. We like talking about Star Wars. The answer is cholangiocarcinoma is a very scarred down tumor, so the things you look for are not the things you look for in a patient who, say, has lymphoma. You don't expect the tumor to vanish. Rather, you're looking for changes that might meaningfully indicate that the cancer is dead and the disease is controlled, even if on paper the tumor was 5 centimeters before and is still 5 centimeters now. So we've identified specific aspects of the tumor that we can see. Rather than measuring its size in one dimension or another, rather we're looking at how well it takes up contrast, what it looks like on imaging. And the expert for this is sitting exactly 10 feet to my right. It's Dr. Coy. And what we identified was that when you look at changes in the enhancement pattern using neat metrics, you can actually better differentiate who's going to do well and who's not going to do well. As Yoda says, size matters not. So classically in cancer, we think about what we call RECIST criteria on the left. Has your tumor gotten bigger or smaller or stayed the same? And it turns out, depending on whichever one of those you have, the outcomes are kind of the same. But if you look on the right, those two curves, the blue and the red, separate nicely because it's telling you information about how living or not living that tumor is after you delivered therapy. We're learning more and more across radiation oncology, IR, and others about different molecular profiles, certain mutations that may or may not confer a benefit if you add local therapy, like ARID1A, where mutations to confer resistance to a lot of the local therapies we have now. And here, as we enter the era of immunotherapy, we're learning that if you take biopsies of these tumors and look for the immune cells in those tumors, that correlates with how they look on the scans, look on the pictures that you get as part of your CAT scans anyway, and predict for sensitivity to both radiotherapy and to immunotherapy, which is offering us new possibilities for picking which patients should get different treatment strategies and identifying patients who may need further intensification or de-intensification of treatment down the road. So let's bring it back. What outcomes matter? I'll have you note that we think about ongoing data in this space, and there's one randomized trial that just got presented earlier this year. The trial was conducted in the UK. It was a small trial, only 69 patients, and they demonstrated that for patients with unresectable cholangiocarcinoma, that the addition of radiation therapy, primarily for patients with extrahepatic or Hyler disease, did not confer a progression-free survival benefit. The problem with progression-free survival as your primary endpoint is that you might control the tumor itself, but one little satellite nodule pops up in the kind of periphery of the liver. That's a progression-free survival event. You have failed according to the trial. However, that's not what we meaningfully care about. Are patients living longer? Are they living better? And the overall survival benefit with the addition of radiation therapy was at least seen or suggested in this trial. So again, I'm like a broken record, quality or quantity of life, ideally both. So with that in mind, Dr. Javli, Dr. Coy, many others here are launching a randomized phase 2 trial for patients with advanced cholangiocarcinoma. This has been done with the support of Cholangiocarcinoma Foundation, AstraZeneca, and others, taking patients who have intrahepatic cholangiocarcinoma, primarily those with metastatic disease, and randomizing patients to receipt or non-receipt of radiation in this setting. And what's the key item here I'll draw your attention to? The primary endpoint, the thing we're interested in, is overall survival. Are we helping patients live longer? And a key secondary endpoint, quality of life. Are we helping them live better? So hopefully I've convinced you, even though we as radiation therapists, we don't have a great PR or marketing team, we don't have a lot of companies that are backed, but radiation is an excellent local therapy option in this pantheon of local therapies for the treatment of both localized and metastatic biliary tract cancer. Perhaps metastatic cancer patients in this setting benefit from local therapy to prevent tumor-related liver failure. We have neat science and translational data that are trying to help identify different populations molecularly, immunologically, to benefit from different approaches. And at the end of the day, we have to keep coming back to, are we helping patients live longer? Are we helping them live better? And we look forward to opening and pursuing trials to answer those questions meaningfully. Thank you.
Time that they ask me to talk, I always refer to Dr. Ludmir, because whatever we lack in terms of funding from companies, we make up for in enthusiasm and so our final speaker in this session is Dr. Milind Javli, which we all know and love. Dr. Javli, take it away.
Thank you very much, Eugene. After that, Fred referred me to as the Godfather, but after Ethan's animated presentation, I really feel like a grandfather. So my presentation is going to be really quite short, and it's going to try to sum it together. We had such wonderful presentations, from all specialists, the surgeons, radiation oncologists. Colin presented FUDR pump, etc. And I think I'm fortunate in that I work at an institution where I can utilize their expertise. So I've sort of titled my short presentation is Uniting Expertise, the Power of Multidisciplinary Care in Oncology. While we talk of immunotherapy, we talk of targeted therapy as great advances in oncology, I really think the underlying theme is the power of multidisciplinary care, because each therapy adds only so much. So we saw this figure before, and we saw the incidence of cholangiocarcinoma that's increasing. Unfortunately, at Texas, we understand the burden of the disease even more. We are the nation's highest incidence and prevalence of primary liver cancer, which includes HCC or hepatocellular cancer and intrahepatic cholangiocarcinoma. It is thought to be because of the epidemic of NASH or fatty liver, or now we call metabolic associated steatotic liver disease. In fact, in the city of Houston, about maybe 5 or 7 miles from here, in an area called Fourth Ward, was the dump for Union Pacific Railroad. People who lived over there were the underprivileged minorities, and it is thought to be a cholangiocarcinoma cluster. So we have a high number of patients. When we started our practice and started focusing on it about 15 years ago, we saw about 40 patients. So that's a great number. Now we see close to 400, not because we cannot see more, not because it really meets our capacity for what we can offer in terms of the specialists and the kind of experts that you saw today. So the need is there, and I think we have to work together. But I think what I've seen over the last few years really is an exciting change in the disease. Juan had the GEM-CIS study. We used FOLFOX. These are drugs we used in colon cancer and pancreas, and that's sort of what we use. But look at the exciting trajectory over the last 4 or 5 years. We have 6 agents approved. Zanidatamab was just approved 2 weeks ago. So it's really an exciting area that I think we are all privileged to be a part of. So this is what worries me. I returned from a trip from India like 2 days ago, so I'm sort of barely awake. You have to pardon me with that. But what you see even there, I saw patients who have this metabolic associated steatotic liver disease, like fatty liver. And this is an epidemic in Latin America, in Mexico, far more, followed by North Africa, some parts of Europe, Middle East, then India, North America, Australia. So it is estimated that about 40 to 50% of patients who are over the age of 50 will have some sort of component of fatty liver or steatosis. So I think that there was a question earlier about, will we ever screen for cholangio? We won't screen for cholangio, but we'll screen for liver diseases. I think an ultrasound, a fibroscan to see how the liver is changing so we can hopefully detect early changes like cirrhosis, besides just diabetes, hypertension, cardiac disease, besides hepatocellular cancer and liver cancer. So we saw this study several times before, the TOPAZ study, like the keynote study, which showed an improved survival, and it's in advance. But really the way I look at it and the way I tell my patients is this is the bridge to the next step. This improvement in survival of 2 months is something to be happy about, not something to celebrate, because it's still very modest. And this is a bridge that we use here and many institutions here as a next step. Can we consider surgery? Can we consider radiation therapy? Can we consider radioembolization? Hopefully FUDR. In a small select group, can we consider transplantation? And that's really the theme of my next few minutes, that we will use this game to result in incremental advantages with multidisciplinary care. So I'll give you an example from my practice. There's a young woman who was from Tennessee, 39. She presented with abdominal pain. She had these liver lesions, lymph nodes in the para-aortic region as well as in the portocable region. So never would we think that she's resectable. She had an unusual pattern on the biopsy which made it look more like colon cancer, but the colon was actually, the colonoscopy was negative. She had a BRAF mutation, so technically we could have given her targeted therapy too, but we gave her gemcitabine and durvalumab, and you see a very nice response there at the end of therapy, in 6 months. So she had these lymph nodes which still make it a distant disease, not considered resectable. But is that true? I mean, this person who has a good biology, should we declare that this person should never get operated? So I referred her to my liver surgery group. She saw Dr. Chen, who just gave us a nice talk on neoadjuvant therapy. So she's considering of a surgery. And this is N of 1 because I think I've learned from the surgeons that you not only look at the extent of the disease, but you look at the biology of the disease. How is it behaving? How does it track over time? And then can we think of out-of-the-box therapies in a reasonable way for patients who might benefit most? And that's where this lady is headed. She would not be thought of as surgical because she's technically metastatic disease. Now, there's a history to multidisciplinary care in oncology, which began in to foster collaborative decision-making. In the 60s, we have advances in surgery, where patients actually survived complicated operations, the mortality rate improved, radiotherapy became safer, now cobalt and other things gave way to modern radiation. And then in the 1970s, oncology developed as a specialty. Formerly, oncology was limited to like leukemia and lymphoma. And then around the 70s, we started treating solid tumors. Back then, treating cholangiocarcinoma with chemotherapy would have been thought as ridiculous. In the 80s in the US, we developed comprehensive cancer centers, such as this one, to provide comprehensive care across specialties. And then this has then morphed to patient-centered care, where we include several other aspects to care, psycho-oncology, palliative care professionals. Now, I think hopefully the next step would be managing the financial toxicity. And this modern era now uses molecular diagnostics, precision medicine, that has increased the need for diverse expertise beyond what we offer before, beyond what individual specialists can offer. So this is what we sort of think as multidisciplinary therapy or multidisciplinary care, where we formerly thought of surgery and radiation and medical oncology. Now it includes diverse specialties, which include hepatology, if the person has lung disease, pulmonology, psychiatry, nutrition, palliative care, etc. And this sort of a comprehensive approach, I think, is especially important when you look at an uncommon disease where individual expertise is limited. So these are some of the benefits of multidisciplinary care. I'm fortunate to have these energetic people around me, these surgeons and radiation and so on. With them, we can have improved treatment planning. We can have holistic patient support. We can have enhanced communication between specialists. In the past, we were in silos. We hardly communicated with each other. And these are then translating to better patient outcomes and better patient satisfaction. But there are challenges. There's time and resource constraints. There's coordination that has to occur between team members. You'll be surprised that when we are getting together here, even from Anderson, we haven't met each other, some of us, for over 6 months. So this is the forum where we're meeting. There's variability in institutional support. I mean, institutions also have the bottom line, and some specialties pay more than the others. They get more resources. Medical oncology is not one that is a high reimbursement specialty. And then how do you navigate patient across different specialties, and how do you keep track? You know, if the patient is coming from Midland, Texas, and you're coordinating their care with the patient, the doctor there and specialists here, navigation is a little complicated. Things get lost in follow-up. So this has led to tumor boards. So the tumor boards, we have regularly scheduled meetings. For hepatobiliary, we have one Tuesday afternoon. Then now we have started one on Monday every other week with Methodist to review transplant cases. We discuss complex or rare cases. We ensure that decisions that are made are evidence-based. It's an educational forum for faculty and students. I, being one of the more senior members, I still learn a lot from the surgeons. They teach me a lot about anatomy and liver segments and so on. So these are various tumor boards, but in the past, attendance to this was mixed. So to give you an example, our liver tumor board was at 5 p.m. So imagine after a full busy day in the clinic, and you are catching up on your notes, and then you're trying to go to this liver meeting at 5 p.m. So attendance was scant. What has changed, however, is COVID. So COVID happened, we all started working remotely, and then all of these tumor boards are now virtual, and our attendance, where we were struggling to get 10, 12 people, are now 40 people all of a sudden. So it's a benefit of, an unexpected benefit, I would say, of virtual care has been that now we have a really strong forum of many people, and now we invite people from other institutions too. So the next step that has been implemented at Anderson and many other places is the virtual molecular tumor board, where these are meetings held regularly. They include physicians, oncologists, scientists, genetic specialists. The physician presents the case, the scientists provide information on the genetic profile, and these members then provide, there are hopefully patient advocates provide some input about what are available therapies. We may have a MET amplification, but we cannot give a drug that's approved for lung cancer in cholangiocarcinoma. So there are logistical challenges. And then there are consensus recommendations, and the treatment physician makes the ultimate decision with the patient. So we are gradually morphing from a traditional tumor board that has existed for over the last 30 years to a sort of a molecular board where we also include genetic information. But where we need to go is a more patient-centric approach where we have shared decision-making. Patients don't participate in this tumor board. Caregivers don't participate in the tumor board. In fact, I've asked sometimes as a patient who wants to participate, and it's because of HIPAA issues, they can't participate in their own decision-making. I think that has to change in some way that is compliant. Personalized treatment plans cannot be made without including the patient. We don't address psychosocial issues. There are many technologies that are now, I think medicine is far behind. I mean, when I look at transfer of imaging and so on, I think UPS is far superior to who we are. I mean, I can see a patient from Cleveland. It takes an arm and leg to actually see a scan from a patient from Cleveland. So I think the data analytics, AI, tools for care coordination are still very limited, and I hope that will change with time. So I'm going to present a case, which is just one case, and I was actually thinking about a few more cases, but then I felt a lot of these people are going to be in the room. So I found one case that I shared with Dr. Ludmir, 53-year-old. Ethan, are you here? Yes. 53-year-old African-American gentleman, a veteran who we both love dearly, and presented with abdominal pain and fever, suspicion of COVID-19. His imaging had this big liver mass. You see this large mass. He saw the surgeons. I think he saw one of the surgeons in the room. They said this is not an operable mass. So we decided to investigate further. He had some family history of liver cancer and metabolic syndrome, hypertension, diabetes. We didn't really investigate with special scan for fatty liver, but I'm sure he had it. There was nothing else that could have led to this. He didn't have any PSC or ulcerative colitis or anything. He had this biopsy, poorly differentiated adenocarcinoma, stage 2. He was not a surgical candidate because it included the artery and portal vein. We started with chemo because we didn't have immunotherapy. We ordered molecular testing, and this is what you see in real life. He had a testing done in the VA. We got a testing done here. Unfortunately, in both cases, it was necrotic tissue, so we couldn't do NGS. We did a liquid biopsy, but the liquid biopsy did show a BRCA mutation, BRCA1. And then we followed that up with germline testing. Looks like he had germline BRCA1 testing. He had lymph node that was positive. He got gemcis, and then he had stable disease. And then he did well for 6 months. I referred him to Ethan, who got very excited, but that happens very easily. And so he decided to treat him with proton beam therapy along with concurrent capecitabine. We had a liver transplant protocol. So I introduced him to Dr. Kodali. I said, maybe we can consider transplantation. And then this was sort of the proton planning, which I don't understand, but I assume this was the way to treat him. So he got protons. He did very well. He got chemotherapy, then radiation therapy with capecitabine. He had that BRCA mutation. So then I gave him some olaparib therapy, which he continued. And I was hoping that now he's going to transition to transplant, and a really healthy young fellow who we liked greatly. His CA19-9 improved a lot. But then 7 months after getting this olaparib therapy, he had mental status changes. He had this brain lesion, a really large tumor in the brain. So clearly transplant was out. Really everything seemed to be out. At this time, we referred him to neurosurgery. He had surgical excision of this mass, craniotomy. And then, some radiation therapy was given post-operatively. We sent that brain tumor for next generation sequencing. The next generation sequencing of that brain mets had MSI high. So the original tumor, we didn't have enough tissue. And this again is a case for why sometimes it's important to go after it. So he had 2 biopsies. Interestingly, the brain showed MSI high tumor. He got pembrolizumab. He did very well for some time. Unfortunately, he after a while of stability on pembrolizumab and doing well, he died of complications of COVID. So but just to show that I think multidisciplinary care is an evolving field where we look at surgery, we look at chemotherapy, we look at targeted therapy, and so on. And I think this is just a lot has changed since then. Now I'm going to say that I grew up in Mumbai. Mumbai is a city on the ocean, and I was very connected to the ocean. My favorite book is Old Man and the Sea. So this story is important to me. And I think what was said earlier by our wonderful social worker, Ember, is the intrinsic value of every individual, So there's a starfish story, which many of you know. An old man walks along the beach and sees a young boy throw something in the water. As he approaches, he sees hundreds of starfish lining the beach, washed in from the tide. And the young man is basically looking at each starfish, seeing who is alive or viable, and then tossing them in the water. And then the old man asks, why does he bother? It's pointless. There are too many starfish. You can't really help them all. And what's the point of it? And as he flings the starfish deep into the water, the young boy replies, it mattered to that one. So I think it's very important that this for me was an important lesson, not just in oncology, but in life. So I'm going to summarize, look how far we have come. No drug approved. Now we have several approvals. We have one more just 2 weeks ago. We have immunotherapy. The advent of molecular profiling, targeted therapies has led to a sea change. We have several targeted areas, but really it's the multidisciplinary care that matters. So I've learned from Fred that FGFR therapy works really well, but he wouldn't be here without Eugene deciding to target him with radiotherapy, without some of these, without Rosie getting a transplantation. So I think this is a model for precision medicine in GI cancers, but really it's instructive how multiple specialties need to work together. So there's too many things, people to acknowledge, and this is an old slide, which I may have left people out. But really the people to acknowledge for all the providers and the medical people in this room are the patients. You know, you let us into your life at the most vulnerable and the most difficult time in your life. So we should not all forget as providers what a privilege it is. So thank you again for coming here and coming to MD Anderson and letting us be a part of your journey.
Have all the speakers come down, and while they're doing that, that's actually the first time I've seen the starfish story. So, Lynn, I think I can speak on behalf of everybody in the room. We are all starfish. As you're walking along the beach, you've impacted all of us in a positive way. So thank you. So go ahead and take some questions.
Thank you. I'm a general surgeon. I do a lot of surgical oncology, although I don't call myself a surgical oncologist. But I was very fascinated by the histotripsy for one reason. I'll tell you a little story. About 20 years ago, I had a woman come to me with a pancreatic cancer. It was quite bulky. Liver resection. We also had one for colon, so it was T4 plus. As is not uncommon, about a month or two later, she blossomed out a lot of liver metastases. In those days, of course, we didn't have histotripsy. We had radiofrequency ablation. And the interventional radiologist ablated about half a dozen liver lesions, a couple of them close to the diaphragm, developed pneumonitis, big inflammatory response. Kept waiting for her to develop her distant metastases and die. I lost track of her 10 years later in ED. When you talk about the actually, I know it's all anecdotal, but I really do believe that we see patients who are responding to their tumor endogenous immunotherapy after disruption of the tumor cells in the treatment target. We just don't know what we don't know how to determine who's going to respond and who is not. And I'm looking forward to hearing more of that, especially with the histotripsy, which I think has potential to be tremendously immunogenic against cancers. I'd love your comments on that.
Yeah, thank you for sharing that story with us. And I'll tell you, we don't disagree with you. I don't think it's a matter of saying no across the board. It is a matter of very rigorously studying it in a way that makes sense, in a way where we are proactively, prospectively tracking the data to make sense of it. The problem is that there can be such a phenomenon as just kind of hanging on to this thing, and then, you know, there are people out there who's going to give it to you regardless of your situation. We've seen that happen, you know, and I think it's important for all of us as responsible clinicians to make sure that as we study it, as we deploy this technology, we do so responsibly. That's all. I think, you know, Dr. Ludmia is running a trial, to your point about pancreatic cancer metastatic to the liver. You'd never think about providing local therapy. Again, we're not saying no to it. We're studying it rigorously on a clinical trial where we are now providing local therapy for metastatic pancreatic cancer, just like we will be for other aggressive cancers like cholangiocarcinoma. We're willing to do it. We just have to do it on a clinical protocol.
I'll build on what Dr. Fancow said and say that here in Indiana, we ran the only randomized trial of local therapy for oligometastatic pancreas cancer today. It was a positive trial with a PFS benefit of median 2.5 to 10.3 months. We published that a few months ago. And to the point about the immune response and the abscopal effect, in radiation, this is something we've spoken about for the better part of 15 years, and it feels like something of a unicorn, right? The abscopal effect, it exists, but not really, right? And so what we found in this study of doing local therapy in a randomized and rigorous fashion for oligometastatic pancreas cancer is that when you add local therapy, which in our trial was primarily radiation, but we don't really have good data to say one local therapy does this differently than another, is that there's an immense immune response, and that's sustained in patients who get the local therapy. So the idea is no matter what local therapy you're doing, perhaps this may be true for pancreas, this may be true for cholangio, maybe true for both, is that by ablating, by delivering ablative doses of some therapy to these tumors, you're exposing the immune system to the cancer neoantigens, and you're priming the immune system to actually go after these tumors. So that's a future direction, but to Dr. Chancal's point, the only way you do this effectively, believably, and reliably is in a robust clinical trial.
So I would say, like, I mean, in this room, I have a patient who has had, I don't know, 10 or 12 ablations in the lung over the last 2 or 3 years. Just to show that I think metastatic treatment for metastatic disease in the right patient has intrinsic value. We can't treat metastatic disease as one size fits all, just treat them with chemotherapy and nothing else, because our gains with chemotherapy are very modest. And I think it's really the combination, and like Ethan showed very well in the pancreas trial, in certain select patients that works.
I think I can use this, I think. So with the hipotrypsy, am I thinking about this correctly? The hilar, the bile duct would not be a candidate for hipotrypsy. There's just not enough material there to go after?
Yeah, so right now, we're not using it for that application. I will tell you, there are places out there that are starting to use it for that application. Again, just kind of as a test to see if it works kind of thing. I do think at some point it may make sense to study it. Again, we're in the process of putting together a number of different clinical trial protocols to study the various indications for histotrypsy. Cholangiocarcinoma may be one of them. We do have to be a little careful because understand that it is a very delicate location, and if you injure anything there, you can worsen the outcome very rapidly. So we have to just be very careful as we design these studies.
So everybody seems to want histotrypsy.
Yeah.
And what's led to that explosion of interest, and how do you? Everybody asks me in clinic.
Yeah, for sure. Yeah. And half the room in here is probably looking into it too. No, I think it's a matter of, stories being told across the internet, friends telling each other, but mostly the company has done a very aggressive job marketing. And I understand marketing both to clinicians, but also to the lay, population, the patient population hanging on to hope, looking for some kind of magic cure. And every time something like this comes along, it's completely natural for patients to kind of gravitate to it and want to kind of lean into it in the hopes that it is, in fact, that magic bullet that will treat their cancer. I understand that. We're studying it in a rigorous way so that we can provide you with the answer as to whether it is, in fact, going to be part of your treatment plan. I'm hopeful that it can be. I mean, we believe in it to some extent. That's why we got it here at Anderson. But it does, there's a lot of work that needs to be put into it.
Can you hear me?
Yep.
As one of those IR starfish, I can attest to the fact that I wouldn't be here right now if I didn't have the procedure done. And so from the marketing standpoint for IR, utilize that. I've got a couple questions. Number one, Melinda brought up the multidisciplinary care. For stage 4 cancer patients, do you envision a day when, if it's metastasized to the lungs, the bones, the liver, if you get to the point where we can treat each one of those individually and, over an extended period of time, there's nothing detectable, would that put us stage 4 is in a position either to have resection down the road or even so far as a transplant. Do you envision that?
So maybe if I can repeat the question, you're asking if you have a patient with stage 4, such as yourself, that diagnosis, you're able to kind of knock out all the tumors one by one, and is surgery an option or some other type of resection an option?
Particularly transplant. I mean, it all starts there.
You never say no. I think the answer is in very select situations where it's really driven by the patient's disease biology. Each one of you has a different biology driving this cancer, and it requires somewhat a test of time and really just observing how does that cancer respond to each individual treatment that you go through each step of the way, and does it demonstrate that it's not going to act up if you do something as extreme as a surgery, because the surgery is a major insult to the body. It's going to cause a lot of inflammation. It's going to cause a lot of stress hormones and growth factors to be produced that will potentially cause other tumor cells to wake up and start to metastasize or act up. So you really have to observe that patient very carefully and just make that decision in a very conscientious way. I never say no, but I think that you really have to look at each individual to decide that. It's not something that you can export to everybody.
You can have a surgeon going.
Already to make a stepwise decision. If people get their metastatic areas clear and we go backward, we call it the reverse approach, and we'll clear their primary tumor. For the patient who may have presented with metastatic disease, if we can clear it or control it, we can go back and resect it. The biggest price you pay for resection is an opportunity cost. What I mean by that is you have to take the foot off the pedal to stop chemotherapy or whatever systemic therapy. So that's the biggest fear. We want to understand in the mind of the surgeon, that's our biggest fear, is during that opportunity cost of time off that something else could explode. But in general, if the patient is healthy and is willing to understand that risk, we're willing to go for it.
Understood. Then my last question, one of the marketing, like a better term for histotripsy, is the immunobenefit down the road. Is there any reason why radiation and or ablation might not provide the same kind of immunobenefit? I don't know when you're radiated, if it just gets, consumed, or if there's an opportunity there.
Yeah, that's a great question. I think one of the issues with, at least with ablation, is ablation uses heat, and it basically just completely destroys all the tissue that's there, and including the parts of the tumor that the immune system might recognize and respond to. So that's the theory as to why maybe ablation often does not induce that effect. But it's interesting that case that the surgeon brought up earlier about the radiofrequency. You wouldn't typically expect to see an immune response from an ablation type procedure. I think with histotripsy, the idea is that the type of destruction that you might see maybe will preserve some of those immune components the immune proteins that the immune system might then recognize. I think with radiation, also similarly, you may not completely destroy the tissue, but you may, I don't know if you want to comment on that, but it seems like that would be something you might observe with active radiation. As Dr. Luzner mentioned earlier.
Hi, I have a question. Can you talk a little bit about you mentioned the ablation being heat. Can you talk a little bit about cryoablation and how that differs?
Yeah, sure. Sorry, I did mention heat, just meaning that microwave is what we most often use in the liver. But certainly there's other technologies that we can use in the liver, including cryoablation. I would say cryoablation is generally less commonly used, mainly because it often involves using more needles to do more punctures,
than what we might achieve with a heat-based ablation like microwave or radiofrequency. Also, most of the data that is, most of the studies that have looked at ablation in the liver have been done with microwave and radiofrequency. Cryoablation in the liver is less studied, so it's a less established technique.
Sure, I was thinking more in terms of metastatic to lung.
Yeah, sure. No, and there has been some suggestion that doing cryoablation is better at preserving some of those immune proteins that your immune system might recognize. So cryoablation probably does preserve that better. But again, this abscopal effect that I think was alluded to earlier, it's something that's kind of it's a unicorn. You know, every once in a while you might see it, but we just can't predict it. We don't know what cases we're going to see that. But in theory, cryo should be better for that.
We're getting close to time. I know that this gentleman here had a question from the very beginning. You want to go ahead?
Thank you. Sorry, yeah, the session is hyper informative. Actually, got the tons of questions, but I just try to keep it short. So the most concerning one to me about the local therapy is that are there possibility about combining like multiple ways of local therapy, either like sequentially or simultaneously, for instance, because the previous talk about the histotripsy, it mentioned that it needs to be applied to lesions less than like 3 centimeters. So if like a patient has like a size greater than that, is there possibilities for us to apply either like radiation therapy to shrink it first and then like sequentially to create a condition about that?
Yeah, absolutely. And one of our interventional radiologists, he's not here today, but we put together a series looking at how we combine radiation therapy, Y90 ablation, and indeed that does help patients whenever we need to combine different therapies. And to Fred's question earlier, there may be some rationale or reason to combine these different types of local therapies to the liver because of the time course and the quality of the immune response that you get. So, for example, with histotripsy, they've seen in animal studies at least that there's almost an immediate immune response to that. These antigens that are produced whenever you destroy the tissue goes immediately to the regional lymphatic system, and the antigen presenting cells begin to alert the immune system that there's something that's not supposed to be there, this cancer, that's a danger signal. Whereas with radiation, as Dr. Nawali was mentioning, that kills the cancer over the course of weeks to months. And so that immune response that you get is something more prolonged and of a different quality than what you might get with, say, histotripsy or ablation or Y90. So these things can be used in tandem to potentially help us to enhance that immune response and then combine that with things like immunotherapy or other targeted therapies down the line.
So, Colin, I have a question for you. I mean, how these multiple therapies, right? You have histotripsy, you have radiation therapy. I certainly think there's a role for intraarterial therapy, for instance, multifocal intrahepatic disease. Is that what you're limited to? Because I see people use it really, I don't know, I saw a large mass forming cholangio yesterday, and I'm sure the gentleman would have treated with radiotherapy. But how do you select patients for that versus other modalities for liver-directed therapy?
Yeah, and I think in the context of having multiple different therapies and kind of sequential improvement, I think that's where we're hopefully going in the future with AI. I think it's, you said it's something that can get us control of the whole liver fairly well, but then how are we doing that more definitive treatment of the individual tumor? At the end of this chemotherapy, right? It's not a truly ablative technique with surgical resection. But I think it is a good bridge to get us to there. And so, that's certainly something that we're using now and other people are likely to use in the future. It's certainly that we can use a higher dose of radiotherapy to a small area. It's something that we can consider as
Thank you for your expertise. I have a question in terms of the HAI pump. So if someone were to like move forward with other types of treatments, is it possible to do radiation with the pump in place, or does it have to be removed first? I know that there's heat involved, and so I just didn't know what that would entail.
For HAI, no. I mean, we routinely will do ablation after, or either ablation or radiation therapy after HAI. That is not a contraindication whatsoever.
What is your best recommendation for the peritoneal metastasis? I guess I want to ask for the least invasive as well.
So I think I probably stand as the only one here who does both liver surgery and peritoneal surface malignancy. So I do both HIPEC. I don't do HIPEC, but I do both HIPEC and PSM malignancies. And I'll say that the treatment of peritoneal carcinomatosis from cholangiocarcinoma is highly selective, and it really is a question of biology more so than anything else. I've done cytoreductive surgery. I have not done HIPEC because I don't think there's necessarily a benefit there, and there's certainly no data for either HIPEC or HIPEC. In carcinomatosis from pretty much anything other than colorectal cancer and appendiceal cancers. That being said, that is a trial that's ongoing. In California, I think I look forward to their data as much as everyone else. There definitely is a role, though, for cytoreductive surgery in selected patients.
So at our institution, we will consider it very, very selectively, as long as the primary is not present. For instance, I had a patient who had surgical resection and then years later developed carcinomatosis. And that responded very well to treatment for 7 or 8 months or longer. And that was after a great deal of feedback and decisions that she considered her, and she did well. But they are not, at least at our institution, we wouldn't be considering it if there is a primary intact. There's the primary intact along with carcinomatosis. Maybe there's room, but we have never done it.
This is probably almost my understanding. When you radiate the tissue, scar tissue forms, and as in Fred's case, his tumor became scar tissue. And my understanding is with the histotripsy that that tumor is involuted and within to be smaller. So my question being, is it the healthier tissue that's surrounding that involuted tumor with the regenerative potential of the liver compared to any other organ? My thought process is that rather than have scar tissue, that the surrounding healthy tissue has room to regenerate into that involuted area that's collapsed.
So you're asking, if I can make sure I understand the question, you're asking, is it better to do one modality over the other because of the regenerative capacity that you can get from the liver?
Yes.
So you actually observe the growth of the liver in both situations. I'm actually reviewing papers that are describing this phenomenon called hypertrophy, the growth of the liver after high doses of radiation. And we actually see that in a lot of patients that we treat with radiation for cholangiocarcinoma. It grows in other parts of the liver. The liver is a really smart organ. It actually detects whenever it has lost functional volume. And in areas that were not radiated, it will actually grow in compensation for the parts of the liver that were damaged by the radiation therapy. The involution that you're talking about with the histotripsy is something that still needs to be studied in detail. Certainly, it can cause that same sort of phenomenon. It's just in that same area or local therapy or local area that the histotripsy is done because it's not damaging as much of the healthy liver in the surrounding area around the liver. So it's not that one is better than the other. It's really that we need to identify who are the patients that are going to really benefit from one over the other, or are they equivalent in certain situations. One of the limitations with histotripsy is the size of the tumor that we can see. So there are multiple considerations that we have to take into account whenever looking at this.
So we have seen, for instance, doctor, that we have patients who have pretty extensive disease, but if the contralateral liver, like the left lobe is severely affected, then I've seen the radiations or local ablations being given pretty aggressively because the rest of the liver can compensate and hypertrophy and so on. So I do think there's room for exactly what you said, but I'm not sure one modality is better than the other in that regard.
Okay, we'll have one last question.
Okay, it might be three, but I'm gonna do it fast. And so we hear all the time that patients hearing that there's absolutely no complications to histotripsy. Yet your slide showed 6.8%.
Let's turn off. Okay.
8% major complications. So what are some of the complications patients should look out for with histotripsy? And the other question was, when it liquefies, is there any cause of CR chance for seeding of the tumor?
Yeah, a great question. So in terms of common complications that have been described, mostly they're related to skin changes. So actually, the more superficial aspects of the tumor closer to the skin means that the energy waves are converging much more closely, tightly together on the skin towards the tumor. And so you can have some skin changes, kind of like akin to a very mild burn on the skin. There has been described some pain. If you are near biliary structures, if you are near vascular structure, there is a potential and a possibility of either biliary kind of congestion or vascular clotting. So you can have an occlusion of the blood vessels. Now, long term, there's some suggestion that they reopen. So we really don't know, like I said, a lot right now in terms of long-term safety. But so far in the 600 plus 700 cases that they've done, they haven't had any real significant major complication from the procedures. So that has been reported. As far as your question about liquefaction of the tumor or cavitation of the tumor leading to dissemination of the cancer, that hasn't been described, that hasn't been reported. Everything is kind of confined to within that histotripsy zone. So the cavitation is occurring within this cavitation, this histotripsy zone, and so it's really not spilling out anywhere. It is confined to that zone.
Contraindications for having an HAI pump and then going to transplant.
The only real contraindication is the drop in vertical I think I do not know of any centers that are doing post-HAI pumps for cholangiocarcinoma yet. I don't think there have been there's not.
And I'm so sorry, another question just came to my mind. With all the immunotherapy that's being approved for cholangio, for transplant patients, what is the opportunity for them to be on immunotherapies after transplant?
I would let a transplant surgeon.
Sorry.
Ongoing.
Not a transplant surgeon, a transplant hepatologist. So immunotherapy pre-transplant now, all patients with cholangiocarcinoma, majority of them are on immunotherapy combinations. We want to make sure they have a washout period of at least 6 weeks to reduce the risk of rejection post-transplantation. Post-transplant, we try to stay away from immunotherapy. So patients can go on adjuvant systemic chemotherapy, but we really try to avoid immunotherapy. Immunotherapy is probably an option for patients who have recurrence where everything else has failed, knowing that there's a very high risk of rejection, and we're probably going to lose the organ, but then, recurrence and metastatic disease versus losing the organ. So we really work hard in those patients, which we typically don't like, is to go up on the dose of the immune suppression and watch them make
All right, very good. Well, this is going to bring the session to a close and our symposium to an end for the day. Thank you very much to everybody for coming. A couple of announcements. Go ahead.
I was just going to announce that we are going to do, there's time to sit and visit and network with patients and caregivers if you want. And then at 5 p.m., we are going to go, there's a dinner for anyone who's interested at the Wolfgang Puck. You take the elevators down, go out the door into the other elevators and go to the 6th floor. And that's where dinner will be from 5 to 7. If you have any questions, just holler at us. And I just want to thank everyone for coming too. Stacey, do you have anything?
Yes, Stacey.
Just quickly to say thank you, especially to Rosie and Fred for sharing your stories. It's so meaningful. And to all the professionals that are here from MD Anderson and Houston Methodist, thank you so much for being here and thank you for your presentations. It's so meaningful. Thank you to our two organizers here, Dr. Kadali and Dr. Trankow. We're so grateful that you were able to be here. We know many of you came from far away, so thank you again. There's time to visit. Please get connected with Melinda and with the advocacy team. Want to thank them, Melinda and her team, for really coordinating this whole regional symposium. And also, please travel home safely. Please get connected with us online if you haven't already. And thank you.
Yeah. No, this is we've done 6 to 11 shifts, and this is awesome. So no, thank you. Because I mean, we have the team here that does all of it, right? And then my coordinators who are involved in pre and post care, everybody registered and showed up and stayed till the end. So I'm really proud of them. Yeah. Thank you. This is awesome. Yes. Same here. Thank you. Great. Well, I guess hang around, talk with everybody, and then we'll see you at dinner. Yeah.
Yeah, sure.
I gave him the faulty microphone.
Yeah, no. So IPEC and HIPEC are both, which one's liquid, which one's aerosolized chemotherapy. I would say for cholangio, so I do several cholangiocarcinoma, but right now don't do either HIPEC or HIPEC. And the reason why is because we have good data that we mentioned site reduction, removing all the peritoneal cells. Data on HIPEC across many different ovarians and cholangio, it's really mixed that additional chemotherapy actually does anything. What we do know it does is it increases complications. And so if you're, especially for cholangio, which is fairly complicated type, when we do those site reductions, we're taking up those are big surgeries. And so I think sometimes, not every time, that's, we do diagnostic laparoscopy first, the camera and look around, see if it's possible. And then if it is possible, then the goal is to take out everything. The longest one is 22 hours, usually 6 to 8 hours. But I did one for a patient who went to the carcinoma on Tuesday. So it's, even more so than liver-directed therapies, the peritoneal surface stuff is very patient-specific, where it makes sense. And if you go to 10 centers across the country that do this for 10 surgeries, you might get a different answer. It's just not common enough where we have real trial data that says this is the right thing to do. I'm in San Antonio. Yeah, so I trained in New York at the Sloan Kettering and the Anderson Institute centers. For you in Nebraska is very large. Yeah. Like bowel infections and other stuff like that.